Hey, future RN, welcome to this 10-hour NCLEX Masterclass, your ultimate crash course to pass the NCLEX. We've packed the most important topics you need to know, so stay with us till the last minute for the best tips and strategy. Complete this session and you'll be ready to conquer the NCLEX. Let's dive in.
As we know about the fluids and electrolyte, we really need to first know that every body compartment contains fluid that holds the electrolytes. Now, interestingly, the electrolyte makeup of each compartment is very unique, so they differ from one another. Now, for our cells to function optimally, both the fluids and electrolytes need to be in the right places and in the correct amounts. Now, another critical aspect to note is that when an electrolyte leaves the cell, it is replaced by another, so it can maintain balance. Now, as we're speaking about balance, for the body to stay in homeostasis, the number of cations and also the anions need to be equal. Lastly, these compartments are separated by the semi-permeable membrane, which actually can regulate the movement of the substances in and out. Now, today we'll talk about the compartments. Now, as you see here in the photo, you are being pointed to the plasma or the intravascular compartment. And this actually houses the fluid. And this fluid is actually running inside the blood vessel. So it includes the blood plasma, which is very important for maintaining blood volume and pressure, as well as delivering the nutrients, also the oxygen to the tissues throughout the body. Now, we also have the intracellular fluid compartment. Well, it will encompass all the fluid located inside the cells. In fact, the majority of the body's fluid is found within the cells, making the compartment the largest in terms of fluid volume. Now, take a look here. For the intravascular compartment, there's about only 6%. However, if we are talking about the intracellular compartment, that comprises about 70% of the total body fluid. Now, since most of our body fluids are inside the cells, this compartment plays a very important role in cellular functions, such as maintaining electrolyte balance and also supporting the metabolic processes. Now, we'll head into the extracellular compartment, which is contrast to the intracellular compartment. So this basically is referring to the fluids found outside of the cells, and they comprise about 30% of the total body water. Now, for the extracellular compartment, it includes the various types of fluid like the interstitial fluid, which is about 22%, and they are actually found in between the cells. This is what we refer to as the third space. There's also the blood, the lymph, even the fluids within the bones and connective tissue. Now, the extracellular compartment also contains the transcellular fluid, which can be found in spaces like the cerebrospinal fluid, like synovial fluid of the joints, and even the digestive fluids as well. Now, this compartment plays also an important role in transporting the nutrients, the electrolytes, and also the waste products in between the cells and into the bloodstream. Now, this time, we'll talk about the different body fluid transport mechanisms. So I'm sure that you're familiar already with these, but let's just go ahead and kind of tackle. So the first one that we have is the diffusion. So what is this? This is basically the movement of the particles, such as the electrolytes, from an area of higher concentration to an area of lower concentration until the equilibrium is being achieved. Now, we know that the diffusion is a process that occurs naturally. It does not require energy. Now, as an example to the diffusion, the sodium ions basically will move from the bloodstream where they are at in a higher concentration. Now, remember about the value of the sodium ions. They're about 135 to 145 milliequivalents per liter. Now, they're going to kind of like shift sometimes into the cells where the concentration is lower. And this is actually going to help regulate the electrolyte balance across the cell membranes. Now, another transport mechanism that we are going to review is about the osmosis. Now, we are talking about the movement of water, right? And this is going to involve the movement of the water through a semi-permeable membrane from an area with fewer solutes to an area with more solutes. Now, this is intended to balance the concentration of the electrolytes in both sides. Now, to give you as an example, if the fluid surrounding the cells has a high concentration of sodium, what's going to happen is that the water moves from inside the cells from a lower sodium concentration to the extracellular space to equalize the sodium levels. And this can lead to shrinkage of the cell, or it could be dehydration if it's not regulated. Now, the next one that we're going to talk about is the filtration. Now, this is involving the movement of water, also small particles, through the membrane through pressure differences. And this typically can happen from an area of a higher pressure to a lower pressure. Now, as you see here in the picture, this is basically our glomerulus with the Bowman's capsule here. We have the efferent and afferent arteriole. And in the kidneys, the blood pressure in the glomerular capillaries forces the water, also the electrolytes, the waste products, through the filtration membrane into the nephron, and this is going to start the process of the urine formation. Now, part of the body fluid movement is going to be the hydrostatic pressure. It's not really it's not really a transport mechanism. However, this is something that you should recall. As we know that hydrostatic pressure is the exact force that is exerted by the fluid in a confined space, let's say the blood or the body fluid that is found within the capillaries. So what's going to happen here is that it will push the fluid and all the solutes from the blood into the surrounding tissues. Now, take this as an example, wherein in the capillaries, the hydrostatic pressure will push the water and also the electrolytes, like let's say the potassium, out of the blood vessels and into the surrounding interstitial fluid, providing cells with the nutrients. So when the hydrostatic pressure starts to increase, such as in the case of a fluid overload, then it can lead to somewhat we call as accumulation of fluid, and it can result into the accumulation of edema. This is what we refer as third spacing. Please don't forget that about the edema. Now, let's talk about the different regulations of the body water gains and losses. So let's just kind of browse through the following. And so the first one that we have are the osmoreceptors. So these are primarily located in the hypothalamus of the brain. And these are supposed to detect the osmolarity or the concentration of the solutes of the body fluids. And so when there is an increase in the osmolarity, then the osmoreceptors will stimulate the release of the antidiuretic hormone, or we call that as the ADH, and this is going to help conserve the water. So this will now promote water reabsorption in the kidneys and also helping to maintain the fluid balance. Now, the osmoreceptors will also cause us to have that thirst, which is a natural mechanism in order for us to ingest the needed amount of fluid. Now, another regulator is the antidiuretic hormone, and this is also called as the vasopressin, which is basically produced by the hypothalamus, but this is going to be stored into the posterior pituitary gland. Now, what is the role here of our antidiuretic hormone? Well, it basically will act onto the kidneys, particularly the collecting ducts, in order to reabsorb water if in case there is a need for the body to conserve. And it can also help maintain the body water to balance. And also it can help regulate the blood pressure if in case there is a drop in the circulating fluid volume, especially in a case of a dehydration, or let's say if there is way too much concentration in the blood. Now, the third regulator is what we call as the RAS, okay, or the renin-angiotensin-aldosterone system. Now, this is going to be composed of so many peptides and hormones. And the first one that we have is the renin, which is produced by the juxtaglomerular cells of the kidneys. And this is going to respond when there is a drop in the blood pressure or if there is low sodium levels in the body. Now, please take note that it will also trigger this peptide, which is the angiotensinogen, which is basically a precursor, and this is produced primarily by the liver. However, this is going to be converted into angiotensin 1, and then will also be converted into angiotensin 2 by the help of the ACE or the angiotensin converting enzyme, which is primarily found in the lungs when the blood passes through the pulmonary capillaries. Now, another hormone that is also contributing to the RAS is the aldosterone, which is basically a hormone that is secreted by the adrenal cortex. Now, let's talk about the different actions of these peptides and hormones. Now, for the renin, remember that the renin is the primary activator of the RAS. So what's going to happen here is that it will activate the angiotensinogen, and also it will bring into the cascade of the conversion, right? Now, for the angiotensin 2, which is a potent vasoconstrictor, this is going to cause the blood vessels to constrict, and this will bring the blood pressure to go higher as a response to a low circulating fluid volume, or let's say when there is low sodium level in the bloodstream. Now, another is the release of the aldosterone, which is primarily produced by the adrenal cortex. And this is going to help reabsorb the sodium ions and also the water in the renal tubules in response to a low circulating fluid volume. Now, for this person that had previously been low with their fluids, or let's say low in their blood pressure, they're really going to have to feel a difference once this cascade will restore their circulating fluid volume. Now, another peptide that we should recall is the ANP, and this is referred to as the atrial natriuretic peptide. So what is this? This is a peptide that is primarily produced by the atria, and this is going to be released when there is stretching of the atria as a response to an increased blood volume passing into the right or the left side of the upper chambers of the heart. So such is in the case whenever there is ingestion of large volume of fluids. And so the body's response to that is to actually release the ANP, and it has that special function to inhibit the release of the renin and also inhibit the release of aldosterone. So this specifically will have the natriuretic effect. It means that it will cause the excretion of sodium ions in the kidneys. And we know that water can also follow with the excretion of sodium. So after that, there's also going to be diuresis. So for the person who had excessively ingested maybe a gallon of water within a 2-hour period, and if the fluid is no longer needed by the body, and so the kidneys will be excreting those excess fluid. Now, please take note that the ANP also has a diuretic effect, and it also has a vasodilator effect. Now, let's move forward into our discussion about the different forms of the fluid volume deficits. And so there are so many, there are 3 types, and we'll talk about this first one. Now, if you might recall, the goal of treatment, especially in a case of dehydration, is to make sure that we are going to get the fluid levels back to its normal state. We are going to have to replace the electrolytes, maybe sodium, potassium, and also figure out what caused the dehydration so it doesn't happen again. Now, With the first type, which is the isotonic dehydration, this is the most common kind of a dehydration that you are probably uh, are familiar already. And so this is also termed as the hypovolemia. And so this is the loss of either the water or actually both the water and the electrolytes in equal amounts. And so let's say maybe like after a long hike in the sun without enough water, and the blood volume will actually drop, meaning there's going to be less fluid circulating in the system. And it can lead to the fatigue, it can lead to dizziness, also a drop in the blood pressure. So this is something that is quite noticeable by the person who's actually exercising. Now, please take note that there are also some known causes about the isotonic dehydration. One of the causes is the insufficient intake of the fluids and solutes. You'll see here the P, poor intake of fluids and solutes. There's also fluid shifting. We're talking about the shifting of the body fluid into the interstitial space. And another is the excessive losses of isotonic body fluids. Now, the next type of fluid volume deficit that you should know is the hypertonic type of dehydration. So what is this? This is something that can happen when you are actually losing more water than the electrolytes. Let's say when you're sweating a lot, or maybe you're having a high fever and you're not drinking enough water. And so when this happens, your body will try to balance things out by pulling the water from your cells, causing the cells to shrink. And so, have you even noticed when your skin feels so dry, they will feel so tight after you've been dehydrated? That is a sure sign that your cells are losing water. And it is very important for us to rehydrate with water, but sometimes you'll also need the electrolyte replacement drinks like those used by the athletes. Now, let's talk about the different causes of the um, hypertonic dehydration. One of the known causes here is your diabetes insipidus, wherein the body is no longer able to conserve the fluid, so it will just keep excreting fluids through the form of urine, and this is really going to deplete the circulation. We're talking about liters of fluid, let's say 4 to 6 liters uh, in 24-hour period. So the patient here will be definitely prone to hypovolemic shock. Now, another thing that you need to remember, one of the causes here is the renal disease, especially during the early stage, wherein the person will be diuresing way too much. If there's also excessive perspiration or diaphoresis, or when the person has excessive diarrhea, or let's say when a diabetic person, a type 1 diabetic, will go into a diabetic ketoacidosis, they're going to be going into what we call as osmotic diuresis, wherein they're going to be excreting volumes of fluids through the form of urine. So they're going to end up so dehydrated. Now, the other causes here are the hyperventilation and also prolonged fevers. And let's finally talk about the third type of the fluid volume deficit. So the third one here is what we call as the hypotonic dehydration, wherein there's more electrolytes that are lost compared to the water. And so this is less commonly occurring, but it can still happen when your body is actually losing more electrolytes from water. So it can happen if you're sick maybe for a long time, maybe you have a chronic illness, or maybe if you overhydrate with just plain water. Here, the water in your blood moves into your cells, causing the cells to swell up rapidly. Now, it might sound so strange, but when you are drinking way too much water without replenishing the electrolytes, it can actually make you feel weak, and it can cause some lightheadedness because your blood pressure, your blood volume is going to drop. Now, these are the most common causes of the hypotonic dehydration. One of those is a chronic illness, could be malnutrition, and another is kidney disease, and possibly excessive administration of the hypotonic fluid when, let's say, there is inadvertent administration, maybe rapid administration of the hypotonic IV. Now, this time, let's switch into the exact opposite side of the coin here, and we're going to be talking about the fluid volume excess. Now, there are also three types of the fluid volume excess. And the first one that we have here is the isotonic overhydration. And this is also the most common form of volume excess. And this is what we refer as the hypervolemia. And this is something that can occur when there is excessive amount of fluid in the extracellular fluid compartment. So in this case, the fluid actually does not shift between the different compartments in the body, leading to a expansion of the extracellular space. Now, you're seeing here the different causes of the isotonic overhydration. One of those is the kidney disease, could be the inadequately controlled IV therapy. Maybe there's no proper monitoring about the hydration to this patient, or maybe when the person is on a long-term corticosteroid therapy, they can actually cause the body to retain more sodium and more water, which can contribute to fluid volume excess. So I really want you to relate to a person who is actually taking steroids, such as a person who might be admitted for a, let's say, exacerbation of COPD, or let's say pneumonia, and they're going to get some sort of corticosteroid, maybe in a form of prednisone or methylprednisolone. So they're really going to be prone to retaining lots of fluid in their system. Now, take note that the person with this isotonic overhydration is at risk to developing circulatory overload. And keep in mind, if this is happening to an elderly person, keep in mind that they're really going to be prone to developing other problems, let's say heart failure, or it could be pulmonary edema. And this is something that would require immediate attention, because this is something that would really make them so difficult to catch their breath, especially that there is now accumulation of fluid in the pulmonary tree or in the capillaries. And this is caused by the backing of the fluid from the left side of the heart back into the pulmonary circulation. They're going to be gasping for air around this time. They're going to need maybe support, maybe supplementation of oxygen, and they probably would need the administration of diuretics in order to get rid of the excess fluids accumulating inside their lungs. Now, we also have a second type of overhydration, and this is the hypertonic overhydration. And this is not really common, but it still happens. And this is something that can happen whenever there is a rapid infusion of, let's say, hypertonic saline. Let's say maybe the patient is requiring hypertonic saline for hyponatremia, and maybe there was a mistake, or maybe there was no close observation about the increments of the patient's sodium level. And so this can really cause a rapid increase in their sodium in the system. Now, this can also lead to the hypertonic overhydration. And so this is really going to cause pooling of water out of the cells. And this is going to cause the fluid to congregate into the bloodstream, right? And this can sometimes will lead to some difficulty of breathing in some individuals, especially if they're elderly. Now, take note here that the common causes about the hypertonic overhydration are the following. It could be the rapid infusion of the hypertonic saline, which I already said, excessive ingestion of the sodium, maybe salt tablets for hyponatremia, or it could be the ingestion of sodium bicarbonate, which is a very common form of alkalinizing agent, especially for those people suffering from heartburn or maybe gastritis. So they're really going to prone to developing this one. Now, This is something that you should be aware of. This is what we call as the osmotic demyelination syndrome. This is a neurological complication if the patient receives rapid correction of their sodium. And so there are some parameters that should be followed, especially when you are the nurse administering the hypertonic saline solution to this patient that has, let's say, a severe or moderate low sodium level. We definitely need to correct the low sodium gradually, because if we are going to rapidly correct that, this can lead to permanent or, let's say, irreversible damage in the myelin, especially the neurons, and it can lead to the quadriplegia. The patient can also develop dysphagia, also confusion, and some sort of a neurological manifestations. Now let's move forward to the next type of the fluid volume excess, and this is we refer as the hypotonic overhydration, and this is we call as the water intoxication that can happen when there is excessive fluid moving into the intracellular space, which can result in the expansion of all fluid compartments inside the body. And so, again, this can also complicate into electrolyte imbalances due to the massive dilution. Now, the following are the causes of the water intoxication. Here are the syndrome of inappropriate antidiuretic hormone, wherein the body is trying hard to conserve the fluid that's supposed to be excreted by the kidneys. So it will conserve everything now that it's going to cause a lot of fluids to be retained inside the system, which can dilute the solutes, which is not really a good thing, okay? Because this can cause some imbalances, especially sodium. Now, another is heart failure, which is something that can really cause some dilution of our electrolytes as well, because the heart is not able to pump the blood effectively to the kidneys, right? Now, we also have the inadequately controlling IV therapy. And so this is also similar to the isotonic overhydration, wherein there is probably administration of hypertonic fluids, hypotonic rather. And so we make sure that we are monitoring the administration in order to prevent the fluid overload. Now, another thing that can happen is probably the irrigation of the wounds, especially if the irrigant is a hypotonic solution. So you got to be careful that this is our patient is monitored closely, because this can somehow cross into the system and it can lead to excess body fluid. Let's say the solvent, or let's say there's going to be an excess of body water. Now, moving forward here, we have the different assessment findings. So we are going to have to compare both the fluid volume deficit and the fluid volume excess in the different body systems. So let's start first with the cardiovascular system. Now, when there is a dehydration, what you're going to see in the patient or observe is going to be that thready pulse when you're palpating. It's somewhat kind of weak. And when you're counting, it's actually increased. But when you are palpating, the amplitude of the pulse is basically diminished. Now, when you are checking the blood pressure, it will be low, and they are at risk to developing the orthostatic blood pressure. Our patient will be prone to falling. And when you're observing into the neck veins of our patient, it will appear flat. Same thing with the hand veins. You probably would not see those normally engorging veins, superficial veins. Now, if we are talking about the central venous pressure, this is also going to be decreased, such as that it will be less than 8 millimeter mercury. And please take note, we are using that unit. Now let's move on into the dysrhythmias. Why there is a dysrhythmias, especially in a patient that has the fluid volume deficit? Well, of course, we know that with this patient, they're actually not perfusing well the different body organs, and including the heart as well. And so the heart itself is deprived of the volume in order to function, in order to do its job in pumping or supplying the the body organs with the blood. And so in itself, it can lead to the irregular rhythm, and also it can possibly lead to some life-threatening dysrhythmias if not attended early. Now, let's go into the fluid volume excess manifestations, and we are still under the cardiovascular system. Now, the pulse rate is also increased. However, this time, the characteristic pulse is going to be much more like bounding, uh, close to 3 or maybe 4. And when you're looking into the patient's neck, the external jugular vein will be distended. So you will see that JVD, and the blood pressure will be elevated. And when you are looking into the central venous pressure, this will be greater than 12 cm, or 12 greater than 12 millimeter mercury. Now, the same thing can happen, especially if there is fluid volume excess. The heart is going to work harder, and so this can also lead to the dysrhythmias. Now, talking about the respiratory manifestations, our patient will have increased respirations. There's going to be some difficulty of breathing, or we call this dyspnea. And same thing with the fluid volume excess, their respiratory rate will be faster as well. However, theirs will be shallow. There's going to be crackles as well, difficulty of breathing. And as far as the muscle strength, the patient here will basically have some changes as far as their level of mentation. They will become lethargic, drowsy. Maybe you will notice that this patient probably came in drowsy. However, by the next hour or so, they will become obtunded or somnolent. And this is really going to tell you that their body is really not getting enough perfusion. Now, our patient here will also manifest some muscle weakness. And of course, this is the lack of the perfusion to the muscle tissues. Now, take note that there also going to be presence of fever in this people with the dehydration. Of course, we know that the fluid inside our muscles will actually help regulate the body temperature. So if there is the lack of fluid, then there is no cooling mechanism. Now, let's talk about the altered level of consciousness, especially that can happen in the fluid volume excess. The person here will also suffer from skeletal muscle weakness. They probably would complain about the headache, visual disturbances, and some paresthesias, wherein there's going to be alternating pins, pricks, sensation of pins and needles, maybe absence of sensation. So it kind of be kind of an alternating type of like weird sensations. Now let's talk about the renal system here. And so we know for sure that when a person is dehydrated, there is going to be a decrease in the amount of the volume that will be put out by the renal system. We know that, right? The color of the urine will be somewhat concentrated from, let's say, a normal yellowish or straw colored. It will turn into orangey dark kind of color, especially if the person is not taking a lot of fluids or not adequately taking water. And so this is the job of the antidiuretic hormone. It's actually conserving the water. And so that's why you will see the concentrated urine in this patient. Now, for the patient that has the fluid volume excess, please take note that it actually, the urine output can either be increased or decreased. So pay attention. Now, for a person that has a normal glomerular filtration rate, basically the kidney function here is excellent. And so if there is an instance wherein the person probably is ingesting way too much fluid in a shorter amount of time, the body will try to work in getting rid of the excess fluid by allowing the kidneys to put out more urine. Okay. And so you will expect polyuria in this person with a normally functioning kidney. However, if the person has some diseased kidney, or let's say an impairment of their glomerular filtration rate, then you will notice that the patient will be only emptying. They will only produce lesser amount of urine. And it's because the nephrons are no longer able to do their job effectively. Now, talking about the integumentary system, when the patient has dehydration, their skin becomes dry. When you are testing the turgor, it's no longer as elastic. There's going to be tenting. When you're looking into their oral cavity, the mouth will look so dry. You probably will see the furrowed tongue, and there's not a whole lot of moisture that you can observe inside their mouth, especially under the tongue. Now, talking about the fluid volume excess here, what you're going to see here is the pale, cool skin, and it's probably because of the excess fluid. Um, it could be in the third space, or it could just be an increase in the fluid volume in the extracellular, or it could be in the intracellular compartment as well. Now, the person may also manifest some dependent edema. You can see them in the ankles or maybe their legs or their feet. Whenever they're probably sitting for a while, you'll see the edema collecting into the lower extremities. Now, let's talk about the gastrointestinal system. Here we have the different manifestations, especially for the um, person that has the dehydration. They're gonna manifest the hypoactive bowel sounds. It simply means that their motility, or let's say the peristalsis, is slower this time. And this is expected for this person to have constipation. They're also going to be some weight loss, of course, with poor ingestion, right? And they will have that marked thirst sensation. Now, transitioning into the fluid volume excess, the patient here will have the exact opposite. There are going to be some hyperactive bowel sounds. As far as the motility, there's going to be increased bowel sounds. The peristaltic movements will be much busier this time. And the patient probably would develop some diarrhea because of the hypermotility. And because of the massive ingestion of fluids, they're going to be gaining weight. And this could be weight gain associated with anasarca, or let's say edema, or just mainly the expansion of the intracellular compartment as well. Now, the patient will also have some liver enlargement around this time, and possibly ascites if there is an involvement or maybe an issue of liver cirrhosis. So this is really going to affect the other nearby organs of the body. Now, this time we're going to talk about the different laboratory findings, and I'm sure that you're already familiar with these. So let's just compare the different values between the fluid volume deficit and excess. And so for the osmolality, this is basically the study in our blood to determine the concentration, right? And so normally it's supposed to be at 280 to 300 milliosmoles per kilogram. So for a person that is dehydrated, it is expected that the value is greater than 300. However, for a patient that has a fluid volume excess, it simply means that their blood is super diluted. There's way too much water compared to the solutes. And so the value will be lower than 280 milliosmoles per kilogram. Now, the same thing with a hematocrit, and you will see here the values for the male and the female adults. And if there is dehydration, the amount of the cellular compartments with regards to the plasma will be much higher. So it simply means that there is hemo concentration. So you will see that the hematocrit value will be higher this time. However, if there is excessive fluid ingestion, then the concentration of the blood cells will be kind of like diluted. And so you will see the numbers will be much lesser this time. And we're still talking about the hematocrit. Now, moving into the blood urea nitrogen here, normally it's about 7 to 25 milligrams per deciliter. And if there is dehydration, the value of the BUN will go up. And so this is going to give us an idea that the patient is not taking in adequate amounts of fluids. Now, if the person is having an excess intake of fluid, then their blood urea nitrogen will be somewhat diluted, right? So we know that the blood urea nitrogen is a solute. And so if the patient is taking way too much water, then the ratio here, or let's say the concentration of the BUN will be much lesser this time. Now, talking about the sodium level, normally it's supposed to be at 135 to 145 milliequivalents per liter. For a person that has dehydration, their value will be greater than 145, and it will be lesser than 100. It will be lesser than 135 for the person with the fluid volume excess. So, meaning their solutes are also diluted. Now, let's talk about the urine-specific gravity. This is going to give us an idea how concentrated or how diluted the urine is. So basically, this is quite synonymous, or it has the same resemblance to the blood osmolality, okay? But here, with the urine-specific gravity, this is going to pertain more about the concentration or the dilution of the urine. Now, if the number is above 1.025, this simply means that there is there is increased conservation of body fluid. So, meaning when you are taking care of a patient that has dehydration, take note that the body will actually try to conserve with the antidiuretic hormone. It will try to reabsorb as much as they can all the body fluids back into the system, and so there's going to be much slower, or there will be much lesser volume of urine that will be formed around this time. So it simply means that the urine is super concentrated. Now, the exact opposite can happen if there is a reduction of the specific gravity, let's say less than 1.010. So this is something that is evident in a patient that has the diabetes insipidus, wherein the body is just wasting way too much body fluids. And so the color of the urine this time is so clear, and it's being produced in massive amounts. Now, guys, let's talk about the different interventions. So for the patient that has the fluid volume deficits, we really need to take steps to prevent more additional fluid loss. And also we need to restore the fluid volume. And we're going to have to start replenishing the body fluid by maybe through the oral route, if the patient is able to do that. However, if the patient is not able to do that, then the IV route will be recommended. Now, we really need to make sure that we are tracking the intake and output of our patient this time. And in general practice here, please pay attention. For a patient that has an isotonic dehydration, the recommendation for the treatment here, as far as the IV fluids, it will require isotonic solutions, such as the 0.9% sodium chloride, or it could be the lactated ringer solution. Now, if the dehydration is hypertonic in nature, it will require hypotonic solution. So this could be half normal saline solution. This is going to replenish the lost body water. Now, please take note here, guys, that when a person will have a hypotonic dehydration, this person will definitely require hypertonic solutions in order to allow redistribution of fluids into the vascular compartment as well, and to maintain the circulating fluid volume. Now, another nursing intervention that you should be doing is to keep an eye onto the intake and output. We have to keep an eye on that one, report them to the medical provider if there are any discrepancies. And we also need to administer medications as prescribed. So it's such a case wherein maybe the patient had fluid volume deficit because of diarrhea. They could probably be having large volumes of emesis. We're going to have to administer maybe antiemetics or maybe antibiotics or antimicrobials to treat the infection. Or if the patient is losing way too much fluid because of, let's say, they're running fever for several days already, so they're really prone to losing a lot of body fluids through evaporation. So we can administer the antipyretic as prescribed. Now, moving into the fluid volume excess, or let's go back to the fluid volume deficit. So part of our task here is to maintain or to monitor the levels of our electrolytes and also the fluid. And as needed, if there is a a need for us to replace because maybe the values are critical, or let's say the patient's value is just not within that acceptable range. So we need to get the attention of a medical provider to make sure that we are replenishing those required electrolytes. Now, for the fluid volume excess, we also need to prevent additional fluid accumulation. And so, if the patient already is having some fluid volume excess, maybe they're hypertensive rather, tachypneic, they're probably developing that pulmonary edema. Definitely, we need to stop the IV infusion, and we are going to expect the administration of the loop diuretic, especially furosemide or Lasix, and this is going to uh, be a rapid acting medication in order to get rid of those excessive fluid that is lodged in the pulmonary tree. Now, take note that our patient will probably require fluid and sodium intake restriction in order to prevent accumulation or more accumulation of fluid into the body tissues. We are also going to have to do strict intake and output monitoring. We're going to have to weigh our patient daily, especially after waking up in the morning before breakfast. And we definitely need to check their electrolyte and body fluids as well. We're going to weigh them, and as needed, we're going to replace as ordered. Now, this time we're going to talk about the first electrolyte imbalance, which is the hypokalemia. We know that the normal range for the potassium is 3.5 to 5.0 milliequivalents per liter. And you probably will see this in some books that the upper limit is about 5.3, but for the NCLEX, we usually would refer back to the 3.5 to 5. Okay. Now, the value in hypokalemia is less than 3.5. And so we will definitely need to revisit the most common causes of the hypokalemia. So as you see here, I have created for you that acronym DITCH-K. So these are the common culprits of hypokalemia. The first one is the use of the diuretics, especially thiazide and loop diuretics. It could be other drugs, let's say steroids. The patient will end up with low potassium. And the same thing when they're using a lot of albuterol for their asthma, to treat their bronchospasm. There's going to be shifting of the potassium from the bloodstream into the cellular compartment. So this is going to cause some rapid imbalances as well. Now, another is the I, which is the inadequate potassium intake, or probably the person is fasting, or maybe when the person is being treated in the hospital for small bowel obstruction, and they are going to require insertion of the nasogastric tube, and they will require decompression of their stomach. And so if they're connected to the suction, they're going to lose a lot of potassium ions. And this is really going to endanger them to developing cardiac dysrhythmias as well. Now, another is the transfer, or let's say shifting of the potassium ions from the intravascular compartment into the intracellular compartment. And this is going to commonly happen if our patient is receiving lots of insulin, if they are hyperglycemic, such as in the case of DKA, or let's say the hyperosmolar hyperglycemic non-ketotic coma, and we definitely need to control their blood sugar. But one bad thing about that is that with the administration of insulin, this patient is going to develop hypokalemia, because this is the expected effect of the insulin. Now, another cause here is the alkalosis, and why alkalosis is going to lead to hypokalemia. And the reason for that is when there is an alkalosis wherein the pH of the blood goes up, which simply means that the blood is becoming basic, right? So this will cause the hydrogen ions to leave the cells, and they're going to move into the blood to help neutralize the alkalinity. Now, take note that in alkalosis, In order to maintain the electrical neutrality, the potassium ions will move into the cells as the hydrogen ions start to leave the cells. And so the shifting of these two substances will actually reduce the potassium level in the blood, and this can lead to the hypokalemia. Now, another problem is the Cushing syndrome, which we're in, there is a increase in the production of the aldosterone. And so with the excess aldosterone, the body will be excreting lots of the potassium ions through the kidneys. Now, we have the H, which stands for heavy electrolyte loss, and this could be attributed to the vomiting, diarrhea, could be wound drainage, could be nasogastric suction. We also have kidney disease, and this is what we refer as the hypokalemic nephropathy. And so this can cause prolonged or severe hypokalemia. And let's move into the manifestations. This is very important for you to refamiliarize the signs and symptoms. And so I have created for you the acronym tired wall, which represents T, which represents thready, weak pulse. And so when you are palpating the patient's radial pulse or maybe other distal or peripheral pulses, this is some kind of very difficult to palpate. And this is happening because of the decreased cardiac output resulting from the reduced potassium levels, which can impair the cardiac muscle function. Now, for the eye, we have the ineffective respirations, and this is caused by the weakening of the skeletal muscles, including those involved in the respiratory system. And so what you're seeing in this patient will be shallow and ineffective respirations, which can lead to the hypoventilation, and it can also lead to the decreased oxygenation of the bloodstream. Now let's have the R, which is reduced gastrointestinal motility. And so here, our patient will have constipation. They're going to be bloating, abdominal discomfort because of the very slow peristaltic movement. And imagine if our patient is still doing their normal food intake, and if their peristaltic movement is hampered, this is really going to cause some huge discomfort, especially if the food contents are trapped or they're going to stay a lot longer in the colon, or let's say the small bowel. Now, let's talk about the letter E, which is the EKG or ECG changes. So what you're going to see here are the following. There's going to be flattening of the T wave, which is basically right here. You will not see that spike anymore. There's going to be the appearance of the U wave, and the ST segment will look depressed. And we also have it here. Okay, so this is the ST depression. Now, talking about the deep tendon hyporeflexia. So our patient will have a much lesser response when we are checking their patellar reflex, and this is because of the impairment in the nerve conduction and the muscle function, which can manifest as decreased or even diminished reflexes during the clinical exam. Now, talking about the W, which is the muscle weakness. So our patient really will complain about this. They really will not be able to tolerate a lot of physical activity this time when they are hypokalemic. We also have the A, which stands for altered level of consciousness, and our patient can become lethargic. They could be confused. At some point, they will become comatose if the hypokalemia is so severe. Now, we also have the two L's. So the first one is low blood pressure. They will become orthostatic. And the next L is the loss of the discrimination. So it simply means that their tactile ability or their tactile discrimination ability is going to be much less sensitive. Now, we are going to talk about the different interventions for the hypokalemia. And here we are going to keep an eye into the potassium levels regularly in order to check if our treatment is achieving or if we are able to achieve the goals. And we are going to place the patient in continuous cardiac monitoring, especially if the potassium level is moderately low or let's severely low. We'll be able to capture those deadly, um, what do you call this, dysrhythmias. Now, part of the care is to administer the potassium replacement. And I need to draw your attention here because when you are giving the potassium replacement, especially if it's in a form of a tablet or let's say liquid, you got to be careful because this is a gastric irritant. This can lead to esophagitis. And so make sure that this is going to be given after food intake or let's say a meal, and make sure that you're instructing your patient to sit upright for at least 30 minutes to prevent backflow of the medication into the esophagus. Now, when you are administering the IV form of the potassium, the rate will be at this number, no more than 10 milliequivalents per hour. Because if it's way faster than the 10 milliequivalents, let's say 30 or 40, this is going to cause a rapid hyperkalemia, and this can lead to dysrhythmia as well. Now, please take note when you are going to be working in the nursing or the med-surg unit, the allowed administration rate will be 10 milliequivalents per hour. We can give this medication through the peripheral IV. You probably would be placing our patient in a continuous cardiac monitoring device. However, if the patient has, let's say, a much more severe form of hypokalemia requiring one-to-one care, they're probably going to send this patient to the ICU. And so the medication can be administered up to 20 milliequivalents per hour, provided that the patient is connected to the cardiac monitor continuously, and also that the patient's IV axis is going to be the central line, because this is really so irritating into the peripheral veins. Now, another thing that we need to keep in mind is the assessment of the kidney function. What I'm talking about here is that you need to evaluate the urinary output of your patient before initiating the potassium replacement, because if the kidneys are not receiving enough hydration, the potassium ions that you are giving will accumulate really fast around this time, and this can lead to inadvertent hyperkalemia. So we really don't want that. We need to address the dehydration first with replenishing IV fluids, and then we will do the potassium replacement. Now, we also need to place our patient into follow precautions because of the muscle weakness, some confusion. We're also going to have to plan on discontinuing the potassium wasting diuretics, let's say the thiazide or let's say the loop diuretic. So our medical provider needs to review the medication. Maybe this patient is going to benefit the use of the potassium sparing diuretics such as the spironolactone or the aldactone. Now let's move into the advising our patient to increase their intake of potassium, especially the diet. So we need to identify those food sources that are rich in potassium, so our patient will be able that they are guided on what food items to purchase. Okay. Today's session, I'll be talking about the electrolyte and acid-base imbalances. So as a continuation, we will proceed with the topic on hyperkalemia, which is basically that elevation of the potassium level in the blood. And this is referred to as an elevation of greater than 5.0 milliequivalents per liter. Now, let's talk first about the different causes of the hyperkalemia. Well, you are going to see here the acronym PAD-CAM. This is represented by the following letters. The letter P stands for the pseudo-hyperkalemia, which is a condition that is caused by the falsely high potassium level, and this is brought about by the poor blood collection, especially if there is hemolysis or let's say cell breakdown during the sample handling. And so if you're going to encounter this, it is very important that you're going to have to repeat the collection of the blood if there are no signs of hyperkalemia in order to confirm the result. Now, the next letter is letter A. This stands for the acidosis, particularly metabolic acidosis. And because this is going to lead to a shift of the potassium from the cells into the blood. So remember that in the acidotic states, the hydrogen ions enter the cells to buffer the acid while the potassium ions exit. So this is going to result in the increased serum potassium levels. Now, we're going to talk about the next letter, which is letter D, and this pertains to the drugs. And there are medications that can actually lead to that. So you are seeing here the heparin. We also have the beta blockers, the ACE inhibitors, and the angiotensin receptor blockers, and the NSAIDs. So talking about the heparin, what is the result or what is the outcome for treating this patient with heparin? Well, the heparin can actually induce hyperkalemia by decreasing the aldosterone secretion. And the same thing with the beta blockers. It can inhibit the cellular uptake of potassium, while the ACE inhibitors and the ARBs are going to cause the potassium to be retained by blocking the aldosterone effects, which is essential for the potassium excretion. Now, next are the NSAIDs, which can actually cause acute kidney injury, and it can also lead to a reduction in the renal blood flow, leading to a decreased potassium excretion. So as we know, this can cause elevation of the potassium in the bloodstream. Now, the next set of letters, we have letter C, chronic renal impairment. We know that in a chronic kidney disease, it will impair the kidney's ability to excrete the potassium. And we have letter A, adrenal insufficiency, which basically pertains to the Addison's disease, which can result to insufficient production of the aldosterone. And with that, this can also lead to a decreased potassium excretion in the kidneys, which can also contribute to the hyperkalemia. And this is going to be followed by the M, which is the muscle damage. As we are going to remember about the muscle injury, such as in a form of a rhabdomyolysis, or let's say in the case of severe burns, this can release large amounts of the potassium ions into the bloodstream as the muscle cells break down. Now, let's now talk about the different clinical findings that you were going to expect in a patient with hyperkalemia. So you're going to see the acronym here, cardiac, which is represented by the following letters: C for cramps, pertaining to muscle cramps. As we know that in hyperkalemia, these cramps can be due to the increased excitability of the muscle cells caused by the elevation of the potassium. And the patient here will particularly experience the cramps in their limbs and also their back. Now, followed by the letter A, which is the ascending paralysis. This is a late sign in hyperkalemia. So this is referring to the progressive weakness that will start in the lower extremities, and this is going to ascend toward the trunk and upper body. And this can also affect the respiratory muscles, which can lead to the letter R, respiratory failure, which is also a late sign in hyperkalemia. And this is occurring because the muscles involved in the control of respiration are becoming weak, and they are not going to be able to effectively facilitate the breathing. Now, we also have the letter D, which is the decrease in the blood pressure. Your patient becomes hypotensive because hyperkalemia can lead to the vasodilation, and it can also reduce the cardiac contractility, which can do the hypotension and will lead to the inadequate perfusion of the vital organs. This is going to be followed by letter I, which is irregular heart rate and also dysrhythmias. And our patient here will manifest those irregular heart rhythms due to the impact of the high sodium, or not sodium, but potassium levels on the cardiac and electrical transmission. Now, for the patients with the hyperkalemia, they can experience bradycardia. Their heart seems to be slower, or they might encounter another set of arrhythmias, which can be detected on the EKG. Now, the next letter is A, which is altered level of consciousness. There's also confusion, and this is to the effects of the hyperkalemia on the nervous system and also cerebral perfusion. Now, the hyperkalemia can also lead to cognitive changes, disorientation. The person will become less responsive, and this will really require immediate medical attention. Now, this is going to be followed by the last letter, which is C. This pertains to the cardiac changes, EKG changes. And so you're going to see this different, the different waveforms with the different levels of the potassium. Now, you're going to see the tall or elevated peak T waves or narrow T waves when the potassium level reaches 7 milliequivalents per liter. And when the patient progresses to 8 milliequivalents per liter, there's going to be absence of the P waves, and there's going to be disconnection of the P waves and also the QRS complexes. Now, progressing to a level of 10, or let's say 9 to 10, this is going to cause broad irregular QRS complexes, as you're seeing here. Look at that. And moving into a level of 11 milliequivalents per liter, you will see a much more biphasic waveforms. So there's now going to be fusion of the QRS, ST, and T waves. And finally, with a level of 12 milliequivalents per liter, this can cause the ventricular fibrillation, or the patient will have cessation of cardiac activity when they become pulseless. Now, I really want you to pay attention regarding the different levels of the potassium, because our waveforms are quite different from each other. Now, we need to address this patient with the hyperkalemia. Of course, we're going to be worried about the cardiac activity. So first and foremost, we're going to need to do cardiac monitoring continuously in order to capture the life-threatening dysrhythmias, and like I've said, with the different waveforms. And if there is continuation of, or if the patient is taking the potassium supplements, we need to stop those. Either IV or oral supplements need to be discontinued right away, and their diet will have a restriction of potassium intake. And what we're going to need to do here is to potentially administer furosemide, which is a loop diuretic, to allow excretion of the potassium ions via kidneys, and also sodium polystyrene, which is an exchange resin. And this is something that you can give orally or through enema, which will allow the exchange of sodium and potassium in the GI tract. And so make sure that you are monitoring the potassium levels after you give these medications. Now, in order to lessen the excitability of the cardiac muscle in the hyperkalemic state, we're going to have to administer the calcium gluconate IV and also D50 IV, and this is going to be coupled with the regular insulin to be administered intravenously. And this is a temporary management to shift the excess potassium from the bloodstream into the cells. But take note that this is only temporary. This can allow the potassium to go back from the cells to the bloodstream after a period of 5 to 6 hours. So definitely we're going to need to do something else after we administer the D50 and the regular insulin. Now, another is to make sure that we are monitoring the patient's serum potassium levels when we are treating them, in order to evaluate how effective the pharmacologic treatments are. Now, again, since we are dealing with hyperkalemia, our patient is going to be advised to avoid potassium, or actually a salt substitute. And these are very high in potassium content. Now, for those people that will be requiring blood transfusion, it is recommended that they're going to be given fresh blood, as we know that for those blood products that are stored in the blood bank for a longer time, there is a higher chance that they are high in potassium content. So this needs to be avoided. Now, let's proceed to the next electrolyte imbalance, which is the hyponatremia. Now, recall the value for the sodium in the blood that is supposed to be at 135 to 145 milliequivalents per liter. But for this order, the sodium level is less than 135 milliequivalents per liter, and this is going to be caused by the following. Okay, now this is the acronym that you should be recalling: DISPLAY. So this represents the following. We have letter D, stands for the diuretic. So if your patient is taking diuretics, especially thiazides, or let's say loop diuretics such as furosemide. This can lead to massive sodium excretion through the urine, which can deplete the sodium levels, leading to that hyponatremia. And we also have letter I, which is inadequate sodium intake. For example, if the patient is fasting or there is just low sodium intake, then the person will not be able to really meet the body's needs, contributing to this electrolyte imbalance. We have letter S, which is sweating excessively or diaphoresis, and this can result to massive loss of sodium through the sweat. And we also have letter P, which is for poor kidney function. Whenever there is kidney disease, it impairs its ability to regulate sodium, or let's say concentrate the urine or reabsorb the sodium, causing a massive loss of sodium in the body. And we also have letter L, which stands for loss through vomiting, diarrhea, or wound drainage. And if we are talking about the gastrointestinal fluid loss through vomiting, diarrhea, or let's say wound drainage, this can really cause a depletion of that sodium as well. Now, another problem is with the aldosterone deficiency. And we know that the aldosterone is that hormone that promotes sodium retention in the kidneys. But when there is deficiency of the aldosterone, such as in Addison's disease, this can cause excess sodium loss in the urine. And we are depleted with, there is much lesser sodium content in the bloodstream. Now, we're going to talk about letter C, which is about congestive heart failure, because in CHF, the body retains water to compensate for poor heart function. And with this water retention, it dilutes the sodium concentration, causing hyponatremia. And then we also have letter E, the last. This stands for excessive antidiuretic hormone, such as in the case of SIADH, wherein it will cause the excessive reabsorption of water, which will cause dilution of the sodium in the bloodstream. Now, as we go further, we're going to talk about the different manifestations of hyponatremia, and I want you to recall the words cold spars. So this is represented by the following letters. Letter C is for the confusion, because with the hyponatremia, it actually will alter the balance of the sodium in the nervous system, especially the brain. We know that sodium is important in the transmission of the impulses, right? Now, followed by the letter O, which is basically orthostatic hypotension. When the patient stands, there's going to be a sudden drop in their blood pressure. We got letter L, lethargy, and this can lead to a alteration in the function of, the sodium that is low can alter the neurological function. And as we know that sodium basically is intended to transmit those impulses. And so with a deficiency in the sodium, this can lead to decreased energy levels and general also, fatigue. Now, for the next letter, we have letter D, which is decreased urine-specific gravity. So it is going to indicate diluted urine, often found in hyponatremia. We also have the letter S, which stands for skeletal muscle weakness. We have letter P, personality changes, wherein the person's mood or behavior will vary because of the hyponatremia. There's also A, abdominal cramps. There's going to be discomfort. And we also have letter R, rapid thready pulse. And we also have S for the seizures. Now, this can happen because of the rapid changes in the sodium levels, which can cause the cerebral edema. Or let's say this can allow the fluid to shift into the cells of the brain, increasing the intracranial pressure, which can lead to the convulsions. Now, we definitely need to intervene this imbalance by administering them the intravenous sodium chloride, which is going to basically our primary treatment for this hyponatremic patient. Now, in such a case wherein there is hypervolemic hyponatremia, our treatment here will be the administration of the osmotic diuretics, since we are going to deal with the excess water, and we definitely need to retain the sodium this time. Now, we are going to manage the hyponatremia by the different treatment strategies, which will vary greatly, whether the hyponatremia is somewhat chronic or it could be acute. But in severe cases, this will necessitate hospitalization, and this could really require one-to-one care for much more close monitoring, especially if our patient's sodium level is so severe, because this can really lead to some neurological disturbances. Now, another thing that we need to administer here is the antidiuretic hormone antagonist, or known as the tolvaptan. And this is going to be primarily used to allow the sodium level to go up. And this is a medication that is primarily used for the treatment of hyponatremia associated with a congestive heart failure, or let's say the syndrome of inappropriate antidiuretic hormone. And so the action of the tolvaptan is basically to block the vasopressin receptors in the kidneys, which will promote water excretion while retaining the sodium. Now, another thing that we need to administer to the patient is to increase their oral intake of sodium. And we're going to advise the patient to increase their sodium ingestion as directed or as ordered. And another thing that we need to incorporate in the care is to institute seizure precaution, especially if our patient has severe form of hyponatremia. They are at risk for falls. And for those patients that are using lithium for mood disorders, it is very important that we are monitoring the sodium level, because this can lead to, the hyponatremia can lead to lithium toxicity. Now, let's proceed to the next imbalance here, which is the hypernatremia. And this is referring to any sodium level greater than 145 milliequivalents per liter. Now, what causes the hypernatremia? Well, you have here the acronym CHILD, which is represented by the following letters. C for corticosteroids, which can lead to hypernatremia, and this can promote sodium retention in the kidneys. And the corticosteroids can also stimulate the reabsorption of the sodium while it can excrete potassium. Now, we also have the next letter, which is letter H, representing hyperaldosteronism, which is characterized by the excess production of aldosterone. And in this condition, the person here will have enhanced sodium reabsorption in the kidneys, causing the sodium levels to excessively rise in the bloodstream. Now, this is what we refer to as the Conn's syndrome. Now, the following letters, we have letter I, representing increased sodium intake. So if a person has excessively ingested sodium supplements, or let's say maybe in an inadvertent administration of hypertonic saline solution, this can directly elevate their sodium levels. Now, we have letter L for lower water intake. And so this can lead to what do you call this? Concentration of our sodium level in the bloodstream. And this can be caused by fasting or just inadequate intake of water. Now, this child is followed by, of course, letter D, which stands for the dehydration. And this is caused by the following. It could be increasing metabolic rate, could be fever, or if the patient is hyperventilating, or it could be excessive diaphoresis or sweating, or when the patient has watery diarrhea, or if the person has diabetes, which is a condition wherein there is an insufficient production of antidiuretic hormone, which is supposed to, a hormone that is supposed to concentrate the urine. But now we are actually having massive losses of fluids, which will cause the sodium level to rise excessively. Now, what are we going to see in patients with hypernatremia? So I want you to recall this acronym, DREAMS HILTS, which is represented by the following letters. Letter D, which stands for decreased urine output, which reflects the kidney's ability to attempt conservation of water due to elevation of the sodium levels. We also have letter R, which stands for restlessness or agitation. And this is indicating that the central nervous system is being affected by the hypernatremia, because in itself, it can disrupt normal brain function. We also have letter E, which is extreme thirst. As we know, that the hypernatremia can trigger intense thirst as the body seeks to restore fluid balance. We have letter A, altered level of consciousness, and this can include lethargy or stupor, particularly in cases of hypervolemic type of hypernatremia. Now, followed by letter M, which is the muscle twitching, which is an early sign. And during the later stage, this can be followed by skeletal muscle weakness. Now, followed by our letter S, which is all about seizures. And this is going to happen in severe cases of hypernatremia. And this happens because in hypernatremia, this can increase the neuronal excitability. And we also have the following letters. H for high specific gravity of the urine. It indicates that our urine is concentrated due to the kidneys' efforts to conserve water. We also have letter I, increased serum sodium levels, of course, greater than 145 milliequivalents per liter. We have letter L, which is tachycardia, which is a common, letter L, lethargy rather, or stupor, which is basically suggesting that there is a decrease in the brain perfusion due to the fluid overload. We also have letter T for tachycardia, which is a common complication or a compensation response to the fluid volume changes, especially in hypervolemic hypernatremia. And we have letter S, which is skeletal muscle weakness, or it could lead to absent deep, or let's say hypoactive deep tendon reflexes. So what are we going to do here to treat this patient with hypernatremia? Well, if there is way too much sodium, then we can treat that with the administration of the diuretic. And of course, we are going to expect that the medical provider will restrict the patient's intake of the sodium. And same thing with, we're going to have to administer a isotonic solution, which is D5 water. And this is going to limit this is going to dilute the sodium concentration in the blood. We're going to have to institute safety precaution in our patient as they are prone to developing seizures with altered level of consciousness. They are at fall risk. And our patient definitely needs to have close observation during this time. Now, let's talk about the next imbalance here, which is all about hypocalcemia. Now, this is a condition wherein the potassium or the calcium level drops below 8.5 milligrams per DL. So please take note that in some books, the lower limit of the normal calcium level is 9.0. But in general population or in general medicine, we actually have the lower limit, which is 8.5. So anything below that is considered as hypocalcemia. Now, this is going to be caused by several factors, and this is represented by the acronym HIDES calcium. H stands for hyperproteinemia, because with elevated protein levels in the blood, it can bind to the calcium, and this can reduce the amount of free ionized calcium, which is the active form of calcium in the body. Now, this is followed by letter I, which is inadequate calcium intake. So if the person is not consuming enough calcium-rich foods, this can lead to insufficient calcium in the bloodstream, causing this imbalance. We also have letter D, diarrhea, of course. With that, this can lead to excessive loss of calcium through the feces. And we have letter E, end-stage kidney disease, wherein this can cause a decreased conversion of vitamin D into its active form. And when this happens, the body will not be able to absorb calcium in the gut. Now, this is followed by letter S, which is steatorrhea, which is basically fatty stools, which is a fat malabsorption syndrome, wherein there is a binding to of calcium in the intestines, preventing its absorption into the bloodstream. Now we have letter C, calcium chelators or binders. And so these are medications that are known to bind the calcium, uh, making it unavailable for absorption or use by the body. We have letter A, which is alkalosis, because in a more alkaline environment, the calcium binds to the proteins more readily, and this can reduce the amount of ionized calcium in the blood. Now, this is followed by our letter L, or lactose intolerance, wherein people with this condition may avoid dairy products, which are a major source of calcium, leading to low intake and also leading to hypocalcemia. We have letter C, celiac disease or Crohn's disease, and we know that these conditions can damage the intestines, impairing the absorption of calcium and other nutrients, which can lead to hypocalcemia. We have letter I, inadequate vitamin D intake. We know that this is a necessary vitamin to intended for calcium absorption in the gut. So without sufficient vitamin D, the calcium absorption is going to be uh, decreased as well. Now we have the letter U for urinary loss. So in such a case with a kidney disease or a polyuric phase of kidney disease, this can cause excessive excretion of the calcium ions in the urine. Now, we also have letter M, malabsorption syndromes, wherein it can encompass several conditions that can prevent the intestines from absorbing calcium rapidly in the gut. Now, what are the manifestations that you should be expecting in a patient with hypocalcemia? Now, please take note the following words: twitches, chats. So this is represented by the following letters. T stands for tetany. We know that with low calcium, it can increase nerve excitability, and this can lead to involuntary muscle contractions and spasms we call tetany. Now, this is followed by letters W and I. Well, of course, with a W, weak pulse or diminished peripheral pulse. This can really affect the cardiac contractility as well. This can lead to a weaker pulse and reduce blood flow into the periphery. Now we have letter I, irritability. This can lead to neuromuscular excitability like twitches, cramps, and paresthesias, because we know that calcium is supposed to stabilize the nerves, right? However, with the low calcium levels in the blood, this can cause them to fire abnormally, leading to the twitches. Now we have letter T for the True sign, which is a classic sign of hypocalcemia, wherein you can see this when you are inflating a blood pressure cuff on the arm, which can induce the carpal spasms due to the increased nerve excitability. We have letter C for the Shvastak sign, which is elicited by the tapping of the facial nerve of the patient that has hypocalcemia, and this can cause the muscle to twitch. Now, we also have the letter H, which is hyperactive deep tendon reflexes. And so in hypocalcemia, this can lead to exaggerated reflexes because of increased excitability of nerve and muscle tissue. And we also have letter E, ECG changes, wherein you will be seeing a prolonged ST and QT intervals. We know that calcium is essential for normal heart muscle contraction. However, with hypocalcemia, um, this will slow down the repolarization phase of the heart, and this can result to the prolongation of the ST and the QT intervals. And we have letter S for the seizures. We know that hypocalcemia causes the overexcitability of the central nervous system, which can lead to this problem. Now we have letter C for the chats, and this is referring to the cramps because the lack of calcium it causes the spontaneous muscle contractions, um, and it's gonna make the cramps to be really painful due to the nerve hyperexcitability. We have letter H for hypotension because we know that calcium deficiency affects heart contractility and vascular tone. This can lead to decreased blood pressure. And we have letter A for the arrhythmias, which can be related to the ECG changes, wherein there is going to be prolongation of the repolarization phase due to the hypocalcemia. We have letter T for the twitching, of course, and letter S for the spasms. And this is associated also with the tetany. Now, we're going to treat these patients with the following list of interventions. We're going to have to treat them with the, or of course, we're going to have to evaluate, monitor the patient's albumin levels. Because as we know, if there is, let's say, elevation of the protein, there is excessive binding of the proteins with the calcium, and this is going to cause increasing or if this is really going to lead to a drop in the ionized calcium. Now, we are going to have to monitor the cardiac activity continuously to capture those arrhythmias. We're going to have to include administration of calcium supplements. It could be IV, calcium gluconate, or oral form tablets. We're going to have to administer calcium boosting meds, and this includes the aluminum hydroxide, vitamin D to allow absorption of calcium in the gut. And of course, our patient with a hypocalcemic state is so excited. They are really prone to developing seizure. We're going to have to provide them a calm environment. We're going to institute seizure precautions and also to include care for handling of our patient, move them slowly because of higher potential to, they have a much higher risk to developing pathological fractures. And we're going to administer calcium gluconate here, 10% IV for possible emergencies. And of course, we're going to educate our patient for increasing their dietary intake. Now, let's proceed to the next imbalance here, which is the hypercalcemia. Now, this is defined as the elevation of the calcium level in the blood greater than 10.5 milligrams per deciliter. And this is caused by so many factors, and this is caused by the acronym HI-LAKE, represented by letter H, which stands for hyperparathyroidism, wherein there is hyperactivity of the parathyroid glands. And this can increase the activity of the parathyroid hormone, which can also increase that level. And with that, it can raise the serum calcium by promoting bone resorption. It can also promote intestinal absorption and kidney reabsorption of calcium. Now, we have letter I, immobility. So with a lack of a movement, or let's say lack of weight-bearing activity, this can lead to bone breakdown we call resorption, and this can release calcium into the bloodstream. We have letter G, GI absorption that is excessive, or let's say there is too much calcium or vitamin D intake, which can enhance excess calcium absorption from the intestine, leading to elevated blood calcium levels. We have letter H, hyperthyroidism, because excess thyroid hormone can accelerate bone turnover, and this can increase the release of calcium from bones into the blood. Now, letter L, we have here lithium use, which can actually reduce the kidney function, and it can increase the parathyroid hormone levels, both of which elevate the calcium by enhancing bone resorption and reducing the calcium excretion. This is followed by letter A, adrenal insufficiency, wherein this can actually, wherein the dehydration is happening due to adrenal insufficiency, and this can reduce the blood volume and also will lead to concentration of calcium in the blood. We have letter K, kidney disease, which is going to reduce the excretion of the calcium. Now we have letter E, excessive calcium supplements, wherein the patient probably is taking excessive amounts of calcium, which can really overwhelm the body's ability to regulate the calcium. Now, as far as the manifestations, please remember this. The acronym for hypercalcemia is heart waves. Now, this is represented by the letters HEART. There is hypertension because with hypercalcemia, this can lead to increasing vascular tone and also the contractility, which can raise the blood pressure. We have E. There's going to be EKG changes. As you see, there's going to be shortening of the ST segment. There's also widening of the T wave and also heart block. Okay. Now, The A is for the absence or diminished deep tendon reflexes. We know that with increasing calcium levels, it can inhibit neuromuscular activity. It can inhibit excitability, and it can also decrease the um, reflex responses. Now, let's talk about the waves, which is represented by the following: weakness, anorexia, vomiting, encephalopathy, slower bowel sound. So take note about heart waves to guide you in remembering the manifestations of hypercalcemia. Now, this time we're going to have to treat this patient. And so our intervention will also include continuous cardiac monitoring because of the changes in the cardiac activity. We're going to have to administer zero point 0.9 sodium chloride, which is an isotonic saline solution. And we definitely need to administer a furosemide either IV or orally. And this is going to allow excretion of excess calcium through the kidneys. And we are going to also discontinue oral medications that have calcium or those medications that are with a high content of vitamin D. Now, we also need to avoid thiazide diuretics because we know that thiazides can actually conserve calcium ions. Now, we are going to administer these medications. They can inhibit the calcium absorption, and these are phosphorus, calcitonin, and the bisphosphonates. Now, another thing that we need to include in our treatment is to prepare the patient for a emergency dialysis, especially if there is a severe case of hypercalcemia, and we're going to have to monitor our patient for pathological fractures and monitor the patient for flank pain or abdominal pain. This is to check if our patient probably is developing renal or calcium stones. Now, for that, we also need to strain their urine to check if they are putting out this calcium stones as well. Now, let's proceed to the next electrolyte imbalance, which is basically the hypomagnesemia. And this is the disorder characterized by a drop in the magnesium level in the blood of less than 1.8 milliequivalents per liter. And this is caused by the following factors. And I want you to recall his made. This is represented by the following letters: H for hyperglycemia, because with high blood sugar levels, this can lead to magnesium being drawn into the cells, thus decreasing the serum magnesium levels, right? And we also have the letter I for the inflammatory bowel diseases, such as the Crohn's or, let's say, ulcerative colitis. This can impair the absorption of the magnesium in the intestines. We have letter S for the sepsis, which can also result in increased magnesium excretion, and this can allow shifting of the body magnesium as well. Now, letter M is for the malnutrition, wherein if the person has insufficient dietary intake of that electrolyte due to probably poor nutrition or maybe starvation. We have letter A, alcoholism. With this person that is abusing alcohol, they can result in a decreased magnesium intake as well, and massive losses of magnesium in the urine. We have letter I for the insulin. And so if there is increased insulin administration, this can lead to the shifting of magnesium into the cells, which will further cause a drop in the serum magnesium. We have letter D, diuretics. So if you are administering large doses of Lasix, this can also increase the excretion of magnesium via the urine. Now, the manifestations of the hypomagnesemia are the following. So I want you to recall the following words: this spect. So this is represented by the following letters: T for the tachycardia. We know that magnesium plays a crucial role in stabilizing the cardiac muscle cells. So if there is low magnesium levels, this can lead to increasing excitability of the heart. So they're going to have a faster heart rate. Letter H for hypertension, and I for irritability. We have letter S, shallow respirations. because we know that magnesium is essential for proper muscle function, including the respiratory muscles. And a deficiency in the magnesium can weaken these muscles, leading to shallow or ineffective breathing. Now, we also have um, S for seizures. So, if in a case of severe hypomagnesemia, this can also alter the neuronal excitability, and it can increase the risk of seizures due to the uncontrolled electrical activity in the brain. Now, this is followed by letter P for paresthesias, because with a low magnesium, this can affect nerve function, and this can lead to abnormal sensations such as tingling or numbness due to increased neuronal excitability. We have letter E for EKG changes, and take note about the peak T waves and depressed ST. And we also have the letter C for Shvastik, and the reason it's because there is excitability, neuromuscular excitability in this hypomagnesemia. Now, there's also trisukine. This is indicative of neuromuscular irritability as well. Now, for a patient with a hypomagnesemia, the following interventions need to be carried out. We're going to need to monitor their serum magnesium levels periodically to evaluate the effectiveness of the treatment, and also to do continuous cardiac monitoring to assess if our patient is developing those dysrhythmias. We're going to have to administer magnesium sulfate IV to replenish. And our patient is prone to developing seizures, so we're going to institute the seizure precautions. We're going to have to monitor the deep tendon reflexes as we are going to replace them with the magnesium. Now, it is very important that we are going to promote the intake of magnesium in the patient's diet to maintain normal levels. Now, in the flip side, we also have the hypermagnesemia, which is basically the level that is greater than 2.6 milliequivalents per liter. And this is caused by many factors. And the following are ID, and this is represented by the following letters: I for increased magnesium intake. So if the person is excessively taking in magnesium containing antacids, or let's say laxatives, or maybe the patient has received excessive IV magnesium, this can lead to this imbalance. D for decreased renal excretion, and this is attributed to renal insufficiency. Now, for the patient that has a hypermagnesemia, take note about the following words. Use the acronym DREAM HARD. So, what does that mean? D stands for the dysrhythmias. We know that hypermagnesemia can lead to, let's say, bradycardia. This can really slow down the heart rate, because we know that magnesium has a depressant effect into the heart muscle. It can also lead to heart block. It can also lead to other arrhythmias. We also have reduced serum calcium. This can lead to hypocalcemia due to the competitive inhibition of the calcium absorption by high magnesium levels. And with that, this can also lead to neuromuscular symptoms. Now, we have letter E for EKG changes or ECG changes, wherein the person will have a widened QRS complex, or let's say T-wave changes. The person will also have altered level of consciousness, and they're going to manifest lethargy, confusion, or in worst case scenarios, they're going to be comatose, because we know that magnesium has a depressant effect into the central nervous system. This can also lead to neuromuscular depression. So, M for muscle weakness and leading to muscle paralysis in severe cases. We have letter H for hypotension. We know that high magnesium levels can cause vasodilation and also relaxation of the blood vessels due to the excessive magnesium. And we have A for areflexia, or let's say absence or decreased deep tendon reflexes. We have letter R for reduced heart rate and also reduce respirations, as it can reduce the cardiac muscle activity. It can also depress the respiratory center of the brain. Our patient will also become drowsy, and we definitely need to treat our patient by continuously monitoring their cardiac activity. We are going to have to administer calcium gluconate, which is basically an antidote for hypermagnesemia. Okay. We know that this is going to help stabilize the cardiac membrane, and this will also restore the normal heart function. Now, furosemide is another medication that we can give intravenously. This will promote the excretion of excess magnesium. We have a restriction of the magnesium intake, and also avoiding those um, supplements that actually contain magnesium, especially laxatives. Now, lastly, we're going to talk about the acid-base balance. So we know that the major organs in the body that can regulate or will help in the balance are your lungs and the kidney. So let's talk first about the lungs. So the lungs basically can regulate the acid-base balance by controlling the carbon dioxide level. So in such a case wherein there is, let's say, carbon dioxide elevation, this is going to cause, or this is basically gonna increase the partial pressure of the carbon dioxide. We are talking about the bloodstream, right? And so in response, the body will actually tell the lungs to hyperventilate in order to get rid of the excess CO2. However, if there is a depletion of CO2, it simply means that there is decreased partial pressure of a carbon dioxide. What's going to happen here instead is that the body will tell the lungs to hypoventilate in order to conserve CO2. And this will now help stabilize. It will also raise the acidity in the blood. Okay. Now, we also have the second organ in the body, which are the kidneys. The kidneys are responsible to maintaining the hydrogen ion levels and also the bicarbonate levels. So it can do some wonders. So if in a case of like acidosis, wherein there is a drop in the pH, right, or less than 7.35, what's going to happen here is that the body will actually cause the kidneys to excrete or eliminate those excessive hydrogen ions. However, it will allow the retention of the bicarbonate ions to alkalinize the blood. All right. Now, in such a case wherein there is alkalosis, there is way too much basic content in the bloodstream. This is basically seen in pH greater than 7.45. And in this manner, it will, the body will tell the kidneys to actually cause to retain the hydrogen ions in order to increase the pH, and it will allow the kidneys to excrete excessive base. Alrighty. Now, it is very important for us to recall the basics of the arterial blood gas, especially when we are interpreting those certain values. So pay attention when we are going to do the interpretation. I want you to do this in a methodological type of analysis. So first thing is you're going to have to look into the pH. All right. So what you're going to do is, if the pH is less than 7.35, then that is identified as acidosis, correct? And if the pH is more than or greater than 7.45, that is considered as alkalosis. Now, in step 2, you're going to look into the partial pressure of the CO2 and also the bicarbonate level. So here are the aspects, the PaCO2 and also the bicarbonate. So here we need to determine which is in the expected range. So this is the time that you're going to conclude that the other is the indicator of the imbalance. Now, what you need to do here is to identify the partial pressure of the carbon dioxide, let's say less than 35 or greater than 45 mmHg. And this is going to be respiratory in origin. Now, we also need to identify the bicarbonate or the HCO3, especially if it's less than 22 or let's say greater than 28. Then if there is a problem with the bicarbonate, then this is going to be metabolic in origin. Now, in the analysis, we need to go into step 3, which is basically to combine the diagnosis of step 1 and step 2 to name the type of imbalance. Now, in step 5, what we need to do here is to determine whether there is compensation. Now, here, it is considered to be uncompensated when the pH is outside the normal value and either the bicarbonate or let's say the partial pressure of the carbon dioxide is outside of the normal value range. However, if there is partial uncompensation or partial compensation rather, the pH, the bicarbonate, and also the partial pressure of the carbon dioxide are outside the normal value range. So the 3 values are actually abnormal. However, if we are talking about full compensation, then we should be seeing the pH is within the normal value range, 7.35 to 7.45, but the PaCO2 and the bicarbonate are both outside the normal value range. Now, let's take a look into the following. So, as you see here, in the first or in the second row, 7.35 to 7.45, if your pH falls in this range, or let's say your patient's partial pressure of CO2 is in this range of 35 to 45, or let's say your bicarbonate level is within this range of 22 to 28, this is basically normal. Your 3 areas are actually within the range. Our patient is in a homeostatic state. Now, for example, if our patient's pH is below 7.35, or if your patient's partial pressure of carbon dioxide is greater than 45, remember that our pH and the PaCO2 are in the exact opposite direction, which simply means that they are acidic, okay? Now, if your patient's bicarbonate level is in the range of 22 to 28, basically it's not compensating, it's in the normal range. So this is considered as respiratory acidosis. Why respiratory? Because it goes in the same direction with the pH. These are too acidic, okay? Now, if your pH is less than 7.35, and if your partial pressure of the carbon dioxide is within the range 35 to 45, but if your the bicarbonate is less than 22, then this is acidic. So you have an acidic pH, you have an acidic bicarbonate, then this is going to be metabolic acidosis. Now, if your case is with a greater than 7.45 blood pH, and if your partial pressure of the CO2 is less than 35, your respiratory system is actually trying to lower down the CO2. So basically, this is alkalotic, so greater than 7.45, less than 735 mmHg basically is alkalotic. So they are going into the same direction. With a bicarbonate within the range of 22 to 28, this is going to be considered as respiratory alkalosis. Remember that the lungs and the pH are going into the same direction, both alkalotic. Now, in such a case wherein there is an elevation of the pH greater than 7.45, however, if your partial pressure of CO2 is within the range of 35 to 45, but if your bicarbonate is greater than 28, this is way too much basic, right? This is alkalotic. The pH is also alkalotic. And so this is going to be metabolic alkalosis. Now, moving into this, we're going to need to do some exercise here. So, given into the following values, we have a pH of 7.3, partial pressure of the carbon dioxide of 68, which is high. We have the bicarbonate level of 28, which is actually within the range. This is considered normal. And we have the partial pressure of the oxygen, which is actually low. Now, what is your interpretation for this one? This is what we call as uncompensated respiratory acidosis with some hypoxemia because of the low oxygen level of 60%. Why this is going to be uncompensated respiratory acidosis? As we are looking at 7.3, this is already acidotic. And look into the partial pressure of the carbon dioxide. This is way more than the value of 35 to 45. So our patient is accumulating way too much CO2, right? And our kidneys is not even responding, right? It's only it's at 28 milliequivalents per liter, and so the kidney is not responding. So this is why the diagnosis here is uncompensated respiratory acidosis with hypoxemia. Now let's have the next exercise here with a pH of 7.0, which is very low, right? We have the partial pressure of CO2 of 23, which is also low. Supposedly, it is going to be at 35 to 45. We have a bicarbonate level of 12, which is low, and this is acidic, and an oxygen level of 90 mmHg, which is in the normal range. So, what would be your interpretation here? Again, pH is acidic. We have the partial pressure of CO2. This is in alkaline nature. We have the bicarbonate level of 12, which is basically acidic this time. The partial pressure of the oxygen is low, or actually this is not low, but within the normal range. So this is going to be, yeah, this is corrected right now. This is not low, but normal rather. And so the interpretation for the sample here is partially compensated metabolic acidosis, and there is no hypoxemia this time. Maybe there is hypoxemia slightly because it's only 90%, but not really considered to be hypoxemic, as we know that our levels ranges somewhere between 80 to 100. Now, we are going to have the last set of values. We have a pH of 7.6. So what is that? 7.6 is basically high value, right? And so this is going to be considered as alkalotic. We have a partial pressure of the carbon dioxide, which is 31, and this is low. So this is considered as alkalotic. We have a bicarbonate level of 25. So the kidney is not even bothered. It is staying in the normal range of 25. Now let's take a look into the 60 mmHg PaO2. It's actually low. So this is going to be interpreted as a respiratory alkalosis and compensated with hypoxemia. Welcome back, everyone, to our NCLEX review series for the Foundations of Care. And today I'll be talking about vital signs. Now, the question here is, in what situations do we need to measure the client's vital signs? Well, we know for sure that vital signs should be measured in the following situations. And so at first, we can do this during the first contact or first interaction with a client, especially during a hospital admission, or it could be a clinic visit, or it could be during a home care visit, or it can be done during a physical examination, before and after any invasive procedures or any surgical procedure, before we are going to administer medications, and after we administer those drugs that can impact the patient's heart, lungs, or temperature regulations. And especially for those patients who have a fever or probably taking any cardiac or antihypertensive medications. And of course, this is something that will be required of you to make sure that you are monitoring or you have done your baseline vital signs. And also after you've given the medication, you need to make sure to check if the patient is getting the therapeutic effect of the medication. Now, another reason is we need to, or another setup or setting that you should be doing the vital sign is during, before or during or after the blood transfusion, in order to capture for any untoward reactions or adverse reactions to the blood product, or let's say when there is a change in the client's condition, or if the client reports unusual symptoms. For example, if the patient would feel so unwell or they feel different. And also, we're going to do the vital signs before they're going to do any kind of activity, let's say an ambulation, right? And this is probably the first time that they have done it after a surgical procedure. And so we want to make sure that our patient can tolerate this activity safely. Now, also, we are going to do the vital signs measurement. Let's say, for example, if a patient has a fever or let's say an infection, we're going to have to do much more frequent checking, at least every hour or every 2 to 4 hours, in order to capture the changes. Now, let's take a look into the different temperature, what do you call this, sites, and also the values according to the Fahrenheit or the Celsius. And so this is just an overall picture regarding the differences in the values, especially if it's about an oral temperature, axillary, rectal, tympanic, or temporal, or infrared. So as you see here, the temperature, the assessment method that has the lowest reading is actually the infrared, and we do have our highest temperature reading via the rectal route. Now, generally, providers consider a fever when the patient's temperature is about 100.4 degrees Fahrenheit, which is about 38 degrees Celsius or higher. But it is very important for us to really follow the facility's guidelines for normal temperature ranges. And this is something that you can do, probably different methods. It could be mouth, oral, or rectal, armpit, ear, or forehead. Now, generally, the rectal temperatures are usually about 1 degree Fahrenheit higher or 0.5 degrees Celsius higher, while the ear and armpit temperatures are about 1 degree Fahrenheit or 0.5 degrees Celsius lower than oral reading. So I really want you to keep in mind about the differences between the core temperature to the superficial body temperature. Now, this time, we need to consider the different levels or the numbers that we can get, especially if we are going to consider the patient's what do you call this? The time of the day. That's actually one of the considerations that we should look at, because generally the temperature would be lower, especially early in the morning due to the muscle inactivity, and it will go higher, especially in the afternoon or let's say evening. And this is due to the increasing activity and also the metabolism. Now, the second one is the environment, wherein the temperature would tend to drop whenever there is colder weather, and the temperature will go up when the weather is warmer. And the same thing with age. Infants may have some sort of fluctuating temperatures because they have not established yet the full development of their temperature regulation, or heat regulation rather. Now, another consideration that you should think about is the exercise. We know that physical activity raises the body temperature by generating the heat. And we also have the menstrual cycle, which actually will influence the temperature. The temperature can drop slightly before the ovulation, and it can go up about 1 degree Fahrenheit during the ovulation. Another consideration here is that pregnancy, wherein the temperature during pregnancy can stay higher due to the increasing metabolism. Of course, with the presence of the baby or the fetus. We also have the stress, wherein the stress can actually boost the hormone production. It can also increase the body temperature. The presence of illness, infection, inflammation, and often can cause a temperature elevation. And of course, if you are going to deal with a patient that may have some kind of like a fluctuating temperature, and sometimes it might be difficult to get their temperature, you gotta have to be careful with that. You don't have to neglect checking that patient's temperature because it might lead to a life-threatening hypothermic conditions, especially in the infants, right? Now, let's talk about the different measurement techniques. Now, you probably have known this already. Of course, when you are measuring the patient's oral temperature, make sure that you have to wait about 15 to 30 minutes after they eat, or let's say after they drink, or if after they smoke, or after they chew their gum. Now, we want to make sure that we are placing the thermometer under the tongue at the back and ask the client to keep their mouth closed without biting the thermometer. Now, another route here is the rectal. We're going to have to position the client on their left side. And we're going to use this method when oral or other methods aren't possible. Let's say maybe they had a nasal congestion or oral surgery. So we rarely use the rectal site for checking the temperature. Now, it's very important that we are going to lubricate the thermometer and insert about 1.5 inches, or let's say 0.5 inches in infants. So 1.5 inches for the adults. Now, we are going to avoid the rectal temperature measurement, especially for those patients with cardiac issues, for those with rectal surgery, or if they had any bleeding risk in the area, because this can aggravate problems. Now, we have axillary, which is a method that we can use if the oral or other methods are not suitable. And it's known to be less accurate, but it can be useful when other methods cannot be used. So around this time, you got to make sure that when you are checking the axillary temperature, that the armpit is dry, so it's not going to give us a false low reading, and make sure that the client's holding their arm against their chest. Okay. Now, the tympanic route is another method of checking the temperature. But before we do that, we want to make sure that we are checking the patient's ear for any redness, for any discharge or foreign objects before we insert the probe. And we are going to avoid this method if the ear is infected or blocked with wax or the ear wax. Now, lastly, we have the temporal artery type of measurement, which is going to cause us or allow us to check the forehead of the patient, but we want to make sure that the forehead is dry. It's not moist or, let's say, drenched in sweat. We're going to have to kind of slide the thermometer across the forehead and hold it on the temporal artery. Now, if the client is sweating, we want to make sure that we are placing the probe right in front of that site. Now, leading to the next vital signs is the measurement of pulse. And we know that the pulse is basically going to be done because that is a palpable indicator that there is a blood flow, right? Especially with the peripheral arteries. Now, it is a marker of a good circulatory status. However, in the adults, though, the average pulse rate is going to be around 60 to 100 beats per minute. Okay, please take note of that. Anything above that would be abnormal. That's tachycardia, or less than 60 in the adult is bradycardia. And it is very important for us to monitor the changes in the pulse rate because it is crucial in reflecting the client's physiological response to any of their activities, let's say walking, bathing, or exercising. And also, we are going to assess the pedal pulse or the distal extremity pulses in evaluating the circulation into their extremities or their legs. Now, if in case there is going to be difficulty in assessing or a difficulty in palpating those distal pulse sites, what we can do is to obtain the pulse through a Doppler ultrasound for us to amplify the sounds of the pulse, and this will give us a better accurate assessment. Now, as far as the consideration, we want to make sure that we are considering the different factors such as the aging. As the people will age, the heart rate tend to slow down. However, it can be increased with exercise if there are strong emotions, pain, could be fever, or any stimulants. This can be influenced by those factors. Now, we are also going to consider that The heart rate or the pulse rate can be influenced by some of these medications, such as the beta blockers, the calcium channel blockers. I put it there, the CCBs, and the cardiac glycosides, such as the digoxin. So these are things that you need to keep in mind, especially when when your patient is taking these drugs, and when you are checking the patient's vital signs. Okay, we want to make sure that our patient is within the safe range, especially. Okay. Now, another thing that we are going to do as part of our pulse assessment is to check for the rate, the rhythm, the strength, the equality. We need to compare the pulses from one side to the other. And we need to also utilize that grading scale to have that standardized assessment. Now, what we're going to need to do is to recall this different grading method. So you've already seen the 4 plus, which is basically going to be strong and bounding. And this is very important, especially if we are going to assess for the amplitude or the character of the patient's peripheral pulse. Now, 3 plus means that it is full, it is increased. And 2 plus is considered as normal. It is easily palpable. We have plus 1 or 1 plus, which is considered as weak, barely palpable. And lastly, we have 0 as absent or not palpable. So this is a grading system that you should be doing or you should utilize whenever you are checking a post-surgical patient, especially if they have a orthopedic surgical procedure, or let's say a resection of a blood vessel, anastomosis and resection of a blood vessel. For example, if there is a compromise of circulation to the lower extremities in a peripheral arterial disease, right? So they're going to undergo those special procedures. So we want to make sure that we are evaluating accurately the post-op pulsation in order to capture if there's any problems in this patient. Now, also, we're going to have to check for the pulse deficit. So this is something that you need to keep in mind. And what is this basically? Well, a pulse deficit can happen when the radial pulse is slower than the apical pulse. And what it indicates is that it signifies poor blood flow to the extremities, and this can signal heart rhythm issues as well. Now, there are 2 techniques on doing the pulse deficit assessment. There's that one-person assessment wherein you're going to do the counting of the apical pulse first. Then after that, you're going to proceed with counting the radial pulse. However, you can also do the 2-person assessment wherein one person is counting the apical pulse while the other person is counting the radial pulse at the same time in order to capture the different sites. Now, what does the pulse deficit indicate? Well, if this is positive, well, it simply means that there are some heartbeats that are not strong enough to reach to the peripheral arteries. So if you're going to assess this pulse deficit, make sure that you're notifying the healthcare provider so that they can also do some more investigations about this issue. Now, what else do we need to know about the vital signs? Well, here we go. We have the respiration. So this is the assessment, how the body is exchanging gases between the air, the blood, and the cells. And we know that the adult respiratory rate usually sits around 15 to 20 breaths per minute or 15 to 20 cycles per minute. Now, we need to do some checking here because it can vary from one age to the next. So normally, older adult will have that 15 to 20 cycles per minute. For a middle-aged adult, about 12 to 20 cycles per minute. For a 15-year-old person, their range would be similar to us. For the school-age children, their range would be about 16 to 22 cycles per minute. And for the 6 to 12-month-old patients, there's going to be 22 to 38 cycles per minute and 30 to 45 cycles per minute for the 3 to 6 months old. And for the newborn up to 3 months, their rates will be much higher at 35 to 55 cycles per minute. Now, let's talk about the different considerations when we are checking the patient's respirations. Now, we need to know that For those factors that can influence the pulse rate will also impact the respirations as well. So expect that if the patient has a faster heart rate, you can assume that the patient's respirations can also become faster this time. And this is something that can be easily seen in most patients. Now, for in a state wherein there is high carbon dioxide, or let's say if there is a low oxygen level in the bloodstream, this can lead to an increase in the respiratory rate because this is a normal compensation of the body to uh, increase the delivery of oxygen into the body. So this is a compensatory mechanism. Another consideration that you should think about is that when head injuries occur, or let's say if there is elevation of the intracranial pressure, this can also lead to a shallow breathing. The respiratory rate will be slower. Now, if a person is taking an opioid medication, this can depress the respiration because opioids can target the respiratory center of the brain, the medulla oblongata. Now, when you are assessing the patient's respirations, you got to make sure that you are counting the respirations after you are taking the patient's pulse discreetly. You can do this by holding the patient's wrist or placing a hand on the chest so that the patient will not be able to alter their own breathing. This is a technique, basically. Now, what we need to remember is that when we are checking on the respiratory rate, especially if this is the first time that we have encountered this patient, or let's say their respiratory rate seems to be a little bit irregular, you got to do this for 1 full minute. Do not just count the respiration for about 30 seconds and then multiply it by 2 when their respiratory rate is irregular. However, if the patient's respiration is more regular, then you can do the 30-second count and then multiply it by 2. Now, aside from that, when you're assessing the respiratory rate, you need to also determine the rate, the pattern, the depth, and also the unusual sounds that may accompany with their ventilation. Now, this time we're going to talk about the blood pressure. And take note that there are some important reminders for you to recall here, okay, or to keep in mind of. So, normally the blood pressure in the adults should be less than 120 in the systolic and less than 80 for the diastolic. And the person is considered to have an elevation of their blood pressure when the systolic blood pressure is going to be around this range, 120 to 129 for the systolic, and for the diastolic, their blood pressure is less than 80. So this is already considered elevated. When the patient is considered to be at stage 1 hypertension, most of the time their systolic should be at around this range, 130 to 139, or when their diastolic readings will be 80 to 89 mmHg. Now, proceeding to the next stage, stage 2 hypertension, not fun. Systolic blood pressure around this time will be at least 140 mmHg, and for the diastolic, at least their reading should be at 90 mmHg. And for a patient that is considered to have a hypertensive crisis, it will be about greater than 180 mmHg for the systolic and greater than 120 for the diastolic blood pressure. Now, this is very important for you to take note. You gotta do immediate follow-up regarding high elevations or the elevations of their blood pressure, especially when they reach the hypertensive crisis level. You gotta pay attention and make sure that the medical provider is made aware so that we can treat the high blood pressure as well. Now, what are the considerations that you should keep in mind? Well, we know that the blood pressure can increase with age, right? And it can also be elevated in most patient groups. Let's say, for example, for the African Americans or Blacks, they tend to have higher blood pressure. Also, with East Asians, there are also some medications that you need to be mindful about. For example, antihypertensive medication, of course, this is going to lower their blood pressure. for medications that are, let's say, opioids, they tend to cause a lowering of the blood pressure. Now, take note that the blood pressure readings can also be influenced by the time of the day. So the blood pressure seem to be at their lowest point early in the morning, and they can be highest in the afternoon because of the activity during the daytime and also the increasing metabolic rate. Now, take note that there are also influences such as smoking, activity, body weight can also impact the patient's blood pressure. Now, for the assessment, what we need to recall here is that we are going to select the best site for the blood pressure measurement. So there are things that you should avoid. For example, we're going to avoid those areas that have the intravenous access site, the arteriovenous fistula for the dialysis patients, and for those areas that are post-operative sites. Okay, we don't want to utilize those areas. Now, when we are checking for the patient's blood pressure, we need to ensure that they have not smoked within the 30-minute period before checking. Okay, and when we are assessing the patient, when they arrived into a clinic, make sure that they are at least resting, that they have rested for at least 5 minutes upon arrival. We don't necessarily check their blood pressure right away as soon as they walk into the clinic, and once they sit, we can do the blood pressure. No, that is totally inappropriate. We got to make sure that our patient has rested for a full 5 minutes in order to allow stabilization of the patient's body. And also, we are going to think about the mean arterial pressure. I'm not sure if you're so familiar with this, but this is another value that you should think about, especially in the advanced cases. And if you let me, the mean arterial pressure is the value that is going to reflect the average pressure in a person's arteries during one cardiac cycle. And this is going to represent the steady blood pressure that will keep the blood circulating, that will keep the blood flowing to the vital organs throughout the body. So basically, the mean arterial pressure is an indicator how the body is able to perfuse adequately those vital organs. Now, take note that the normal range, the mostly acceptable range for the mean arterial pressure is 70 to 100 mmHg. Now, again, the mean arterial pressure, if it's going to be less than 65, this is the time that you are you're going to be in high alert this time. This means that the patient is not able to perfuse adequately the vital organs. They are going to be at risk for organ dysfunction. Okay, even though in the clinical setting, anything that would be at 65, 68, 69, they are considered to be decent. But in most case scenarios, especially in the critical care setting, it is safest to consider the normal range at 70 to 100, okay? Not in the 65 to 70, all right? But as we are talking about the MAP of less than 65, this is a danger zone, okay? You're gonna have to do frequent monitoring into this patient, and make sure you're doing your diligent interventions to keep the blood pressure up. Okay, however, if the MAP is greater than 100 mmHg, that is not also a good thing. It simply means that the patient probably has hypertension, okay, or hypertensive crisis. Now, if you are going to get the mean arterial pressure, you need to obtain first the patient's blood pressure. So here goes the formula. This is the mean arterial pressure is going to be obtained by multiplying the diastolic blood pressure by 2, and then you're going to add that product with the patient's systolic blood pressure, and then you're going to divide it by 3. The 3 is the constant, okay? Now, how are we going to do that? So for example, if the blood pressure of your patient is 120 for the systolic and 80 for the diastolic, so we're going to substitute all those values. So we are going to multiply the 80 diastolic by 2, So basically that's going to be 160, and you're going to add 160 to the patient's systolic blood pressure of 120. So this is now going to be 280, and then after that you're going to have to divide it by the constant of 3. So now it will yield the MAP of 93.3 mmHg. So at this rate, our patient is still in the safe range, normal mean arterial pressure. So again, make sure that your patient is within that range at 70 to 100 mmHg. Now, moving into the next section of our vital signs is the pulse oximetry. So what is this? Well, this is a very simple, non-invasive test that will measure the patient's oxygen saturation in the blood. Now, normally, our oxygen saturation should be around 95% to 100%. And this is going to show us how much oxygen is being carried by the hemoglobin. And it can also detect a low oxygen, or let's say hypoxemia, before more symptoms can appear. However, though, if the level of your patient saturation is low, what you can do this time is to encourage deep breathing exercises. It can probably help, and the test should be repeated. Okay. However, if the patient's saturation is not improving, then you're going to do your next step. Probably the patient would require additional oxygenation. So you're going to have to evaluate the patient. Is there something causing it? Is there probably a problem, let's say bronchospasm, or maybe the patient is probably getting way too much of the opioid medication, or maybe they have a disease, respiratory condition such as pneumonia. So these are things that you need to investigate, but we want to make sure that we are going to cause that oxygen saturation to go back up in order to stabilize the perfusion to the body organs. That would be our main goal around this time. Now, what would be the considerations that you should think about? We want to make sure that you are correctly placing the sensor on a pulsatile, or let's say a pulsating area like the fingertip, or let's say the earlobe. There's so many things that you need to factor in. There are some factors that can influence the accuracy of the reading. And so if there is probably sensor movement, if the patient's probably kind of moves around with their hands or fingertips, this can influence the reading, especially. Or, for example, when there is a nail polish, probably you're going to have to select a finger that doesn't have it, or maybe you need to remove the nail polish so you can get a more accurate reading. And if in case there is a low blood pressure, chances are is that the patient's oxygen level will also be lower. For example, if there is anemia, low hemoglobin level can also influence the reading. Or if there is poor circulation, these things can definitely affect the accuracy of the patient's oxygen saturation. Now, as you are going to assess for the pulse oximetry, we want to make sure that you are placing the probe or the sensor carefully into that site. It could be a finger, it could be the toe, it could be the nose, earlobe, or the forehead to measure the oxygen levels. But if you're seeing that the patient's distal extremity are kind of like dusky, or let's say if they have some obvious low blood supply to probably the fingertips, then the area will not be a reliable source of oxygen saturation measurement. What you probably would do is to apply the sensor to the earlobe, or maybe to the nose, or to the forehead. Now, you need to avoid placing those sensor into those cold extremities as well, or for those areas that have poor blood flow. Now, this time, we are going to talk about the assessment of pain. This is a very important aspect of the vital signs. Now, we are going to differentiate the different types of pain. Now, the first one that we have is the acute or the transient type of pain. So this is what we call as short-term. It usually occurs from an injury or surgery that could last from a few hours to several days. However, we also have that chronic persistent pain, which is mostly linked to a long-term condition. It could last for several months or years. We also have the chronic episodic pain, which can occasionally occur over a long time. Let's say migraines or sickle cell pain. So they don't really occur constantly, but they will come and go. That's why they're called episodic. Now, there's also that cancer pain, which can become an acute or chronic. Of course, this is caused by the tumor or the treatments itself or some other related issues. Now, there's also that idiopathic pain, which is a type of a chronic pain without a clear cause, or it seems that there's just seems an excessive for that condition. So this is what we call as idiopathic. Now, when we are doing the pain assessment, you got to keep in mind that the patient's rating of that pain is unique. Um, it is a subjective finding. And so you need to understand that whatever the patient says their pain level is, you're going to have to consider that this is factual. Okay. Now, you're going to have to ask the patient about the pain timing. When did this occur? Where did this happen? Okay. Or the exact body location, the severity in a scale of 0 to 10. And you're going to ask about the factors that are aggravating it. Or let's say you're going to also ask what factors that are able to relieve their pain. Now, another thing that you need to consider here is to ask about the possible complementary or alternative pain therapies that they're currently using. And take note that for some people, let's say the older adults, they may show pain through some issues. Maybe they're going to end up with, let's say, insomnia. They're probably going to have some mobility changes or, let's say, depression because of the ongoing pain. Now, the nonverbal cues is something that you need to consider as well because this can indicate uh, pain as well, especially for those people with a dementia. They will not be able to really express what they're feeling. And so you have to keep in mind maybe the patient is getting so restless or just so agitated or, let's say, crying. These are things that you need to be careful about and investigate on. Now, we are going to use an appropriate rating method or scale for each type of patient. So, if you have a patient that is alert oriented, adult patient, then it's safe to use the 0 to 10 numeric pain scale. However, if you're going to have to deal with a child, especially an infant or a newborn, or yes, the infant, you can use the fact scale. Okay, or probably in other age groups you can use the faces as well. Now let's talk about the pain relief. This is a very important aspect in the assessment of pain. There are some non-pharmacologic pain relief, and this will include the cutaneous stimulation, such as heat and cold application. There's also the pressure or massage. These are things that may require a healthcare provider's order. There's also the TENS or the PENS, which basically involves the use of the stimulation, electrical stimulation to block the pain. And this is also going to require some prescription by the medical provider. Now, also consider that there are some support devices that can be used, let's say in the form of a wrap or let's say slings. These can help with the pain from the injuries or let's say a surgical procedure. And so the same thing with the elevation of the limbs can also reduce the swelling. Now, we need to consider that alternative therapies are also common in nowadays. Okay. Now, we know that complementary and alternative therapies are going to be used alongside the conventional treatments. And this can include those herbal therapies. And at this point, the medical provider may need or the patient may need a medical provider's approval before they can use these herbal medications because they can potentially interact with the pre-existing medications that they are using. And another thing that you need to consider here is to respect the cultural and spiritual practices or beliefs our patient is using. Okay. Now, What are we going to need to do this time is to also review on the different um, treatments for the pain. So we have here our non-opioid analgesic. So I believe that you're probably familiar to this. And so with the non-opioid analgesics, this is going to pertain about, this is referring to the NSAIDs, right? Let's say the ibuprofen or the aspirin. Please take note that these NSAIDs should be avoided in patients that may have stomach ulcers, or let's say when they have irritation in the stomach lining, if they have any allergies. Um, these medications can really interact with some of these medications, like the anticoagulants, right? This can increase their risk of bleeding. Some medications, the oral diabetic medications, can also interact with the salicylates or the ibuprofen. And same thing with the calcium channel blockers. Um, Take note that the ibuprofen can be toxic when combined with the calcium channel blocker. And for the non opioid analgesics, when combined with the diabetic medications, this can probably cause the hypoglycemia. So you got to keep an eye, make sure that you are monitoring the patient's blood sugar from time to time. Now, as we're going to move into the acetaminophen, which is a widely used antipyretic medication or analgesic rather, this is something that should be cautioned or should be avoided in patients with liver or renal disease, or for those who are abusing alcohol, or if they have any allergies. We need to make sure that we are checking into their history. If they have any liver problems, we're going to have to keep watch into any signs of a liver damage, let's say nausea, vomiting, or yellowing of their skin. We need to check on their liver function tests, and we want to make sure that we are cautioning or warning our patients not to use the acetaminophen more than 10 days for the adults or 5 days for children because of the risk in the development of hepatic toxicity. Now, take note that the antidote for the acetaminophen overdose is the acetylcysteine. Now, talking about the opioid analgesics, this is a very common modality of treatment. What we know about the opioid analgesics is that this can block the pain, but this can also slow down the patient's breathing and also their coughing. And so these are things that you need to keep in mind, especially for those patients that had just had a surgical procedure. So we know that treating their pain is important, but we also need to keep in mind that we are not causing their respirations to be so low that they will end up with hypoxemia. No, we don't want that either. We're going to encourage them to do the coughing exercises in order to prevent hypostatic pneumonia or collection of the secretions in their lung fields. We don't want those. Take note again, the opioids can lead to respiratory depression. So these are things that you need to keep in mind. Also, there is a consideration that our patient will probably require a lower dose of the opioid whenever they have a renal or liver issues, because they will tend to what do you call this, retain, or they will tend to have more toxic effects of the medication because of the impaired organ function. Now, for the long-term use of the opiates, this is very important for us to consider as well, because it can lead to issues, let's say, for constipation, obstipation, urinary retention, and our patient needs to be cautioned about not driving or, let's say, not handling heavy machinery because they're going to be prone to accidents around this time. Now, what are the important nursing keys to remember when we are administering opioid medications? We will administer the opioid drug at least 30 minutes before a painful activity. Or let's say if they're going to need to do a rehabilitation. So let's say if they are a post-op patient and they need to keep doing their exercise, we need to administer that opioid medication to control or to diminish the level, to diminish their pain level, I should say. Now, if in case the patient's respiratory rate is less than 12, this is the time that you should not be giving the opioid medication, because the more that you're going to give this drug, then this will cause more respiratory depression. You need to notify the medical provider right away. Okay. Now, what else you need to think about? You are going to monitor the patient's vital signs, such as the pulse rate, the blood pressure, the lung sounds, also the urine retention, because we know that the opioid medications can cause urinary retention and also constipation. So these are the things that you need to be mindful about. Now, talking about overdose of the opioid drug, here we go. We have the naloxone as the antidote of choice. This is going to reverse the overdose of your patient. It can be in a form of a nasal spray, or it can be in a form of IV injection. Okay, so this can really reverse the patient's narcotic overdose within a span of a few minutes, but you need to really keep evaluating the patient, because sometimes they can probably go back into that unconscious state. You really need to keep an eye to this patient for the first 2 hours after the administration of the naloxone. Now, moving into the adjuvant therapies, analgesics. These are your amitriptyline, which is basically an antidepressant medication. We also have the venlafaxine. We have the gabapentin, which is a anticonvulsant medication. However, we do use the gabapentin for some pain, especially the peripheral neuropathy type of pain. And take note that these adjuvant therapies can also have their own specific side effects and adverse reactions. So we really need to be cautious about each of these medications. Now, including the marijuana or the cannabinoid oil, these are common nowadays in the treatment of the pain. Okay, so this is going to be dependent on the state where you're going to be working at, and also the management of pain with the use of the marijuana. Okay, now we are going to talk this time about the laboratory values. So I'm going to be presenting to you some of the lab values that you should recall. So the first one is the serum sodium. We know that the serum sodium is the main electrolyte in the body fluids, right? We know that this is the electrolyte that can control the water balance. It also can control the nerve signals, acid-base balance. It is an electrolyte that is absorbed in the intestines. However, it can be excreted through the urine. Now, recalling the normal range of our serum sodium, it should sit around 135 to 145 milliequivalents per liters. Now, this is the time that you need to recall. When the value goes lower than 135, you need to identify those states or conditions that are associated with this hyponatremia. So the hyponatremia can occur in a state wherein the patient has an Addison's disease, wherein they have a lack of the aldosterone. So the patient will end up with decreased reabsorption of sodium in the renal tubules, right? So they're going to end up with a low blood pressure. Another is low intake of sodium in the diet. Or let's say a patient may have a ketoacidosis. There is a massive excretion of the sodium through the urination. We know that with a DKA, they're going to have that osmotic diuresis because of the glucosuria, because of the elevation of the sugar in the urine. The water will actually follow along with the other electrolytes, so it can be easily lost through that route. Now, in such a case wherein there is diaphoresis, or let's say GI losses through vomiting, or it could be diarrhea, or it could be GI loss through a nasogastric tube suction. Yes, those are things that can really deplete the patient's sodium level. Another Cause here is the water intoxication. So if your patient has consumed way too much water at a shorter time, this can really dilute their sodium level, and this can put them at risk to developing seizures, also encephalopathy, because we know that sodium is important in the transmission of nerve impulses. Now, if in case the sodium level is beyond 145 milliequivalents, take note that these are the associated conditions. One is the administration of the corticosteroids. We know that corticosteroids can actually enhance the reabsorption of the sodium in the kidney tubule. So your patient will be at risk in developing high blood pressure as well around this time. Hyperaldosteronism. So this is a case wherein the patient will have, let's say, Cushing's disease or Conn's disease. They have excess aldosterone in their bloodstream, which can cause excessively high sodium levels. Now, if the patient has been taking in way too much sodium in the diet, or if they had received way too much hypertonic saline solution, they can end up with this. Or, for example, if the patient is dehydrated, or maybe they are receiving nasogastric tube feedings, or let's say the gastrostomy feeding, but if they are not given adequate hydration, they can end up with hypernatremia. So you really need to pay attention into those patients that will be using those enteral feedings. Now, another is the dehydration, of course. This can lead to the hemoconcentration of the solutes. So again, this can lead to a hyperosmolality greater than 300 milliosmoles per kilo. And also, this can lead to a sodium level greater than 145 milliequivalents per liter. Now, this time, let's switch into the next electrolyte, which is the serum potassium. This is a major cation inside the cells, and it has the role of managing the water balance as well, the muscle function, and the pH levels. So this is something that can be obtained through food. However, the potassium is going to be regulated, or it can be excreted via the kidneys. And we know that the potassium is very important in the heart function and also the kidney function. And take note, guys, that when you are going to encounter a patient that has an imbalance in their potassium, you really need to establish that normal potassium level of 3.5 to 5.0. Okay. You might see this in other textbooks that the upper limit would be 5.3, but for the sake of the NCLEX, make sure that you're using the 3.5 to 5.0, because in the NCLEX, it is already considered to be hyperkalemic if it's over 5.0. Now, whenever there is a drop of the potassium level, let's say less than 3.5, this can be caused by the following issues. If there is trauma to the body, let's say open wound because of the burns, this can allow the potassium to leak out through the open areas. In a case of a Cushing's disease, because the Cushing syndrome or disease actually has that elevation of the aldosterone, which is going to allow increased secretion of the aldosterone, which will favor the reabsorption of sodium. So this has that antagonistic effect to your potassium. So whenever there is Cushing's disease, the patient's potassium level will be so low. Now, if there is a low intake of the potassium containing foods, of course, you're going to expect that they're going to be hypokalemic. If there is diarrhea, if they're excessively losing a lot of the GI contents, or it could be vomiting, this can also lead to that problem. However, the potassium level can be so high whenever there is renal failure, because the kidneys are no longer able to excrete the excess potassium ions in their body. And so the body will tend to collect more of that. And that is the danger in renal failure. Another is dehydration. So this can really lead to that hyperkalemia whenever there is ketoacidosis or if there is tissue damage, okay? but tissue damage that excludes the burns. Okay, so that's the caveat here. We're not going to include the burns in the tissue damage here. Now, talking about the next lab value would be the APTT, or known as the activated partial thromboplastin time. And this is totally different from the partial thromboplastin time. This is a more accurate testing whenever we are going to um, monitor the patient taking the heparin infusion for, let's say, anticoagulation. Whenever they have, let's say, um, whenever they're taking the anticoagulant heparin for a pulmonary embolism, or let's say a DVT, or let's say whenever they had an acute coronary syndrome, we need to keep an eye on their APTT. Okay, please take note of that. Now, the activated partial thromboplastin time will measure the clotting function in the intrinsic pathway. Please take note of that. We are talking about intrinsic pathway here. Now, the APTT will screen for the clotting factor deficiencies. Okay. We also have the APTT to monitor the heparin therapy. And this is also required. We're going to need to draw the blood before the next heparin dose as well. Now, one thing that you need to keep in mind when you are the nurse drawing the blood peripherally through the veins, do not draw the blood sample from the arm where the heparin infusion is infusing. Okay, make sure that you are using the exact opposite extremity. Now, when you are done collecting the blood sample, it is very important that you are sending the specimen right away to the laboratory to prevent any discrepancies in the result. And we're going to have to directly apply some pressure into the extremity where you did the blood draw. And take note that the heparin therapy actually can prolong the APTT, and this can prolong about 1.5 to 2.5 times the normal, 30 to 40. So you just need to multiply it by either 1.5 to 2.5. So if we are talking about heparinized APTT, you'll use those constant numbers. Okay. Now, whenever there is a low APTT value, this simply means that your patient probably has an issue with their clotting factor number 8, which is the antihemophilic factor A, or this means that they might have this antiphospholipid syndrome, or maybe they have also dehydration. So these are things that you need to keep an eye out. However, the APTT can be elevated whenever there is a problem in the clotting factors 8, 9. We also have clotting factors 11 and 12. So we know that clotting factor number 9 is the antihemophilic factor B. We have clotting factor number 11, which is the plasma thromboplastin. And we also have the clotting factor 12, which is the Hageman factor. Now, take note that the APTT can be elevated whenever there is liver disease. We know that the liver is responsible in synthesizing those clotting factors, or the APTT can be elevated when the patient is being treated with the heparin infusion. Now, moving into the next laboratory is the prothrombin time and the INR. So the PT and the INR, which is the international normalized ratio, these two will actually measure the clotting time, the extrinsic pathway. Earlier, we talked about the APTT. That value will check the intrinsic pathway. Now, the INR basically will be drawn together with the prothrombin time. So here are the following normal values. The PT, or the partial thromboplastin time, normally sits around 11 to 12.5 seconds. This is baseline. The patient is not taking any warfarin this time. For the INR, without warfarin, it should be around 0.8 to 1.2. Okay, I put it there, no warfarin. Now, if there is a much lower values of the two, this is something that will alert you. Low levels can mean that there is a very high vitamin K level in the body, or let's say the patients may be taking excessive intake of the vitamin K, maybe too much of green leafy vegetables. This can really shorten the prothrombin time, or this can happen in hypercoagulable states, wherein this can promote the excessive blood clotting, right? Or let's say when they have cancer. So these are things that you need to remember. Or for those people that may be taking estrogen containing contraceptives, they are really prone to developing blood clots. Now, some people might also have some genetic factors. They might have that genetic disorders that can lead to a faster clotting time. Now, for the exact opposite, higher levels of the prothrombin time can mean that our patient probably have an ongoing liver disease. We know that the liver is responsible in producing the clotting factors. So if there is a dysfunction, this can also impair their production of the clotting factors. Vitamin K deficiency is another one. Whenever there is low vitamin K, this can lead to the decreased production of the clotting factors 2. Also decreases the production of clotting factors 7, 9, and 10, and this can also result to a prolonged prothrombin time. Another indication that the prothrombin time INRs are elevated is the use of the warfarin, or let's say if they have a disseminated intravascular coagulation, the clotting factors are actually going to be depleted, like clotting factors number 1, 2, 5, 7, and 10. So our patient really will be prone to bleeding around this time. And in some cases, some antibiotics might also cause the prothrombin time to go higher. So you need to really review the patient's medication history. Now, this time we're going to talk about the platelets, which is part of your complete blood count. But we have separately isolated the platelet here, so we'll know more about the specifics. Now, the platelet count is intended to take part in the clotting process, right? And this is normally produced by the bone marrow. And to review, the normal range for your platelet count is somewhere between 150,000 to 400,000 per cubic millimeter. And this can be decreased in such a case of acute leukemia, if there is chemotherapy, if there is disseminated intravascular coagulation, or let's say, because we know that in the DIC, the platelets are actually being used up. The body is running out of all the platelets. So they have excessively utilized everything in the body. So our patient will be prone to bleeding this time. Now, the platelet count can also be reduced whenever there is hemorrhage, if there is infection, systemic lupus erythematosus, or a thrombocytopenic purpura, or in a case wherein there is HIT, which is the heparin-induced thrombocytopenia. So add that in your notes. However, the patient will end up with thrombocytosis or higher levels of the platelets whenever they're going to have acute infections, if they have what we call as chronic granulocytic leukemia, if they have chronic pancreatitis, if they have cirrhosis of the liver, or disorders, let's say collagen disorders, if they have polycythemia, or if they have had the postplenectomy, or if they are living in areas in high altitudes, they are known to really have higher levels of the platelets. Hi, everyone. This review session is a continuation to the laboratory values discussion that we had previously. So let's get started. Now, here we are going to talk about the hemoglobin and hematocrit values, which are actually part of the complete blood count. We know that the hemoglobin is a key protein in the red blood cells, and it is very important to have this hemoglobin, because they are going to carry the oxygen to the body tissues, and they're responsible in removing the carbon dioxide. And this is a test that is actually does not require fasting beforehand. So you're seeing here the different values of the hemoglobin between the adult male and the adult female. So for the adult male, you're going to see that it's about 14 to 18 grams per deciliter, but for the females, their range will be around 12 to 16 grams per deciliter. Now, as we're going to go through the discussion here, we know for sure that the males are actually going to have a much higher um, volume, or let's say value, in their hemoglobin. That is because of the body size and also the larger uh, skeletal component of the system, right? It is actually going to cause them to have a much greater number of the red blood cell production and also the hemoglobin. Now, take a look into the significance of having a low hemoglobin level. Well, this is going to be decreased whenever there is anemia or, let's say, blood loss, and it can be increased when there is going to be chronic obstructive pulmonary disease. And this is a body's compensatory mechanism wherein they will try to produce some more red blood cells, especially if there is a lack of oxygenation. The same thing with people living in high altitudes and mountainous areas. They're going to tend to have higher hemoglobin levels, and also in cases wherein there is polycythemia vera. Now, talking about the next component here, which is the hematocrit, this is the component that measures the proportion of the red blood cells in the blood and making this as a valuable indicator for the conditions like anemia or, let's say, polycythemia. Now, look at here again about the values between the adult male and female. Of course, with the male, the range is much higher, or yes, this is about 42 to 52% compared to the females. That ranges around 37% to 47%. Now, we know for a fact that the hematocrit values will be lower whenever there is a decreased red blood cell, or there's also bone marrow disorders, because we know that the bone marrow is responsible in producing the red blood cells, or, for example, when there is a blood loss, or there is leukemia, or, let's say, when there is excessive fluid that is diluting the circulation. We call this overhydration. Okay. Now, the hematocrit count will also be increased whenever there is going to be dehydration. This is going to cause the volume of the fluid or the water to be in lesser amount. However, the blood cell component will be higher in the amount. And so this is going to increase the concentration of the red blood cells. And same thing with high altitudes and increasing levels of the red blood cells, we call as polycythemia. Now, as we're going to move along here, we're going to talk about the lipids. So the blood lipids are mainly going to be uh, this includes the cholesterol. This also includes the triglycerides and the phospholipids. And the lipid testing is the act of the measurement, wherein we are going to look into the cholesterol, the total cholesterol, the high density lipoprotein, or what we call as the good cholesterol, or the HDL. We have the low density lipoprotein, or the LDL, and the triglycerides. Now, we know that the cholesterol is found in all the body tissues, and it is a key part of the LDL. Also, it's going to be part of the brain and nerve cell function, the cell membranes, and some gallstones. Now, we are going to talk about the different components here, especially with the preparation. So the patient that is supposed to be checked on their lipid panel, they need to fast at least 12 to 14 hours before the testing, and with the exception of water. So they can still drink water overnight, but they cannot drink any more. Other than that, juices or soda, anything that has sugar in it, that's not going to be allowed. Another thing that needs to be taught to the person that has a scheduled lipid panel to be drawn the next day will be to avoid alcoholic drinks for about a day before the blood draw. And they should be taught to refrain from taking high cholesterol foods the evening before the test. So please make sure that you're going to include this in the education for this patient. Now, let's go into the different ranges of the lipids. So there are so many components, right? So we'll talk first about the cholesterol, which should be less than 200 milligrams per deciliter, and the LDL, which should be at less than 100 milligrams per deciliter. Now, these two will be in, if the values of these two are less than 200 milligrams per DL or less than 100 for the LDL, it simply means that there could be an extensive liver disease, or maybe there is hyperthyroidism, or could be malnutrition, or maybe they're using steroid therapy for quite a long time. However, the values of both cholesterol and the low density lipoprotein can be increased whenever there is going to be obstruction of the bile tree or the biliary tree. If there is an issue with the liver itself, like cirrhosis, or it could be a hyperlipidemia, or maybe a low functioning thyroid gland, or if there is what we call as an idiopathic hypercholesterolemia, or if there is a problem in the kidneys, could be an uncontrolled diabetes mellitus, and the use of the oral contraceptives. Now, another testing that is a component of your lipids would be your triglycerides. So what is this? This is something that you can see in, well, of course, we have the values here, differing values between the adult male and adult female. So again, the adult male has a range of about 40 to 160 milligrams per deciliter. And for the females, they usually will sit at 35 to 135 milligrams per deciliter. And the value of your triglycerides will be decreased whenever there is an overactive thyroid gland, or if, let's say, there is going to be malabsorption syndrome, or in a case of malnutrition. And the value of the triglyceride will tend to be skyrocketing whenever there is diabetes mellitus, if there is hyperlipidemia, hypothyroidism, and also liver disease. So please take note about the differences of the disorders with each imbalance. Now, we'll talk about the high density lipoprotein, which is the good cholesterol, right? And so it's normally a greater than 60 milligrams per deciliter. Okay. Now, take note that when the HDL drops below 60, it simply means that maybe the patient could be leading a sedentary lifestyle, or maybe they have a diet that is high in refined carbohydrates, or maybe in healthy fats, or it could be that they are obese, could be smoking, or maybe they have a type 2 diabetes mellitus, or if they might have a hypertriglyceridemia, or maybe they have been, what else? Liver disease as well. Now, the high density lipoprotein is a desirable value. Let's say greater than 60. It's really a desirable value that we should include in our patient teaching. So this can be beneficial for them. And of course, it's going to be increased whenever there is going to be a regular physical activity, or let's say a healthy diet with, of course, composing of omega-3 fatty acids, low trans fats, or if they're maybe consuming moderate red wine. And if the patient, let's say females, if they are undergoing the hormonal replacement therapy, they tend to have a much higher level of the high density lipoprotein, which is really going to benefit them around their age. Now, let's talk about the next diagnostic test. So we have here our fasting blood glucose. Now, we know for a fact that the glucose is a simple sugar found in the fruits. It could be produced during the digestion of the carbohydrates, and it can be produced from the liver's breakdown of the glycogen. And this is really going to provide the body its main energy source, and it's very important for the brain and the red blood cell to function from this food source. Now, the fasting blood glucose test will help us to, or will help the medical provider to diagnose diabetes, and also to determine if there is low blood sugar, or what we call as hypoglycemia. And of course, with this procedure, our teaching will be to tell the patient to fast for about 8 to 12 hours before the blood draw. And the patient that is diabetic should avoid taking their morning insulin, or avoid taking their oral medications until after the blood sample is taken. Okay, so that means that their blood sugar levels will be at its baseline. There's no influence of an oral hypoglycemic drug or any insulin. Now, let's take a look here about the value of the fasting blood glucose. It's normally at 70 to 99 milligrams per deciliter, or 3.9 to 5.5 milliosmoles per liter. Now, we know that the blood sugar, the fasting blood sugar, will be decreased whenever there is Addison's disease. We know that there's a lack of the cortisol, right? This can lead to a decreased blood sugar. And if there is liver disease, also with hypothyroidism, if there is insulin overdose, pancreatic tumors, or a pituitary problem, or it could be the post-dumping syndrome. These are things that will be associated with a low blood sugars. Now, whenever there is an elevation of the blood sugar, this could be attributed to stress, because we know for sure that stress can increase the blood glucose through the stimulation by stimulating the liver to produce more glucose and reducing the effectiveness of the insulin. In cases wherein it would be a brain injury, wherein it can affect the hypothalamus or the pituitary gland, and this can disrupt the normal regulation of the hormones that can influence the blood sugar, and this can lead to the hyperglycemia. And also in the case of a Cushing syndrome, which is the overpopulation of the cortisol, we know that this is a hormone that increases the blood sugar by promoting the gluconeogenesis. Now, of course, we have the diabetes and hyperthyroidism, which will increase the metabolism rate, and this can lead to higher energy demands, and this can cause the liver to produce more glucose in return. Now, another is a pancreatitis, or let's say pancreatic cancer. This can also impair the production of insulin. And most often, you will see a spike of their glucose levels whenever a patient has this pancreatitis, either acute or chronic type. Now, this time, we will talk about the glycosylated hemoglobin, or known as the HbA1c. And this is a test referring to the blood sugar attached to the hemoglobin. Now, this is going to give us an idea how well the blood sugar has been controlled by a patient over the past 3 to 4 months, because this is actually attached to the hemoglobin of the red blood cell, right? And this is the red blood cell actually has that lifespan. So all the in the past 3 or 4 months, we will know for sure if the patient has been compliant with a medication prescription, let's say insulin therapy, or it could be the oral hypoglycemic, or maybe if they are not compliant with a diet, we will know for sure if there is if they're not really adhering to the prescribed regimens. Now, what do we need to do as part of this test? Well, there's no preparation, no fasting required. And here you'll see the value. So normally the HbA1c should be less than 5.7%. That is the desired value. Now, for a 5.7% to 6.4%, this signifies that this patient could be in the pre-diabetic stage. However, if the value is greater than 6.5 or more, then this is gonna, it's considered that the patient is already in the diabetic stage, right? They already are diabetic. Now, the glycosylated hemoglobin levels could be influenced as well. So it can be lower in numbers if there would be chronic blood loss, or maybe a chronic kidney disease. We know that in kidney disease, there is going to be a lack of red blood cell production. The bone marrow is going to be the target site for that erythropoietin, which is the hormone generated by the kidney. So if the kidney is failing, then it's not going to be able to produce much of that erythropoietin to target the red bone marrow to produce the red blood cells. Now, another is the pregnancy, also sickle cell anemia. These are things that you need to keep in mind to see a possible drop in the hemoglobin A1C. Now, we are going to expect elevation of the HbA1c whenever there is poorly controlled diabetes, or let's say a non-diabetic type of a hyperglycemia. Now let's move forward into the next laboratory study, and this is all about the renal function study. So I really want you to draw your attention about this because this is something that can be used in a lot of case scenarios. You think about the two main testing here. We have the serum creatinine, which is the key marker of kidney function. And as you see here, our values between the male and the females vary. And for the males, adult males, the value ranges from 0.6 to 1.2 milligrams per deciliter, and 0.5 to 1.1 milligrams per deciliter for the females. Now, this time, what are we going to do to prepare this patient before the blood draw? Well, they should avoid intense exercises for at least 8 hours before the blood draw. And then they need to limit the intake of red meat for at least a day or 24 hours before the testing. So it will not influence the baseline creatinine levels. Again, your preparation, the patient should be prepared by avoiding intense workout or exercise and avoiding increased intake of the red meat for at least 24-hour period. Now, the creatinine level can be decreased whenever there's going to be a muscle dystrophy and if there is myasthenia gravis. However, the value of your creatinine can be elevated whenever there is severe kidney disease. So that's why this is one of the lab values that will be looked at if our patient is suspected of undergoing or if they are leading into an acute kidney injury. Now, another testing that you should look at would be the blood urea nitrogen. And as you see here, the normal value should be at around 10 to 20 milligrams per deciliter. We know that the blood urea nitrogen, it's going to measure the nitrogen in the urea, which is a product formed during the protein breakdown in the liver. And the urea is usually filtered by the kidneys, and with some being reabsorbed and the rest excreted in the urine. And of course, thinking about both creatinine and the blood urea nitrogen, this should be checked together to assess the kidney function. Now, take note here that burns can also cause a drop in the blood urea nitrogen level. Same thing with the dehydration, gastrointestinal bleeding, also increased protein breakdown, kidney. Actually, this is going to be the exact opposite. So basically, the burns can, the dehydration, the GI bleeding can also lead to the high levels of the blood urea nitrogen. Okay, so the blood urea nitrogen can be decreased in cases whenever there is a fluid overload, if there is malnutrition, if there is severe liver damage, or let's say a syndrome of inappropriate antidiuretic hormone. So these actually belong to the higher levels, not under this column. Okay. Now, let's move on to the next section of our discussion here, which will be all about the white blood cell count. So we know that the white blood cell count is part of the body's defense mechanism, right? And the white blood cells will really show the different types of the white blood cell components, right? And if we are going to encounter a term, let's say, a shift to the left, it simply means that there's going to be more immature neutrophils that are present in the blood. So let's take a look into the normal value of the white blood cell count, which is 5,000 to 10,000 per cubic millimeter. That is the range. Anything above that is not a good sign. It could mean that there is inflammatory process, or if there is an infection going on. Anything below the 5,000 could mean that there is maybe a problem with the immune system. The body is not really able to produce the neutrophils or the white blood cells because of a bone marrow depression. Now let's talk about the causes of the low levels in the um, white blood cell count. Now, this is going to be decreased whenever there is aplastic anemia, or if there would be autoimmune diseases, if there is severe infection, or if there is, in a case whenever the patient is taking chemotherapy, or if they are um, having radiation treatments. However, the white blood cell count can be elevated whenever there is inflammation, infections, and also leukemia. Now, let's talk about some terms that, like I have said earlier, about shift to the left. What is that shift to the left? This is basically pertaining to a more immature neutrophils that are present in the bloodstream. Now, there's also two different differences, or there are two types of shifting to the left. The first one that we know of is the um, low WBC left shift. So, what is this? This is basically suggesting that the patient is either recovering from bone marrow suppression, or maybe they're just recovering from a severe infection that used up their neutrophils faster, then the bone marrow can release them. Okay, so this is what we call as a low WBC left shift. However, there's also what we call as high WBC with a left shift. This simply means that the bone marrow is releasing neutrophils rapidly in response to a serious infection or an inflammation. Again, your high WBC left shift, there is a rapid release of the neutrophils in the bloodstream because of an infection or an inflammation. Now, um, whenever there is going to be an increase in the neutrophils, it typically will signify that there is bacterial infection. Okay, so think about that. Now, another shift is what we call as the shift to the right. So, what is this? This simply means that WBCs have more nuclear segments, often seen in people with a liver disease, or if they have a Down syndrome, or maybe a megaloblastic and pernicious types of anemia. So, this is, or these are the conditions that can lead to that shifting. Now, let's move forward into our discussion about nutrition. Now, here, we need to really understand this because even though we have the background on the laboratory values that will indicate a person's nutritional status, it is very important for us to also explore the different macronutrients that would play a vital role in maintaining their health. And so we'll have to talk about the carbohydrates, the fats, and the proteins as well. Now, we'll talk about the carbohydrates. We know that this is the main source of energy for the body. And 1 gram of the carbohydrate will give the body 4 kilocalories of energy. That's basic information, right? And we know that the carbohydrates can help regulate with the fat metabolism. It can also help with the brain function. It will help fuel the brain and the muscles during physical activity. And this is going to assist in the production of the red blood cells and the white blood cells. And the carbohydrates can be found pretty much with milk, let's say grains, fruits, vegetables, of course. These are our major sources of the carbohydrates. Now, transitioning into the next nutrient would be the fats. We know that a gram of fat is equivalent to about 9 kilocalories of energy. And the fats are actually a concentrated energy source, and it can be stored for later use. And it is responsible in protecting the body organs. It can regulate the body temperature as well. It can help in the absorption of fat soluble vitamins, especially the A, D, E, and K. And if there is going to be a problem, let's say a deficiency of the fat intake, or if there is just plainly a fat deficiency, then it can lead to these problems or sensitivity to the cold. It can lead to skin problems, could potentially predispose the patient to different infections, and it can lead to some menstrual issues as well. Now, for conditions whenever there is way too much intake of the fats, right? This can also lead to the obesity. It can lead to heart attacks, heart disease, and also cancer. Now, let's talk about the proteins, which are actually made up of amino acids. And this can give us at least 4 kilocalories per gram. And here are the following functions. It can help with the growth and tissue repair. It can also assist with maintenance of the fluid balance, the acid-base balance, and it can also help produce energy. Same with the enzymes, the production of hormones. And for us to make sure that our patient is um, getting enough nutrition, they need to at least have the essential amino acids, which actually would come from the diet and that the body cannot really produce, right? However, whenever there is a deficiency of the proteins, it can lead to the muscle wasting, malnutrition, and also some issues with pharmacological treatment. There can be some toxicities can happen if the patient will have low albumin levels. Now, this time we will talk about the vitamins. We know that vitamins can support the metabolism and they're going to act as catalysts for the body's processes. They're also going to be helpful in the promotion of the growth. They're also going to be helpful in most of the bodily functions. And here, we're going to have to differentiate the different types of vitamins. We got the water soluble and the fat soluble vitamins. Now, let's talk about the water soluble vitamins first. There's plenty of them. So, here are the water soluble vitamins we got in from vitamin B1, 2, 3, 6, 9, 12, and also letter C. Now, we know that the water soluble vitamins are not stored in the body and they can be easily excreted in the urine. Okay. Now, take note about the corresponding names of each vitamin. We got thiamine, which is pretty rich in food sources such as pork, could be nuts, whole grains, could be legumes. Vitamin B2 or riboflavin is abundant in milk. We got lean meat, we got fish grains, and we also have the niacin, vitamin B3, which is abundant in meat, poultry, fish, beans, peanuts, and also grains. We have pyridoxine, which is the vitamin B6. This is abundant in yeast, corn, meat, poultry, and fish. And folate or folic acid or vitamin B9, this can be found mostly in green leafy vegetables, liver, could be beef, fish, legumes, and grapefruits, or it could be oranges as well. And then we have the vitamin B12 cobalamin, which can be found mostly in liver or meat products. Now, vitamin C can be found in so many food sources, and one of those would be the oranges, citrus fruits, tomatoes, broccoli, cabbage, uh, and also watercress. Actually, it was so surprising about that discovery that watercress actually is very high in vitamin C, much higher than the uh, the tomatoes, right? Now let's talk about the fat soluble vitamins. These are your A, D, E, and K. So for the vitamin A, this is going to be abundant from dairy products, fish, liver, green, orange, vegetables, fruits. For the vitamin D, this can be found in fortified milk, fish oils, cereals. And vitamin E, this is going to be uh, very abundant in vegetable oils, margarine, fruits, vegetables, nuts, seeds, also cereals. And lastly, we got the vitamin K that can be found in green leafy vegetables, cruciferous vegetables, could be the oils like soybean, canola, and olive. So I really want you to go back and familiarizing or refamiliarizing these food sources for each vitamin. Now, this time we're going to talk about the malnutrition markers, and they are very critical in the assessment of our patient's nutritional status. And they're going to help us in identifying those nutritional deficiencies that may contribute to the overall health decline. And so for the hematological studies, we got there the complete blood count, which is very essential in differentiating the types of the anemia our patient may be having. And this can specify if they are having the iron deficiency type of anemia, or maybe if they're having the vitamin B12, or let's say the folic acid deficiency. So it's really important for us to look into the differential counts under the complete blood count. Now, another is when we are going to look into the malnutrition markers through the proteins, okay, we are going to do this because this will give us a better insight into the patient's protein status. And so part of that is to check for the protein or short-term protein levels. And this is something that can be assessed through obtaining their pre-albumin levels, the transferrin level, or the retinal binding protein, and also the creatinine and the blood urea nitrogen levels. Okay. Now, in order for us to determine the long-term protein levels, this is going to be measured through obtaining the albumin information through that blood sample. Now, for us to determine the nitrogen balance, this is going to be determined by the urine urea, and this is going to detect if there is going to be loss of proteins through the urine. Now, this time we will talk about the therapeutic diet. So hang tight. This is going to be a bit lengthy, and we're going to review about the different diets that will be indicated for the different conditions. Now, the first diet that we'll talk about is the clear liquid diet. And this is a very common diet that can be seen in most patients. This can provide the patient some fluids, right? And it can provide some electrolytes to prevent the dehydration. This is something that can be ordered for those patients as a rest for their bowel, or let's say after surgery. So when a patient has completed a surgical procedure, they need to kind of like gradually be transitioned from this kind of diet, from a clear to a full to a soft diet, before they're going to go back to their routine diet, like let's say regular, right? And so the other reason is to prepare the patient for a bowel procedure, maybe. Okay, so from, let's say, for example, having a regular diet or a carbohydrate controlled diet for lunchtime, and if and whenever they have a procedure, let's say a colonoscopy the next day, the lunch, the patient who had a lunch of the consistent carbohydrate diet will then be transitioned into a clear liquid diet for the evening, and then they're going to take the bowel preparation medication in order to yield a clear output throughout the night in order to prepare for them, to prepare them for the colonoscopy procedure. Now, let's talk about the allowed food items here. We have the water, broth, tea, clear juices, and gelatin. So these are food items that are considered to clear, right? Of course, this is something that will allow you to see across the what do you call it, the liquid. It's not going to be cloudy. You can see through the liquid when it's considered to be a clear liquid. Okay. Now, the next diet that we should know about is the full liquid diet. And this is going to be used to transition a patient from having a clear liquid after a surgery, or for those who have any problems having a difficulty chewing, or let's say difficulty swallowing any food items. Now, this is a diet that can include those clear and opaque type of liquids. This will include the milk, yogurt, soups, but we know that these food items really would lack many of the nutrients. Now let's transition into the mechanical soft diet. So what is this? This is something that can be ordered for those patients that may have probably issues with dysphagia, or if they have poor dentition. They're not going to be able to chew much with harder textures. And what you're going to expect here are those mashed potatoes, or let's say mashed vegetables, ground meat, and soft fruits, anything that can be easily swallowed. However, in the mechanical soft diet, we're going to restrict the intake of raw fruits and vegetables, nuts, and tough meats. So remember that. Now, moving into the soft diet. So, what is this? This is going to be used for those patients that also have a swallowing difficulty or chewing difficulty, or if they have any problems with their gums. Now, the food items that will be allowed here are your pasta, cooked vegetables, tender meats, and we're going to restrict the raw fruits, fried foods, and nuts. Now, the next diet that we're going to know is the low fiber, low residue diet. So, this is designated for those patients that have intestinal inflammation. Maybe they have scarring, or let's say if they have slow motility. And this can allow those refined bread, could be rice, cooked potatoes. However, in the low fiber, low residue, we're going to limit the intake of dairy, also limit the intake of raw fruits and whole grains, because these are items that are rich in fiber, right? Now, moving into the exact opposite here, we have the high fiber or high residue diet. And this is something that can be ordered for those people that may have constipation or inflammatory bowel disease, or if they have diverticular disease. And you're going to expect here that your patient will be consuming lots of fruits, vegetables, whole grains, and what can be done here in order to not abruptly cause changes into their system. We can gradually increase the intake of fiber and also the fluids in their diet to avoid bloating or cramps. Again, take note, we need to gradually increase our intake of these food items to prevent bloating and cramping. Now, let's head into knowing the cardiac diet. So, this is something that is recommended for those people with atherosclerosis, if they have diabetes, high cholesterol, or let's say they have high blood pressure, if they have a heart attack, kidney diseases, and this will also help reduce heart disease risk. Now, in the cardiac diet, it is going to promote the DASH diet, which is dietary approaches to stop hypertension. And this is really going to control the high blood pressure, control the cholesterol, and also control the incidence of obesity. Now, in the DASH diet, it will consist of fruits, vegetables, mostly whole grains, low fat dairy, lean meats. It can also limit sugar and the intake of red meat, salt, and fats. So, most often here in the cardiac diet, this is going to consist more about the plant-based, which can really decrease the incidence of the heart disease. Now, also in the cardiac diet, please take note that the sodium, the cholesterol, and all types of fat will also be limited around this time, especially the saturated fat. And we need to educate our patients about the DASH and the limitations in order for them to a much more regulated lifestyle. Now, let's talk about the fat restricted diet. So, what is this? Of course, this is something that will be indicated for those people that may have a malabsorption syndrome, if they have pancreatitis, gallbladder disease, GERD. And this is a very big deal, especially for pancreatitis. We know that whenever there is pancreatitis, it's really going to cause that inflammation of the pancreas. This is the autodigestion. So if there is such a high presence of fatty food, this can cause more workload for the pancreas in order to digest the fatty foods, right? And so this is something that the fat restricted diet is going to be beneficial for this patient. Now, this is something that these food items will be restricted, especially for those high fat containing diets. So, what we're going to expect here will have, they're going to have to make sure our role here is basically to limit all types of fat, and we want to make sure that we're going to monitor for the vitamin and mineral deficiencies, especially when they're having the malabsorption issues or let's say diarrhea. And another thing that we need to incorporate in the care of this patient with a fat restricted diet is to also make sure we have that fecal test, which can check for any fat malabsorption. Now, we also have the next diet, which is the high calorie or the high protein diet. And this is something that will be beneficial for those people with severe stress, burns, wound, cancer, COPD, and also respiratory failure. They're really going to need a lot of nutrients to compensate for the body demands, right? And so our patient will be allowed these food items: so milk, butter, peanut butter rather, meat, eggs, snacks, and supplements. So these are things that are going to be beneficial for them as well. Now we'll transition into the next set of therapeutic diets, and we'll talk about the carbohydrate consistent diet. Now, with this is very important to have when we are trying to manage a diabetic patient if they're probably experiencing hypoglycemia or if they have obesity. Here, we need to focus on the consistent daily intake of carbohydrate, fat, and protein. So, making sure that we are doing the carbohydrate counting in order for us to maintain a much more regulated intake of all the nutrients, right? And so when we are promoting the carbohydrate consistent diet, what it mostly consists will be a half of the plate will be about starchy, non-starchy carbohydrate rather, and then that's going to be composed of vegetables, and a quarter of that plate will be about lean meat, lean protein, and also a quarter of that will include the complex carbohydrates. Now, for this patient that has the diabetes, they can also be allowed to drink water or a low calorie drink. Now, moving into the next therapeutic diet is your sodium restricted diet, which is going to be used for those patients managing their hypertension if they have kidney or liver disease. And here we are going to limit their intake to about 1.5 to 2.3 grams of sodium per day. And what we're going to encourage here will be the intake of fresh foods over processed foods. We know that processed foods are rich in sodium nitrites. Now, we are going to have to teach our patient about real food labels. Reading those labels, because so much of these food items that are found in the stores are actually containing sodium. Okay, they do have a lot of sodium content to preserve these food items. Now, the next therapeutic diet we have is the protein restricted. So what is this? Of course, this is something that will be indicated for those patients that may have a kidney or liver disease. And this is intended to provide the patient enough protein to just maintain health. But this will prevent the buildup of the metabolic waste. So what is going to be focused here is to provide a high quality set of proteins, and also to provide them enough calories from other foods. And these are the things that can be allowed in their diet: high quality proteins. There's going to be special bread or pasta. Now, it is very important for us to also calculate the protein that can be found in the fruits and also vegetables. Now, moving forward, we also have the gluten free. So that's actually gluten free. Let me correct that real quick. So that is gluten free diet. So, what is in a gluten-free diet? Well, of course, this is indicated for those patients that have celiac disease or if they have gluten deficiency, and they need to avoid those gluten-containing food items. All right. So, next is the renal diet, and this is indicated for those patients that may have a kidney disease or if they are undergoing dialysis. And what is going to be allowed here? They're going to be allowed low sodium, low potassium diet, low phosphorus, and also moderate protein. So please take note about the components here. Now, next is the potassium modified diet. So this is pretty much dependent on what the patient's level of potassium is. So if in case the patient has uh, high potassium, if they have hyperkalemia, so what's going to be done to them is to have a or low potassium diet. However, if they have hypokalemia, then they're going to have a much higher potassium intake in their diet. Okay, so it's going to be vice versa. Okay, so you have allowed diets increasing potassium in the diet or also decreasing their potassium in the diet. Now, next is the high calcium diet. So this is something that can be beneficial for those patients that may have some issues like osteoporosis, or if they have any problems regarding their bones, they need to at least be allowed to take in dairy, calcium rich food items. Um, and this is also going to allow the DASH diet. Okay. Now, take a look into the low purine diet. So what is this low purine diet? This is indicated for those patients that are managing gout, if they have kidney stones, if they have high uric acid in the blood, then they're gonna get the benefit of this type of diet. Now, what kind of food items or restrictions that should be included in the low purine diet? So we're going to restrict those food items such as the fish, organ meats, gravies. These are really high in uric acid, or a purine rather. And so these are things that should be avoided. Now, take a look into the high iron diet. So what is this? This is something that can be indicated for those patients that may have iron deficiency anemia. So what's the food item, or what are the food items that can be allowed to this patient? Well, they're going to be able to take in lots of meat products, dark leafy greens, legumes, because these are rich in the iron content. Now, we also gonna have to talk about the vegan and a vegetarian diet. So when we are talking about these type of diets, it can be into different types. So as you see here, strictly vegan simply means that there's no animal products in their plate, right? However, if they're considering themselves as lacto-vegetarian, they can allow dairy in their meals. If they consider themselves as lacto-ovo-vegetarian, it can include some dairy and eggs. However, just ovo-vegetarian, this simply means that they can only include eggs in their diet. Now, what are the considerations about the vegetarian diet? Well, make sure that they are taking adequate amounts of protein, also vitamin B12, iron, calcium, because we know that plant-based products really don't have enough of these sources, or they don't really supply the body enough of these contents. And so they're going to be prone to the deficiencies of the vitamin B12 type of they're going to end up with a vitamin B12 anemia, or let's say iron deficiency anemia, or let's say they're going to end up with some calcium deficiency if they're going to strictly just adhere to a vegan type of diet. So make sure that they're going to be have some supplementation in order to balance their nutrition. Hi, everyone. Welcome back to another day of our lecture for the NCLEX review. We will be continuing our discussion about foundations of care, and I'll be talking about physical and health assessment today. So this will be part 1 of 2. Now let's get started. So when you're actually going to start the health assessment, you have to make sure that you're going to have to start something with a mental status exam, and you got to pay attention to the patient's appearance. When you're going to do this, you have to take a look into their posture, their movements, the kind of clothing that what they are wearing. Is it appropriate? Their grooming and also their hygiene. This is something that can give you an idea how well kept they are. A poor hygiene can definitely indicate some mental health issue as well. Now, for the next item that you should think about will be the behavior of our patient. So you need to assess the patient's alertness here, their facial expression, the body language, their speech pattern, and also their orientation. You need to test if they know the current time, the place where they're at currently, and also the person, if they know their name, right? Now, we need to also check for their memory. You got to monitor, or you're going to have to assess if they have intact shortened memory or the recent events, or maybe they have issues with past experiences. So this is something that you can also determine during the health assessment. Same thing with the new learning. You're going to have to ask them to test their memory, to recall by asking the patient to remember unrelated words after time intervals. And same thing with their judgment. You need to assess here if they are able to make decisions, or to assess if their decision is going to be realistic. Now, another thing that you need to keep in mind is to check their thought process as well in order to ensure that their thinking is logical and reality based. So please take note about this one. Now, what are those assessment techniques? And you probably had known this before, but we'll just breeze through with the following. So we know that the first technique is what we call as the inspection, right? This is going to require the use of our vision, our sense of smell to observe the patient. And we're going to have to, of course, use proper lighting and also use some devices, maybe an otoscope or ophthalmoscope as needed. We're going to have to check for the patient's probably extremity. We're going to use the touch to palpate, to check for the patient's skin, assess their texture, the skin temperature, if there's any tenderness. That's also part of the palpation. Now, we generally start with a light palpation, and then we're going to have to proceed with a deeper palpation as we go along. Now, the next assessment technique is the percussion. We are going to need to use our fingertips to tap on the skin or probably other body areas to check for the underlying structures. We're going to have to check if there's any excessive presence of air, if there's fluid or maybe masses, and the characteristic of the sound that is produced. Maybe it's becoming more hyper-resonant, or is it more dull this time? Now, the last one that we know of is the auscultation. We're going to have to use the stethoscope to evaluate the sounds of the heart. It could be to check for the lung sounds or the bowel sounds, to make sure that we're able to decipher the quality and also the function of that specific body organ. Now, this time we'll talk about the integumentary system. This is generally the first thing that we can easily observe as soon as we encounter this patient that we just have met. Maybe a new patient just came into that particular practice, or maybe this is a new patient to the hospital. Now, what do we do when we are actually checking the integumentary system? This is going to require us to check into the skin, the hair, the nails. We're going to have to use our sense of sight or vision, and we can also use our sense of touch in order to assess that. Now, especially for the dark-skinned individuals, this is something that would be more challenging if you're not really familiar with the assessment. If there's any color changes, and if they are dark-skinned somewhat, it's kind of be challenging, okay? So these are the things that we're actually going to have to do with the dark-skinned people. If in case they have a cyanosis, what we're going to look for here is to look for some grayish color of the lips, could be the tongue, the bluish discoloration of their nails, the palms, the sole, or could be there's going to be pale conjunctiva. Now, to look for any kind of jaundice, what we're going to look for here is to check for the lining of their mouth and the yellowing of their sclera, their eyes. Now, if you are suspecting for any kind of bleeding, what we're going to look for here is to check for any swelling, any darkening of the skin. So it will be further darker, and we're going to have to compare both extremities from one side to the next, right? And another thing that we need to also check is for the inflammation. We're going to have to feel for any warmth. We're going to have to inspect their skin and compare it to the unaffected side. Now, when you're going to be tackling or you're going to be taking care of this patient for the first time, what you're going to do mostly, before you're going to have to do your assessment, physical assessment, is to do these questions you're going to have to complete, asking them about possible self-care activities that they do at home, if they have any current skin diseases or maybe medications that they're currently using, Or are they exposed to any environmental hazards? Have they noticed any skin color changes recently? We're going to have to look for any moles, anything that could be concerning, right? Or could be sores that are not healing. So these are the things that you need to ask in your patient and make sure that you are verifying this. Okay. Now, aside from those, we're going to have to objectively uh, evaluate our patient for the bruising, the itching, the rashes, if there's any noticeable hair loss, maybe nail changes, scarring, could be edema. And part of our integumentary system check is to do the cap refill or the blanching reflex. This is very important, especially if we are worried about the circulation of our patient. Okay, now let's move on into um, the next part of our discussion, and this is going to be about the head, neck, and lymph nodes. So, what we're going to do here is to basically assess for the patient's head, right? And also follow that fashion from the head down to the neck into the lymph nodes. We're going to have to use our eyes to look for these abnormal color, or maybe if there's any abnormal turgor, or let's say if there's any mass. Those are things that we need to pay attention. We're going to have to do the listening as well, auscultation. Now, what are we going to do with the head part? What we'll look at will be the size of the head, any shape. There's also probably a need for us to look for any mass or any tenderness. What we're going to also do here is to check, feel for the temporal arteries and the sinuses for any tenderness. And we're going to have to ask our patient to move their jaw to test for the cranial nerve number 5. This is the cranial number 5, which is the trigeminal nerve, right? And so here, we can also check for the face, the symmetry of the face, if there's any swelling, if there is involuntary movement. Now, we will proceed with the neck assessment. We will also check for the symmetry of the neck muscles. Is there any symmetry or asymmetry from one side to the other? We'll check for the range of motion. Are they able to turn their head from one side to the next? Are they able to flex, or are they able to extend their neck? And part of that assessment is to palpate the trachea to ensure that it is midline, right? And another is to check for the thyroid gland, to check for enlargement. But you got to be careful here, especially if there is already obvious enlargement of the thyroid gland. You don't have to do depalpation here, because this can lead to escape of the hormones, can lead to the thyrotoxicosis. So you don't do that. Now, for the lymph nodes, what we're going to need to do here is to check for the growth, if there is enlargement of those lymph nodes. And the size of these lymph nodes should be less than 1 centimeter. They're usually not palpable. Okay. Now, what we're going to do here is to check by using gentle pressure. We're going to use the circular movements using our fingertips, and to feel for these lymph nodes. We're going to start from the ears, moving downward. We're going to have to palpate both sides, noting the size, the shape, and also their tenderness. Now, as we move along, we're going to have to check for the eyes. So we are going to have to do the inspection, the palpation, the testing, vision, and also with the use of a ophthalmoscope. But we're not going to include all those others. They're not usually asked in the NCLEX. But before you're going to proceed with eye examination, it is very important that you're going to do your interview first. You got to ask the patient about any visual issues. Do they have any blurriness? Are they experiencing any double vision? Is this new? Is this chronic? Are they experiencing any pain? Are there any discharges that they notice at home? Is there a need for them to wear glasses or contact lenses? Or are they using any medications to control the eye pressure? Do they need to use like eye lubricants, eye drops maybe? Or if they had any other eye history, did they have any surgical history in the past, right? So those are the things that you need to keep in mind. And as far as we're going to start with the eye assessment, especially when we are doing the eye exam, we're going to have to use the Snellen's chart. That's the commonly used device for the eye exam, right? Now, before you're going to have to really do before you're going to touch your patient, you can actually check the external structures for the patient just by vision, by visual inspection. You can do checking the symmetry of the eyelids. You can definitely tell right away if there is any ptosis or drooping of the eyelids, or maybe protruding or maybe sunken eyes. Um, yeah, are the conjunctiva clear? Are they yellowish? Is the sclera yellowish? Are the corneas smooth? Now, when we are going to proceed with the Snellen's chart, what we usually do here is to ask the patient to stand at least 20 feet away from the chart. And this is to check for their distant vision. Another thing that we can do is the near vision test. What we're going to do here is to use the handheld screener. We're going to give the patient a magazine, or let's say a book, to test each eye separately. However, if they have a pre-existing condition, they need to use the eyeglasses for the reading. The distance here is usually about 12 to 14 inches away from the eyes. And what we will usually see in the elderly population is that they're going to have the presbyopia. There's going to be blurriness in their vision when they're reading. Now, the next test that you should recall is the what? Near or the confrontation test. So what is this? The confrontation test is done using that cover to, you're going to have to instruct the patient to cover one side of the eye to test their peripheral vision, and we're going to have to compare the client's vision with the examiner. So just like here in our picture, you're going to stand opposite to each other, of course, and then you're going to use your fingertip to kind of move towards the patient's central vision, and then kind of moves away from the central vision, and to check if the patient can still see on the farther side. So you have to make sure that you can compare your visual field and the patient's. Okay. Now, another thing that you need to recall for the eye examination is the corneal light reflex. So what is this? You are going to have to check here for the alignment of both eye axes by shining that pen light and observing the reflection in both eyes. So let's zoom this in. So this is the normal alignment when actually you're shining the pen light. The appearance is that the reflection is actually going to be towards the middle, right? So that would be the expected one. However, if you're going to have the esotropia or the left eye, especially on the left side, so take a look at that. So there is that abnormality in the position of the patient's left side, and then we also have the exotropia. It's kind of like moving towards the lateral side. Okay, so this will basically be seen using that light reflex. So that reflection will actually towards the lateral side. Now let's go into the next testing here. We have the cover and cover test. So this is done this way. You're going to have to use that opaque material to cover one side first, and then followed by the next side. So you are going to test for any slight misalignment. You're going to have to cover one eye and observe the uncovered eye for any movement. So the problems that you will see here are we call this the strabismus, which is a constant malalignment of the eyes. And then there is also what we call as zoetropia, which is a specific type of a misalignment. And the next one is the esotropia, which is an inward turn of the eye. And we also have the exotropia, which is an outward turn of the eye. Now, this time we'll talk about the 6 cardinal position testing. So I hope that you can still recall these. So what you're going to do here as the examiner is to check for the 6 muscles controlling the eye movement by having the client follow an object. So you're going to test for the following, the superior rectus. So you're going to test for the upward movement of both eyes. Then you're going to also check for the superior oblique, which is the downward and outward movement. And we also have the lateral rectus, which is the outward movement. So both lateral rectus on each side. And we also have the medial rectus, which is the inward movement of each eye. And we also have the inferior oblique, which is the upward and outward movement. Okay. And then lastly, we have the inferior rectus or the downward movement. So basically what you're going to do here is to have the patient follow the movement of an object. You're going to have to instruct the patient to focus into that object while you're moving it right in front of him or her. Okay. Now let's move into the next testing here, which is the color vision testing. And so this is to determine the perception using that Ishihara chart to identify numbers and letters in color for images. So such as this one, this is 74. This is really going to check for color blindness. Now, another thing that you're going to have to do is the pupillary light reflex. So the normal direct pupillary response is going to be constriction. So as soon as you're going to light that pen light right in front of their into their eyes, then directly you're going to see that constriction. Okay, that is expected when you are going to light that pen light. However, if just in a normal ambient light, the size of the pupil will be kind of midway. However, if you're gonna turn off the light and you're just kind of like looking into the size of the pupil, you're not going to use the pen light around this time. You just kind of like take a look into the size of the pupil. It will dilate. Okay. Now, talking about the problems about the pupillary reflex, there is what we call as the mononuclear blindness that you can detect when the light is directed to the blind eye and it results in no response in either pupil. There's no reaction. So this is what we call as mononuclear blindness. And so when the light is directed into the unaffected eye, both pupils should constrict. So that is our expected finding. However, if there is mononuclear blindness, there's no constriction. Now, another testing that you should recall is the consensual pupil response or reaction. So what is this? When you're shining the pen light into one side, this will also cause constriction of the other pupil, right? And vice versa. Again, this is to check if there is maybe blindness in one side or not. And another thing that you need to do is the test for accommodation by having the client focus on both distant and near objects. So this is going to we're going to require you to use maybe a pen or a pencil, kind of move further away from the patient, or maybe ask or have you're going to have to position that object to move closer into the patient's central vision. So this is to test for the accommodation. So what will be seen here is that there will be the normal response here is there will be constriction when the object goes closer to their visual field, and there will be convergence of the eyes. Again, when the object gets closer to their visual field, there is constriction of the pupils. There's also convergence. Okay. However, if there is no constriction and there's no convergence, well, it simply means that their pupillary response is abnormal this time. Now, when you're doing the eye assessment, especially with the use of the pen light, remember that acronym PERLA, which is pupils equal, round, reactive to light, and accommodation. So these are the steps that you should be doing in order to attain a perfect assessment of your patient's visual acuity or visual function. Okay. Now, let's move forward into our next section, which is the assessment of the nose, the mouth, the throat. And here, we definitely need to start with asking our patient about any issues like nasal discharge. Are they experiencing any nosebleeds, sinus or facial pain? Are they experiencing frequent colds, changes in their smell, anosmia maybe, if they are experiencing recurrent allergies or seasonal allergies, and the kind of medications that they are currently using. And it's something that we need to collect as well in order that we can investigate further if there's any issues. Now, we need to also investigate if there's any history of nasal trauma or any surgical procedures that they may have in the past. Now, for the mouth and throat, we are going to have to ask them as well regarding any sores that's troubling them, maybe lesions, gum bleeding, if there's any change in their taste, toothaches maybe, if they are using currently any dentures, their oral hygiene habits. Are they currently smoking? Are they taking alcohol currently? Or are they having any history of infections or injuries or surgical procedures in the mouth? So these are other important aspects that you need to collect before you're going to do your physical examination. Now, as far as the objective data, this is something that you can do in a fashion manner. We're going to start with the external part of the nose. So you're going to have to check if it is centered, if it's proportional to their face. We'll check for their patency of the nose. So you're going to test this by testing by occluding one nostril one at a time and have the client sniff through the other. So you're going to have to use those maybe a vial of a coffee, ground coffee, or maybe those usual odors, okay? And make sure that when you are testing the patient, they have to close their eyes so they'll not be able to cheat during the examination. Now, a nasal cavity is something that you also need to be checking, all right? So here, the patient will be, you will be checking the cavity by using that nasal speculum and also the pen light to check for any swelling, to check for discharge, if there's also bleeding, any presence of foreign objects. And the most important thing here is to really check for any septal deviation, okay? Now, as far as the sinuses, what we can do here is to press the frontal sinuses below the eyebrows and also the maxillary sinuses below the cheekbones. And the client should feel the pressure, not pain. Again, normally they should only feel the pressure, no pain. For the lips, what we can do here is to inspect for the color of their skin or the lips. The moisture, are they cracked? Are they having the lesions? Now, also take a look into their teeth. Check for a condition. The number should be white, spaced evenly, and free from any debris or decay. We also need to check for the jaw alignment, have the client bite down to check the upper and lower jaw alignment. We're going to have to also check for the gums. We'll look for the swelling, the bleeding, color changes, if there's any receding gums. And for a healthy gums or healthy set of gums, we're going to have to expect pink color, right? Now, another thing that you need to look for is the color of the patient's tongue, the texture of the surface. Is it moist? The top part of the tongue should be rough, and the other side, or the underside rather, is going to be smooth and shiny with visible veins. Now, another part of your mouth assessment is check for the buccal mucosa. We're going to have to inspect the inner cheek for color and also the lesions. It should normally be pink, moist, and also smooth, right? Now, next is to check for the palates. Here, you're going to have to use the pen lights. We will check the hard palate. It should be white and has that dome shape, whereas the soft palate will be light in color, light pink, and it should be smooth and also free from any defects, right? Now, another testing that you're going to be doing is to look for the uvula. So this is supposed to be centered, and it will rise when you're going to instruct the patient to say ah, and this is actually going to be testing the cranial nerve number 10, which is the vagus nerve. Another part of your testing is the testing of your throat, patient's throat. We're going to check for the color, the presence of the tonsils, check for any exudates or lesions, and when when there is a need for us to grade, we can do that from a scale of 0 to 4. 4 would be both sides are actually touching the midline, and this is going to put the patient at risk to their airway patency, right? Now, another is to check for their tongue protrusion. So what we're going to do here is to ask the client to stick out their tongue to test the cranial nerve number 12. That is to check for the hypoglossal nerve, and the patient should normally be able to extend the tongue at the midline. And then lastly, the gag reflex, we're going to have to gently touch the back of their tongue, or throat rather, with the use of that tongue blade. And this should elicit that gag reflex briefly. And this is going to check the cranial nerve number 9 and also the glossopharyngeal nerve. Okay, take a look at those. Gag reflex. Now, moving into the assessment here, we have to do our check onto the lungs. But before we proceed, we're going to interview our patient if there's any current issues with coughing, if there's any sputum production that is kind of like progressing. Are they coughing up a lot more? Are they having any shortness of breath? Do they have any chest pain when they take a breath? If they have any history of cigarette smoking. And this is going to be very important. When they say that they have any history of smoking or they currently smoke, you're going to ask them about how many years have they been doing this. So you're going to calculate the pack years by asking them how many packs per day and the number of years that they have smoked. So this is a very important piece of information that you should gather, that you should also relate to the medical provider. Okay. Now, another thing that we need to ask is about their exposure to environmental hazards, maybe their occupation, maybe they have been a construction worker, maybe they have been exposed to asbestos, or any other environmental hazards. These are things that we need to investigate. You're going to also ask about their current medications that they're using, that prescriptions over the counter, if they have any history of respiratory illnesses or any surgical procedures in their respiratory system. So these are things that you should investigate first. Now, let's talk about the lung examination. So you see here that you will be doing the inspection and palpation. So very important when you do your inspection, you will have to take note about the skin color, right? This is very important. The skin color is something that you can see right away. You got to check for the breathing patterns. Is the patient kind of dusky looking? Do they have that reddish skin color? Do they have some kind of like rapid, shallow breathing? Are they hyperventilating? Is their breathing irregular? These are things that you need to look at and pay attention to. Are they in a tripod position, which is a very common position in patients with COPD, right? We're going to have to check for any sternal retractions. Are they somewhat labored when they are exerting their breath? Are there any chest wall abnormalities? Do they have any funnel chest? We call as the pectus excavatum, and maybe a pigeon chest, or there is some kind of like pectus carinatum. Or for those people that may have emphysema, barrel chesting. This is what we call now as the 1:1 enlargement of the anterior posterior transverse diameter, right? So instead of having a 1:2, your patient's diameter is actually 1:1. So there is enlargement of the rib cage, which is a chronic condition. Very common in emphysema patients, chronic cigarette smokers. Now, another thing that you're going to do is to check for their breathing with the use of the palpation. We're going to have to use your palms of your hands to check for any tenderness, lumps, and we have here our checking for the fremitus. So what you're going to do here is to apply both of your palms on the anterior, posterior part of your chest of the patient, and then you're going to have them say 99, 99. And when there is increasing tactile fremitus, there is probably some pneumonia going on, or consolidation, or could be presence of a tumor. However, if there is going to be decreased tactile fremitus, this simply means that there could be a pneumothorax, presence of air in the cavity, or let's say they probably have a chronic obstructive pulmonary disease, or there is lung collapse. Now, let's go back just a little bit into the inspection. So part of our inspection is to determine the pattern of our patient's breathing. I forgot to tell you about the Cheyne-Stokes respirations, which is pretty much the regular pattern. This is characterized by the alternating periods of deep, also rapid breathing, and then followed by periods of apnea. And this is an indication of maybe a severe form of a congestive heart failure, or it could be a drug overdose, or it could be increasing intracranial pressure or renal failure. And then we also have the Biot's respiration, wherein the patient will have irregular pattern characterized by a varying depth and also the rate of inspiration or respirations rather. And this is going to be followed by apnea as well. And this is something that you can find in patients with meningitis or severe brain damage. Now, another characteristic breathing pattern is the Kussmaul's, wherein the patient will have that type of hyperventilation. Yes, Kussmaul's respiration is a type of hyperventilation. However, this is much more of a very rapid, it's deep and much more labored. And this is something that is quite seen more in a patient with a diabetic ketoacidosis, diabetes mellitus type 1. All right. Now, let's talk about the percussion. We are going to have to do this after you do your palpation. So what you're going to start here is to do the tapping at the top of the shoulders right here. And then you're going to have to percuss from one side to the next side. And you're going to have to compare the sounds over the lung fields. Normally, what you should be hearing will be the resonance. This is characteristic of a normal lung tissue. However, when there is going to be dullness, when you are tapping those areas, supposedly resonant areas, this is a sign that your patient probably has dense lung tissue. Maybe they have pleural effusion, they might have tumor. However, if there is excessive resonance or hyperresonance, this is a sign of emphysema. There is way too much air being trapped in the alveoli. Now, another is the auscultation. So you will be using the diaphragm of the stethoscope. You're going to have to listen to one full breath cycle. One cycle. You need to make sure that the diaphragm of the stethoscope is applied to that particular site. You got to stick around one full cycle. So you can do the auscultation to the front or the posterior side of the chest. Make sure that you're going to have to do the same fashion from top part of the chest downwards. Okay. Now, what you should expect here when you are auscultating, you're going to make sure that you're identifying if they have a normal or maybe adventitious sounds. Now, let's recall about what those normal breath sounds are. The vesicular sounds are supposed to be heard in the peripheral lung fields. They are known to be low-pitched, sounding breezy. They are going to be followed by the bronchovesicular, and they are going to be heard more rather, over the major bronchi. And if you're auscultating in the posterior side of the chest, this can be heard better on between the scapula. And if you are listening the anterior side of the chest, this is heard best in the upper sternum and the first and second intercostal space in the anterior chest. Now, the third normal breath sound is what we call the bronchial breath sounds. They are known to be high-pitched, harsh sounding. It sounds kind of hollow breath. And you should be hearing that it's clear. Okay, it's not accompanied by any kind of movement of fluid or something like that. It should be clear. Now, these are the sites that you should expect those different normal breath sounds. We got the vesicular breath sounds in the peripheries, and then we have the bronchovesicular sounds right next to the first and second intercostal space in the anterior chest. And then we have the bronchial sound, high-pitched sound that is mostly heard right on top of the upper chest. Okay. Now, when you're gonna hear bronchial sounds in the peripheral sides, that's not a good sign. That is abnormal. It simply means that our patient probably is having pneumonia because of the consolidation. So the sound is kind of like spread throughout the peripheral aspects of the lung field. So bronchial sounds is only considered normal when you are listening towards the upper side of the chest at the center. When you're listening for the the main bronchial stem, okay, not onto the peripheral side. Now let's talk about the adventitious breath sounds of the abnormal breath sounds. Commonly, we're gonna identify the fine crackles. These are high-pitched popping at the end of inhalation. So what you can actually hear is that, like, when you're gonna use maybe rub maybe your hair, you're gonna kind of like put it right next to your ear, you kind of rub it against each other. That's what it sounds like. That's the fine crackles. And this is common in pneumonia, heart failure, also asthma. However, if you have a patient that has a coarse crackles, this is low pitched. The sound is somewhat kind of like bubbling early in the inhalation, and this is very common in pulmonary edema. Now, the next abnormal breath sounds that you should recall is the wheezing sound, and these are high-pitched musical sound. They are mostly heard during the exhalation. This is signifying that there are narrowed airways, especially in asthma. We also have the rhonchi, which are low-pitched snoring sounds during the exhalation. So this is a finding, or this is common whenever there is airway obstruction, especially in the case of bronchitis. Now, lastly, we have the pleural friction rub, which is that rubbing sound during both inhalation and exhalation. And this is associated with the pleurisy. Now, guys, please don't forget that we still need to go through the, before we can actually go to the heart assessment, remember about those extra sounds like the egulphony, the bronchophony, the whispered pictoriloquy. Now, this is something that you're going to have to do as well. You're going to have to use your stethoscope to auscultate, right? So you're going to have to first to check for the bronchophony. What you're going to instruct the patient is to ask them to say 99, 99, 99. And when you are auscultating from those lung fields, normally the sound is muffled, okay? So this is what we call as the bronchophony. So the 99 is normally going to be muffled. However, if you have the egulphony testing, what you're going to ask the patient to do is to have them say E, 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 and it should sound like E. Okay. Now, if you're going to check for the whispered pictoriloquy, you're going to have to ask the patient to whisper 1, 2, 3, and the sound should be faint and it should be muffled. Okay. Now, let's proceed to the next system, which is the heart or the cardiovascular system. So before we're going to do that, we'll have to check, investigate first, asking them questions if they have any, if they're reporting or if they're experiencing current discomfort in their chest. Are they having any difficulty of breathing? Are they having any trouble with cough? Are they tired? Is there any swelling going on in their lower extremity? Is there any problem during the night, such as nocturia? Are they having any issues in their leg? Is there any pain behind their calf? The skin color. Those changes are very subtle cues that can actually help in your assessment. Is there any issue with their weight? Is there any significant weight change? Are they gaining weight too fast in a short period of time? You're going to have to investigate what medications that they're using. Are there any cardiovascular risk factors that you should know of? And also ask the patient about their family, personal medical history. if they have any other blood vessel issues. Now, moving into the heart exam, you are going to do your objective assessment through the use of palpation. You're going to have to do the tapping. You're going to have to listen using the stethoscope, right? And of course, starting with the inspection, what you can do here is to inspect, check for any check for any pulsations, I should say, especially in the left ventricle during a heartbeat, which may not be always visible. However, if there is a case of a heart enlargement, congestive heart failure, what you can actually feel is that there is that slight kick because of that, what do you call this, enlargement of the heart. So next is the palpation. So what you're going to do here is to feel for the apical pulse in the fourth and fifth space near the midclavicular line. And this might not be felt in obese patients. So what you can do here is to check for the apex, the left sternal border, and also base for any abnormal pulsations. And then you're going to have to proceed with the percussion. You're going to have to tap the chest for any to check for the heart borders and check for the heart enlargement. To also notice for the lung sounds, could be resonant, and the heart sounds are dull. So those are probable things that you might be observing in this patient. Now, as we're going to go into the auscultation, these are the specific areas to locate the different sites. So remember about that acronym APETM, APETM. So for locating the aortic pulse site, this is going to be located on the second right intercostal space. This is your A. Now, if you're locating for the pulmonic pulse site, this is going to be located towards the second left intercostal space, to exactly the opposite side of your aortic pulse site. We also have the Erb's point. This is located in the third left intercostal space, or LICS. And we have the tricuspid, which is located in the fourth left intercostal space. And then lastly, we have the mitral pulse site, which is going to be the fifth left mid-clavicular line. Now, when you are actually doing this check, you need to assess for the rate. Is this rapid? Is this very slow? Check for the rhythm. Is it regular or irregular? And listen to the heart and feeling for the pulse. Now, when you are listening for the pulses, take a look or take notice about the S1 or the lub sound and the S2 or the dub sound, and find out if you can hear any extra sounds or, let's say, murmurs. And this is the time that you're going to do your assessment, grading of the murmur. So you're actually going to do that as well. So grade 1 is considered as very faint. Let's go back real quick about what causes the murmur. Well, murmurs are actually going to be caused by that turbulent flow of the blood, especially if there is an issue with the heart valve. Maybe there is stenosis, or maybe the valves are now incompetent. They are not able to close fully when that part of the chamber is already, if it has already received the blood, if there's incompetency of those leaflets, if they're not going to be able to close fully, then it could allow the blood to go back up into the previous chamber. So those are the things that you are going to find out. So again, grade 1 is very faint, whereas grade 2, this is considered as faint but recognizable. We also have the grade 3. This will be loud but moderate in intensity. We also have the grade 4, which is loud and accompanied by a palpable thrill. And we also have a grade 5. This is sounding very loud and associated with a palpable thrill, plus audible, of course, with the stethoscope partly off the client's chest, right? And then we have grade 6, which is basically extremely loud, and this can be heard with the stethoscope slightly above the client's chest and also accompanied by the palpable thrill. Now, as we go along, we're going to have to also assess for the peripheral vascular system. And so take consideration into the legs or let's say the lower extremities, the ankle, the legs. And so here are the different scales, right, of our checking for the edema. So you have the 1+, 2+, 3+, 4+, and each of this has a corresponding depth. So for the 1+, that's about 2 millimeters deep. For the 2+ edema, that's about 4 millimeters deep. And then for the 3+, that is 6 millimeters deep, and 4+, 8 millimeters deep. And so we'll go along with this first. And so the 1+ edema is basically considered as slight pitting. There's no visible distortion. It can disappear rapidly after you exerted that. If after you have placed your finger, it will disappear. It will go back to its original position. However, when you're gonna see +2 or 2+, this is going to cause a somewhat deeper pit than +1. But again, there's no readily detectable distortion. So it will also disappear in 10 to 15 seconds. Okay. Now for a 3+ or that 6 millimeter deep, there is going to be a very noticeable deep pit that may last more than a minute. It's going to be dependent. The swelling is much fuller, and this is going to be the swelling will last longer throughout the day. Now, for 4+ edema, this is considered as very deep pit that can last as long as 2 to 5 minutes when you are palpating that leg or foot. And the dependent edema or the dependent extremity is grossly distorted. Now, along with that assessment of the swelling, what you're also going to do here is to check for the pulse in the distal extremities, let's say the dorsalis pedis, or let's say the posterior tibial pulse. You're also going to check for the posterior tibial pulse, dorsalis pedis, popliteal pulse. These are the areas that you're going to focus on, especially if there is extensive peripheral artery disease in this patient. Maybe they have some issue with diabetes. If there is a complication, maybe some gangrene going on in their lower extremity. So these are things that you are going to have be the skill that you're going to be using in the cardiovascular system should be utilized to assess this patient with those complications. Now, while we're also going to do assessment is the breast tissue and the chest. So before we're going to proceed with this, we definitely need to do the interview first. In your subjective assessment, you're going to ask them about pain, if they are experiencing any lumps, swelling, nipple discharge, if there's any family history of breast disease, if they have any trauma, maybe they have surgeries, and if they are currently doing self-breast exams or if they have undergone the mammograms as prescribed, okay? Or any surgical procedures that they might have already. Now, to complete this assessment with the breast and chest, again, you're going to do your inspection first and do your palpation. And then also, what we do here first with the inspection. So what you're going to do what you're going to instruct here is to tell the patient to raise their arms. You're going to tell them to press hands to the hips, and just like that. And also to lean kind of forward to check for the symmetry of the breast, to check for the size, to check for any lumps. If there are any skin changes, are there any dimpling of the breast tissue? Are there any abnormal nipple features? So these are things that you need to pay attention to. Now, part of the care is the palpation. Whenever you're doing the palpation, so you're going to ask the patient to lie down with the arm above the head, and you're going to use the tips of your fingers to gently feel the breast tissue. You're going to have to check for the lumps, check for the consistency of the tissue, if there's any nipple discharge. And you got to record the characteristics, such as the shape, the size, and also the tenderness. Now, part of that is to do the this testing. You're going to check for the axillary lymph nodes So with the patient's arm slightly elevated, you're going to feel the armpit area for any swelling of the lymph nodes. Normally, none are felt. So these are the lymph nodes that you should be checking. So let's just zoom that in real quick. So you have the different regional lymph nodes, the supraclavicular, intraclavicular. You got the anterior pectoral lymph nodes. We got the posterior or subscapular, the central, the mid-axillary lymph nodes, and the lateral brachial. So these are the areas that you should include in your palpation. Now, again, lymph nodes are usually about less than 1 centimeter in size. They should not be painful. Okay. Now, part of your care here is to instruct our patient or your patient to do regular breast self exams and make sure that they are notifying their medical provider for any changes and make sure that they do the regular checkups and mammograms as well. Now, let's proceed to the next system, which is all about the abdominal examination. So before you're going to do the actual physical exam, you're going to ask the patient about their appetite changes, if there's any weight loss or weight gain, if they are having trouble swallowing food or liquids, if there's any nausea and vomiting, if they are having abdominal pain. Is this pain going on in the right upper quadrant, or is this in the lower quadrant on the right, or is this on the left lower quadrant of the abdomen? Or it could be pain in the flank area. That's actually part of that. Now, vomiting is also another question that you should ask for any pain. What's the severity, the characteristic? When does this happen? How long has it been going on? Their bowel habits. Check the patient if they have chronic issues of constipation, diarrhea, the kind of medications that they're using, and maybe if they have any history of abdominal issues or any surgical procedures. So you better collect these information to not miss any details. Now, part of that would be to do your inspection. So this is the first checking. You're going to have to observe with your naked eye, check for the shape of the abdomen. It could be flat, it could be round, it could be concave or bulging. Of course, what we're going to worry here is the increasing dense distension of the patient's abdomen or bulging. Hernias, those are things that we're going to have to pay attention to. Symmetry, if there's any malposition of the umbilicus, skin smoothness as well. Are there any visible pulsations in the abdomen? Okay. Or if there is any discoloration, such as that purple discoloration into the umbilical area, we call this the Collins sign, which is a sign of pancreatitis, right? Especially if there is now a rupture. Now, next is to do the auscultation. So you gotta put your patient in a supine position. You're gonna have to 4 quadrants before touching the abdomen. Again, your sequence will start with the inspection, auscultation, percussion, and palpation for the abdominal assessment. Normally, you should be hearing about 5 to 30 times of tingling per minute. That should be your active bowel sounds for each quadrant, right? Now, it is considered to be hypoactive if you're only hearing less than 5 tinkling sounds per minute, and hyperactive greater than 30 times per minute. So make sure you do the different quadrants for a full minute for each quadrant. Okay. Now, another thing that you're going to do when you're assessing the abdomen is to auscultate for the bruit or the vascular sounds over the major artery. So when you are listening for the arterial bruit, so this is going to sound like a harsh murmur, and this is something that is associated with an aortic aneurysm. Okay, so if you're hearing that arterial bruit, now if you're going to listen for that midline murmur, which is characterized as a soft, low to medium pitch, this is basically telling us that there is some sort of a artery stenosis. Okay, especially the renal artery, or if there is probably venous hum, this is going to give us an idea that there is basically a partial occlusion of the femoral arteries. So look into this right here, the femoral, partial occlusion of the femoral arteries. That's your venous hump. Now, we're going to proceed with the percussion of the abdomen. So you're going to have to use your fingertips, your palm of your hand to tap each quadrant lightly, or when you're doing your percussion of the patient's posterior back to assess for probably the kidney, or to the anterior side to assess for the spleen, the liver. They should produce a dull sound. And it is very important for us to assess for any tenderness over the kidney area as well. Most often, our patients should not be complaining of any tenderness when you're doing the light to deep palpation, percussion rather, I'm sorry. Now, for the next testing is your palpation. So you're going to start with the light pressure first, and then you're going to do the deeper palpation and focusing into the different organs like the liver or the spleen. And we're going to have to check for any abnormal pulsations in the aorta as well. Okay. So that is pretty much it. Now, I hope that you are able to capture the most important concepts about the physical assessment. And this is going to be the end of our discussion today. We will continue on the part 2, and we'll be tackling about the musculoskeletal, the neuro system. Same thing. We're going to do the physical and health assessment. And if you have any questions, please let us know. If you have any, if you want to have some clarification, please let us know in the team in order that we can address them in a timely manner. Hello, everyone. Welcome back to our next lesson today. We are going to be tackling on the health assessment, and our focus will be on the musculoskeletal system and the neurological system. So let's get started. Now, when we are doing the assessment for this patient with musculoskeletal disorders or problems, we need to make sure that we go through with the subjective assessment first. And part of the interview here is to make sure that we're going to ask them about those specific questions regarding any trouble with pain, like joint pain, stiffness, if they have any swelling or limitation of their movement, and if they're complaining of any pain in the muscles, or it could be weakness, it could be pain in the bones, or if they have any restrictions or limitations with their daily activities and the kind of exercises that they're doing at home, and possibility of injuries, or could be procedures or surgical procedures that they might have had in the past. Now, talking about the assessment of our musculoskeletal system, we need to also do the inspection. And this is the direct observation of how the patient will be walking while we are testing them, testing about their movement. We're going to have to take a look at that one, and also their posture. How are they positioning themselves, and if there's any abnormal curvature in the spine. Now, another thing that we need to take a look will be to feel or palpate those joints or the bones or the muscles for any kind of tenderness, or it could be swelling. And we need to also make sure if they can move their joints, if they can do range of motions, even maybe with or without assistance. We'll check if they have any pain or stiffness, or if they cannot even do a full range. Now, another thing that we need to do is to check for the strength and their muscle tone. And we're going to have to ask the patient to flex and to resist pressure. And we're going to have to assess if there is going to be increased or a decrease in their muscle tone. Now, let's review into the different grades for the muscle tone and strength. So, of course, 0 means that there's no movement of that muscle. 1 could mean that there is trace movement. And we also have 2, which is full range, but not against gravity. And then we got 3, which means there is going to be full range of motion against gravity, but not against resistance. And then we also have 4, which is going to signify full range of motion and also against gravity, and there is some resistance, but somehow it is weak. Now, moving on to number 5, which is going to signify that the patient has a full range of motion of that muscle or that joint. They can't resist against gravity, or there is full resistance as well. Now, moving into another assessment, we will be talking about the neurological exam. And first things first, we will tackle the Glasgow Coma Scale. This is a very common tool that you can use to assess your patient's level of consciousness and to check for any severity in their mentation or their LOC. Now, the Glasgow Coma Scale, it is a powerful tool that you can use to immediately check for your patient's LOC. You are going to check their eye opening response, their verbal response, or their motor response. So you have all these 3 aspects, and I got this acronym EVM. So that would be your clue to remember the aspects of your Glasgow Coma Scale testing. Now let's go through the scoring here. Now, with your patient, to have a perfect score for the eye opening or the E, you can give spontaneous opening of their eye with a 4. That is the highest score. And so they are going to open their eyes before any stimulus, right? Without being asked, they would immediately just open their eyes. This will be the next one is that they can open their eyes in response to speech or a noise or a sound. So this is scored as a 3. Now the next score is they can open their eyes whenever there is painful stimuli or stimulus, right? And this is something that you can do with applying that 10-second nail bed pressure on their fingertip, or maybe you can apply that pinch on their sternocleidomastoid muscle. And so if they're going to only open their eyes because of the painful stimulus, then that is going to be a 2. Now, if there is no eye opening at all, despite you had administered or you had given them that painful stimuli, then that is a 1. Now, I really want you to consider this, because there are some patients that would not be really going to be difficult for us to test, especially if there is, let's say, swelling, maybe a surgical procedure of their eyes. So you will not be able to score that clearly. And so there is what we call as non-testable scoring if your patient's eyes are closed because of that condition, if there are any obstructions, that make sure you should have that considered. So that is considered as NT. Now, moving into the next aspect of your Glasgow Coma Scale is the verbal response. If your patient can answer questions correctly, they know their name, they know the date, they know where they're at currently, that is corresponding to a score of 5, which is the perfect score. And if they are disoriented, they're confused, they know some things but may get others wrong, so that is already a score of 4. Now, for a score of 3, this patient will probably make those inappropriate words. They will utter those words that make no sense. So they're going to be given a score of 3 and a score of 2 if they're going to have that moaning, groaning sound, incomprehensible words. And we also have a score of 1 for those patients who are not verbal. I mean, they don't have that verbal response at all. Okay. No, if, for example, if the patient doesn't have any interfering factor, no endotracheal tube, and if they're not responding, so that will be scored as a 1. Now, there is also that aspect in your verbal response whenever they have that barrier. So, for example, they cannot speak because of being intubated, or let's say they might have a severe mouth injuries, or maybe other factors that prevent verbal communication. So this is going to be non-testable. Now, moving into the last aspect of our Glasgow Coma Scale is your best motor response. So you're going to give them a score of 6 if they can follow commands. And of course, you're going to check this by asking them to maybe lift their hand, or let's say squeeze your hand, or maybe raise their eyebrows, or close your eyes. So those are things that you can do to check for this. Now that's a score of 6, a perfect score for the motor response. Now, if your patient can localize pain, could be that they're only going to respond with the use of that 10-second trapezius pinch, or if there is, let's say, you exerted that pinch into that extremity, they will attempt to remove the stimulus. They are localizing pain, so they're going to be given a score of 4, and actually 5 rather. And then if they can flex, they're trying to withdraw. This is what we call as normal flexion. So they are going to be given a score of 4 for that. This is something that the patient will probably do when they're moving away whenever there is pain, right? And then they're going to be given a score of 3 if there is abnormal flexion, and this is what we call as the decortication. Now, this is what we call as the abnormal flexion, whenever their patient will be bending their arm in a very stiff, abnormal way when there is pain in that area. They're going to be given a score of 3. Now, a 2 score will be given when they have that extension, known as the decerebration. They are going to extend the arm stiffly in response to the pain that you have exerted to that particular body part. And a 1 will be given if your patient doesn't have any response at all. And lastly, non-testable for this patient if they have a paralysis, or maybe they have some conditions that prevent the movement of that particular extremity. And so make sure that you do that. Now, when we are going to score the total numbers from the eye-opening verbal response, motor response, the range could be from 3 to 15. 15 being the highest, 3 would be the lowest, of course. If none of these would be non-testable, they can get at least 1 for each verbal response, eye-opening, or motor response. Now let's go into the more specifics about the Glasgow Coma Scale. If there are any issues, let's say they have a Glasgow Coma Scale of 3 to 8. Well, this is going to signify that there is severe brain injury, okay? This is going to be the lowest range of the score. This is very serious. There is some impairment in their level of consciousness. So this might suggest that your patient might be at risk for a severe disability, even death, if not managed quickly. And we also have a score of 9 to 12. This is basically going to be, I should say, a moderate brain injury. They might experience some confusion. Maybe they're lethargic, disoriented, but they're able to follow some commands, or they can communicate as well. So there is still risk of worsening brain injury in this range, 9 to 12. So you still need to do close monitoring for this patient, and they still have that increased likelihood of neurological deficits. But they do have a better prognosis than those with a severe injuries. Now let's go back just really quick into the range of 3 to 8. I forgot to mention about the score of 3. This is, again, the lowest possible score whenever there is a deep coma or brain death. And a score of 8 or below typically indicates that this patient might need intubation and mechanical ventilation. So take note about the score of 8 and less than that. So they're not going to be able to really maintain a patent airway. They're going to need some suctioning, repositioning to allow drainage of their oral secretions, and they are not going to be able to manage that. So definitely intubation and mechanical ventilation will be required. Now, moving into the 13 to 15 range in your Glasgow Coma Scale, this is going to signify that there is mild brain injury, and this patient at this in this range, they may range from being alert to responsive, though they could still have symptoms like being confused, maybe some headaches, or maybe temporary amnesia. Even though it is termed as mild, this range of 3 to 15 the 13 rather is on the lower side of the range and may require further investigation still and close observation. And most of the patients in this range, 13 to 15, can recover well from the mild injuries, though close observation should be done in order to detect any worsening of the manifestations. Now, let's talk about the cranial nerves. These are stuff that you need to have mastered already. So we're just going to breeze through the different names and mnemonics. So we have here our cranial nerves from 1 to 12. We got the olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, acoustic, glucopharyngeal, vagus, spinal, accessory, and hypoglossal. Now, I want you to recall that you can use the mnemonic. So it can be the O to touch and feel very green vegetables. And then if you want to recall what this cranial nerve is, whether it's a sensory or a motor or both. So here are the following. So for the mnemonic, so you can use the word some say, marry money, but my brother says big brains matter more. Now, remember that for the cranial nerve number 1, this is that nerve that is responsible to transmit the impulses, our sense of smell. Cranial nerve number 2 is our sense of vision. 3 would be to cause us to have that parasympathetic constriction of the pupil, movement as well. And then we have the cranial nerve number 4, which is responsible for the motor, downward and inward movement of the eye. And we got the trigeminal. We have the mastication, sensory sensation of the face, scalp, the cornea, and also the mouth and the nose. So we have the abducens, which is basically the lateral eye movement. So I want you to recall abducens, abduction. So this is the lateral movement of the eye. And we got the 7th, which is facial. This is both motor and sensory. For the sensory here, this is responsible in detecting at least the taste sensation in the anterior section of your tongue, about 2/3. And then for the motor, this is responsible to moving the facial muscles, closing the eyes, and also, the facial muscles. Now let's move into the acoustic or cranial nerve number 8. This is the sensory nerve that is responsible for the hearing and equilibrium. And then we have a 9, which is both motor and sensory. So the swallowing will be tested here. For the sensory, it has some contribution to the sensation especially in the carotid body, the parasympathetic carotid reflex, wherein there is also that widening of the carotid artery when the blood pressure rises, and also the bradycardia when there is to slow down the rapid firing in the SA node. Now we also have our cranial nerve. So that is basically the cranial nerve number 10, the vagus nerve. And then we got the cranial nerve number 11, which is the spinal accessory. This is to help move your trapezius and the sternocleidomastoid muscle. And then lastly, we have the hypoglossal cranial nerve, which is going to be responsible with the movement of the tongue. Now let's talk about the assessment involved, especially with the balance and symmetry. So this is very basic. We really need to observe the patient's gait. So you're going to watch as they walk into the room. Normally, the patient should walk upright, right? However, when there is issues, maybe the person will have that wide gait. There's going to be that Parkinsonian gait, or what we call as the scissors gait. These are abnormal gaits for this patient. For the balance and symmetry, what you should be seeing here is that the patient should be able to maintain balance. There should be natural arm swing. However, if there is an issue, they can become ataxic, or there will be some unsteady walking. Now, looking for the arm swing, there should be a natural arm swing when a person walks. That's the arm should be opposite to the legs. However, when there is a problem, there's going to be some rigidity or abnormal arm movement. And this is something that you can see in a patient with Parkinson's disease. And for the posture and movement, the patient should be able to maintain upright position. But for some people, they will have that stooped posture. They're going to have a stiff trunk, or the head is somewhat kind of like stiff to move. Now, we're going to talk about assessment of the muscle strength as well and tone of the limbs. So here we have The patient should be able to flex their muscles and resist the test. However, the patient who has an issue would be less than 5/5. They are going to have flaccid paralysis, or could be spastic paralysis. Now let's move on into the different testing for the cranial nerves. So let's start with cranial nerve number 1, which is the olfactory. So what you're going to do here is to have the patient close their eyes and also close their mouth. What you're going to do next is to block one nostril and ask the patient to identify the common scent. It could be toothpaste, or it could be coffee. And then you're going to repeat the same scent to the other nostril. And now you're going to do next is the optic nerve number 2, which is basically the cranial nerve number 2. What you're going to do here is to do that visual acuity test using that Snellen's chart, or you can do that short distance type of reading material. So for the Snellen's chart, the patient should stand at least 20 feet away, and they should be able to see those varying levels of distant letters and numbers. Now, another thing that you can do in the cranial number 2 testing is to assess for the peripheral vision. So what you can do here is to do perform a confrontation test, and this is to check for the peripheral vision. So you're gonna have to ask the patient to cover one side or one eye, while you are going to use your finger or maybe an object to move from the central vision to the peripheral vision. Now, there is going to be difficulty reading the Snellen's chart if there is a problem in your cranial nerve number 2, or maybe the patient will start squinting if they will have issues in their vision. They are not going to be able to really see those peripheral objects if they have peripheral vision defects. Now, for cranial nerve number 3, 4, and 6, these are cranial nerves that you can simultaneously test. Now, I want you to recall that the oculomotor, or cranial nerve number 3, is responsible for the pupil constriction, the upper eyelid elevation, and the easiest way to test this is to observe for the patient's upper eyelid. Check if there's any ptosis. Now, for the cranial nerve number 4, this is to control the downward and the inward movement of the eye, and we got the abducens, which I said, abduction, lateral eye movement. Now, how are we going to do the oculomotor trochlear abducens testing? We are going to check for the movements as well as the pupil size, the equality, the constriction, and the accommodation. So these are the things that we should recall. Now, another thing that you should be noticing if there is an issue, let's say their eye movement is somewhat non-parallel, okay? There could be some nerve dysfunction that could lead to the unequal movement of the lids, or it could be the unequal pupils. This is what we call as the anisocoria. Maybe one pupil will be constricted while the other one is dilated. So this could be a sign that the patient might have an increased intracranial pressure. Now, another abnormality is whenever they're going to have that meiosis, which is basically the constriction of the pupils. Maybe maybe the patient has been taking narcotics, or let's say the mydriasis, which is the dilation of the pupils. So they could be using ophthalmic medication for that, or there could be a problem in the nerves itself. Now let's move into the cranial nerve number 5, which is basically the trigeminal nerve. And the trigeminal nerve has 3 branches, okay? So the 3 branches that we have are the ophthalmic, and also the maxillary and the mandibular. So like I've said earlier, the trigeminal nerve has both sensory and motor function. Now, what are we going to do here to test the patient's motor function? The patient's supposed to clench their teeth, and also we're gonna palpate the temporal and the masseter, just like this. We're gonna have to check for the muscle strength in that nerve. Now, we're also going to have to test for their sensation using that light touch. We're going to use that piece of cotton ball to kind of touch the forehead or the scalp area. And also, we're going to use a paper clip blunt maybe or the sharp end to test for their sensation. This is to compare between a blunt and the sharp sensation. Now, another thing is to check for their corneal reflex using that piece of cotton ball. We're going to have to observe for the blink response. Now, for the normal finding in checking the motor response, the patient's muscle in the masseter, temporal muscle, should be able to contract bilaterally. However, if there is an issue with a trigeminal nerve, there could be a problem, weakness, abnormal contraction. Maybe one side is weaker than the other. And another is that for the sensation, there could be an abnormal or inequality of the sensation between one side to the other, or it could be an abnormal reflex. Maybe the other cornea would not be able to really, there's no blinking at all. Now, let's talk about the trigeminal neuralgia. This is a condition that will be present if there is a disorder in your cranial nerve number 5. And so when you are going to test, especially palpation of the face, or if you're going to have to do the simulation with that paper clip, sharp edge paper clip, you got to be careful around this time, because even with that stimulus, this can cause them some pain. And again, this is what we call as the trigeminal neuralgia or the tic douloureux. Now, moving into the next test will be the cranial nerve number 7. This is the facial nerve, and what we can do here is to ask the patient to raise their eyebrows, have them frown, close their eyes, maybe smile, and have them puff their cheeks. And also in the cranial nerve number 7, we can also test their sense of taste in the 2/3 of the tongue. We're going to have to also instruct the patient to stick out the tongue and leave it out during the assessment process. Now, what would be the abnormal findings for this patient with a facial cranial nerve? There could be asymmetry of the face. This could also be an inability to identify the taste. There's no consistency as far as the identification of the taste. There's also a problem in their sense of smell around this time. This can be a problem together with cranial nerve number 7. Anosmia for the cranial nerve number 1, and then cranial nerve number 7. Now let's talk about cranial nerve number 8, or this is what we call as the acoustic or the vestibulocochlear or acoustic cranial nerve. This is going to be performed. The testing can be performed using that whisper test. You're going to have to stand at least 1 to 2 feet away from the patient's ear. You're going to be standing behind them, and then you're going to whisper some words and have them identify what you whispered. And so if they're not going to be able to tell you what you whispered to them, then there's a problem with their hearing, right? Now, we're also going to test for the hearing loss using the Weber and the Riney test. So here are the following. So for the Weber test, this is something that you can do to evaluate the lateralization of the sound. And this is to determine if the hearing loss is conductive or if the hearing loss is sensory neural. So the procedure here starts by striking that tuning fork, usually about 512 hertz. And then you're going to have to place the base of the tuning fork at the center of the patient's forehead and make sure that you're going to ask them if they're going to be able to hear the sound in both ears. So if they're going to be able to detect bilateral or just one side. Now for the abnormal, for the normal finding, your patient should be able to hear, right? From both ears. However, if there is an abnormal assessment, this simply means that only the defective ear can hear the sound of that tuning fork. And this is going to be what we call as the positive conductive hearing loss. However, we're going to call that as a sensory neural hearing loss if in case your patient's good ear can only hear the sound. So if there's just one ear hearing the sound, then both are actually either are both um, results. Both ears should be able to hear it, not just one. Okay. Again, if only one ear is able to hear it, let's say defective ear can hear it, then this is what we call as a conductive hearing loss. However, if the good ear can hear, then this is what we call as the sensory neural hearing loss. Now let's move on into the Riney test. This is another testing that will also use the uh, what do you call this? This device, the tuning fork. So you're gonna still use the same 512 hertz type of tuning fork. So this is to compare between the air conduction and also the bone conduction. So what would be the result here normally? Okay, so once you strike the tuning fork, you're gonna have to apply the base of that tuning fork into the mastoid process. And you're going to uh, ask the patient if they're no longer able to hear the sound. Now, after that, you're going to have to move the tuning fork at the front of the ear canal. So this is the air conduction. So here, when you are putting the base of the tuning fork onto the mastoid bone, this is basically to check for the bone conduction. While when you are going to place the tuning fork right next to the ear, this is to check for the air conduction. Now, what would be the normal finding in the Riney test? Well, it should be greater for the air conduction than the bone conduction. Okay, it simply means that the sound is heard longer through the air than the bone. Okay, so they should be able to hear much longer. The duration of the sound can be heard much longer uh, for uh, for this patient. Air conduction will be longer compared to the bone conduction. Now, if there is going to be issues, abnormal findings will be positive conductive hearing loss, and that simply means that the bone conduction is longer. The duration of the sound is longer than the air conduction. Now, if we are going to identify the patient as sensory neural hearing loss, then the air conduction will be greater than the bone conduction. But here's the caveat when we are talking about the sensory neural hearing loss. Both are actually affected this time. But if you are comparing about the degree of the damage, the air conduction has, let's say, has a longer duration compared to the bone conduction. Okay, so with the sensory neural hearing loss, there is an issue with the inner ear or the auditory nerve could be damaged. So actually, both the air and the bone conduction are diminished. But if you have to compare both, the air conduction will be much longer. Now let's move on into the cranial nerve number 10 assessment. This is the testing of your vagus and also the glossopharyngeal nerve, which is cranial nerve number 9. So this is going to, you're going to test for the motor function. So what you need to do here is to instruct the patient to say ah. You're going to have to use a tongue blade on the client's tongue. Normally, what you will see is that the uvula and the soft palate will rise bilaterally and symmetrically. However, if there is an issue, the soft palate will not elevate, it will not rise. And this is a sign that there is a bilateral lesion of the vagus nerve. Now, if there is going to be a unilateral rising of the soft palate, this is also not a good indication. Or let's say if there is a deviation of the uvula, these are indications that there could be lesions of the vagus nerve as well. Now, next is to test for their gag reflex. This is the very common test for a cranial nerve. And what you're going to do here is to use that tip of that tongue blade and touch the posterior pharynx with the tongue depressor. So normally, your patient will start gagging, right? However, if the patient does not have any response or let's say absent gag reflex, this is a sign that they might have a lesion in cranial nerve number 9 and number 10. Again, if there's no gag reflex, or maybe the patient just came back from a surgical procedure, they probably have an endoscopy, they just had a bronchoscopy, or maybe they had a upper GI endoscopy. So normally they will have a lack of the gag reflex immediately after the procedure, right? Now, another thing that you need to be testing is the swallowing ability. So what you're going to need to do here is to assist or have the patient drink or take a sip of water, and they should be able to swallow without difficulty. However, the patient that has maybe a dysphagia, they're not going to be able to do that. So just be careful though. That is why you need to do the gag reflex first before you're going to do the swallowing test. Okay? So those are two different things. Now we're going to need to also test for the cranial nerve number 11, and this is the spinal accessory. So what you need to do here is to ask the patient to shrug against the resistance. So you're going to put both of your hands on top of their trapezius muscle, and normally they're going to be able to contract their trapezius muscle. They're going to be able to lift those muscles. However, with a problem, they're not going to be able to do that. There is less muscle contraction, or maybe there is drooping of the shoulder, and this is maybe an indication or maybe weakness or paralysis of those muscles, maybe because of the neck injury. Now, as we go through the other portion of our spinal accessory muscle testing is to do that. You're going to have to put your hand against the patient's face and have them kind of resist that by turning their head towards it. And if there is strong contraction against their resistance, well, that's normal. They can actually do that. However, if they have some paralysis or if they have atrophy of that nerve or fasciculation, or if there's any fasciculation or atrophy of the if there is muscle weakness, if they're not really going to be able to resist against the resistance, then this is a bad sign. This is a problem with your cranial nerve number 11. And lastly, we have the cranial nerve number 12, which is the hypoglossal. We have to test for the strength and the mobility of the tongue. So have them protrude their tongue, instruct them to kind of move their tongue from one side to the next. Or what you can do is also have them push their buccal area, and you're going to apply some pressure to that cheek and have them push your hand to test for the strength of their tongue. So normally they can do that. However, if your patient has an issue, there's fasciculation, or if there is atrophy of the tongue, then that is a significant sign that there is peripheral nerve disease affecting the cranial nerve number 12. Okay. Now, also, there's going to be a unilateral lesion whenever there is deviation to the affected site. Now, this time we're going to talk about the testing of our patient's cerebellar function. And if we are going to talk about cerebellar function, think about coordination, think about balance. So the most common test here is to do the Romberg's test. So you'll ask the patient to stand with their feet together and with their hands on both sides. The first part of the testing is to have them open their eyes first, and you're going to have them close their eyes for 20 seconds, and you got to be ready here to support them if they're going to lose their balance. Now, what would be the abnormal finding here? If they're not going to be able to maintain balance within that 20-second, then if they're going to start to kind of move, maybe take a step back or forward, if they're going to maybe take a step to the side with their eyes closed, there is a problem. This is what we call as a proprioceptive problem. Now, if the patient moves their foot with eyes open, also closed, there is what we call a cerebellar or vestibular disorder, or there is what we call as a positive Romberg's sign. Now let's talk about the single foot balance. This is another testing for your cerebellar function. So what you're going to need to do here is to ask the patient to stand on one foot at a time, at least 5 seconds, with eyes closed. The patient should be able to stand steadily, not going to fall. However, if there is an issue with this cranial nerve, they're not going to be able to stand on one foot for 5 seconds. There's also that heel to toe walking. So you're going to instruct the patient to have the patient walk in a straight line. They're going to need to place the heel of one foot against the toes of the other. However, if there is an issue with their cerebellum, they're going to have difficulty of walking, and also they're not going to be able to carry out the heel to toe or using a wide-based gait. They will resort to the wide-based gait right away. Now, this time we will talk about the test for coordination. This is also testing the cerebellum. So this is all about pronation and supination, thigh tapping. So you're going to instruct the patient to tap their thighs with their hands, alternating between palms and palms up and down rapidly. So alternating just like this, what you're seeing in the picture. So if the patient has some issue with the cerebellum, if they're uncoordinated, they're not going to be able to maintain a rapid pace, or that the patient, you will be able to see the intentional type of tremor. There is that involuntary shaking during the movement. And again, this is a sign of cerebellar dysfunction. You also can do the finger to nose testing. This is to check for the coordination. So you're going to have to ask the patient to close their eyes and have them stretch their arms out, and they need to alternately touch their nose with each finger. So abnormally, they can miss the nose or arms maybe drifting downward, and this is a sign that there is cerebellar dysfunction. Now, another is the finger to thumb testing. This is also to test for the coordination. So what you're going to need to do here is to ask the patient to tap their, to touch each finger to the thumb in a rapid sequence on each hand separately. If they're not going to be able to carry out this kind of testing, then there is a cerebellar dysfunction as well. So this is what we call as the rapid finger to thumb test. And we also have the finger to nose and your finger, which is going to involve you as the examiner. So you're going to ask the patient to point their nose and then point to your finger. So just back and forth. Now, if they're not going to be able to carry out in a very smooth manner, this is a sign of a cerebellar dysfunction as well. Now, another testing is the testing of the coordination in the lower extremity. So this is the heel to shin testing. So of course, the patient will be on their back, and you need to ask the patient to perform the heel to shin test. They're going to be on their back, and they're going to slide the heel of the right foot down the left shin, and then they're going to have to do the same all over again on the opposite side. So normally the patient should be able to do this smoothly. However, the patient has an issue with their cerebellum. Let's say there is drifting, if their heel will not be able to maintain that smooth, what do you call the sliding down from to the shin, from the upper part of the shin to the lower side, there is a good chance that they have an issue with their cerebellum as well. Now look into this testing. This is going to test for the sensory system. So this can employ different types of objects. You can either use the cotton ball, or could use the blunt side of the paper clip, or maybe the sharper edge of that paper clip. So what you're going to need to do here is to test for the absence of sensation, or let's say a lack of sensation. Maybe they can feel some, but not completely. And you can also do this by allowing the patient to close their eyes. Make sure that they're closing their eyes so they're not going to be able to cheat. And there are areas that are specific to be tested, such as the hands, the back of the hand, the lower arms, and also the abdomen. So when you are going to test maybe a particular extremity, you need to test both sides, the right and the left side. If you're testing maybe the face, you need to test the right or the left side of the face, or maybe the abdomen, the right or left side abdomen as well, or the arms, the lower legs, the feet. And this is to check if there is some discrepancy or differences between the two sides or hemispheres. Now, again, absence of sensation is a bad thing. This could mean that there is nerve compression. And if there is an abnormal sensation, this could mean that there is nerve inflammation. And then if there is going to be a lack of sensation, or maybe they're feeling pins and needles. This is possibly signifying that they have some diabetes or maybe tumor in the parietal lobe, which can derange their interpretation of those sensations. Now, another is to do the light sensation with the use of the cotton ball. So again, you're going to instruct the patient to close their eyes while you are touching that particular body part, and then they need to point out, they need to name where exactly you touch them. So especially if you're going to touch the left hand, ask them where you exactly touch them. Okay. Now, the abnormal findings here will be that the patient is not able to really identify where you touch them, or they could probably tell you that you are touching, but on the wrong side. Or maybe there is some uneven sensation between the right or the left side. So these are things that you need to keep in mind for this light sensation. Now, another thing that you're going to need to do is the sharp sensation. So again, you're going to instruct the patient to close their eyes. You will be using the sharp or the blunt side of the paper clip, and you're going to have to alternate applying the sharp and the dull part of your paper clip and touch that patient's extremity. So they need to close their eyes as well and identify if this is a blunt or a sharp side of the object. And again, do not give them any leads. Do not say something about numb or sharp. Just let them say what they are feeling. Okay. So normally the patient will not be able to really determine. They're not going to be able to distinguish either sharp or dull sensation. And there's probably an even sensation between the sides if they have an issue. Now, another testing that you're going to be doing is the vibratory sense. So here we go again. We're going to use the tuning fork. We're going to have to place that tuning fork after striking it. You're going to place the tuning fork into a bony wrist area, or the bony area of the wrist, rather. It could be the ankle, or it could be the sternum. And then you're going to ask the patient to describe the sensation, right? They should be able to feel the vibration. And ask them when exactly the vibration stopped. Then stop the tuning fork by touching it without moving the device. For a patient that has a normal sense of vibration, they're not going to be able to determine, or they probably would tell you that the vibration sense is unequal on one side, or both sides rather, and they are not going to be able to tell you when the vibration stopped. And so if this is something that can come up, you need to really let the medical provider know. It could be a sign that they have diabetes, or maybe stroke or spinal cord injury. Or it could be the diabetic nephropathy. Now let's talk about the joint position. This is what we do for the testing of the proprioception. Now, just like in the picture, you're going to grab the side of the great toe and maybe a finger of each hand. So what you're going to do here is to move the joint 1 centimeter up or 1 centimeter down. And then you're going to ask the patient to describe the direction. Is it moving upward? Is it moving downward? Around this time, you also need to instruct the patient to close their eyes, so they are not going to be able to cheat during the testing. All right. Now, abnormally, they will not be able to really distinguish between the changes in the joint position. And this is an indication that they might have a parietal lobe impairment. Again, parietal lobe impairment. We know that the parietal lobe is basically that part of the brain that interprets the sensation, okay? Especially the position. Now, let's talk about the testing, specific testing, such as the stereognosis. So what are we going to do here? We're going to place a familiar object, let's say a paper clip, a key in the patient's hand, and they need to identify the object. They're actually going to be asked to close their eyes this time. And you're going to put that item into their palm of their hand, and they're going to identify what they are feeling. So abnormally, they're not going to be identify the object, and this is going to indicate that they have a impairment in the parietal lobe. Let's talk about the next testing, which is the extinction testing. So This time, you're going to touch the same spot on both sides of the body at the same time. So you're going to ask the patient to close their eyes. Supposedly, you're probably going to touch simultaneously both hands, and then you're going to ask them what side you're touching, or maybe you're just going to touch the left side, and then you're going to ask them where exactly they feel where you're touching. And so normally they're going to be able to feel the sensation, and they will be able to identify both sensations and their locations. However, if the person has a problem with this, they're not going to be able to distinguish or to locate or to name where exactly you touched. Now, another is the graphesthesia. This is another specific test wherein you're going to have to draw a number or maybe a letter on the patient's palm or the back, and you're going to use a blunt instrument, maybe the Sharpie, or maybe the cap of your Sharpie. So when you are going to draw that character or letter on the patient's palm or back, they should be able to identify the number or letter. However, if there is an issue, they're not going to be able to recognize the figure, and this may suggest a parietal lobe lesion as well. Now, this time we're going to talk about the testing of the deep tendon reflexes. So generally, what you're going to need to do here is to check for the muscle contraction, and this is done through tapping a specific tendon using that reflex hammer. Now, you're going to have to do this on both right and left sides, and your patient's position this time can vary from being sitting or lying position, or it could be supine, or maybe just dangling that particular extremity. And this is something that you should know by now. You're going to have to grade the deep tendon reflex by the following. So if they have a 1+ score, they have a response, but it is decreased. It is present. If it is 2+, it is normal. However, if the patient's response is 3+, this is considered as brisk, but it is not pathologic. And then lastly, we have 4+, which is hyperreflexia. Okay, so this is a very significant tendon reflex. Now, here for a patient that may have issues, they may not be able to really feel the especially if we were talking about the monofilament, right? They're not going to be able to feel that. Or let's say if they have areflexion, no response at all. That could be worrisome. Maybe there is some issue. There could be some problem in the sensory relay center. Now let's talk about the biceps reflex, and this is to check for the cervical spine C5, C6. So these are the two levels that you should be checking. Now, what you're going to do here is to position the patient, partially bend the arm with the palm up, and then you're going to have to place your thumb over the biceps tendon, and then you're going to strike your thumb with the pointed side of the reflex hammer, okay? So normally your patient will have that elbow flexion and their biceps will contract. However, if the person has a problem with the cervical spine C5, C6, there's no response, or there could be an exaggerated response. Now, moving into the next testing here is the brachioradialis reflex to check for the C5, C6. We have here our patient's position would be to just be like this. Hey, hang on a sec. Let me just check on my PowerPoint. That's basically the same. We're going to move into the triceps reflex here. This is to check for the cervical 6, 7, and 8. So you're going to position the patient's arm, just kind of hanging them limp, supporting it with your hand. Of course, you're going to tap the tendon above the olecranon process with the flat side of the hammer. So again, you're going to have to use the flat side of the hammer. And normally the patient will be doing that elbow extension, and there's also contraction of the triceps muscle. Abnormally, though, the patient will have no response, or it could be over or exaggerated response. Now, another testing that we're going to have is the patella reflex, is to check the L2, L3, L4. So you're just going to allow the patient's leg to dangle, and then you're going to tap the patellar tendon below the kneecap with the flat side of the hammer, And normally the patient's leg will extend or the knee will extend and the quadriceps will also contract. However, if there is an issue with the lumbar 2, 3, and 4, there's probably no response, or there could be exaggerated response or hyperreflection. And lastly, we have the Achilles tendon reflex testing. This is to position the patient with the leg hanging freely and to dorsiflex the foot. Now, what you're going to do here is to tap the Achilles tendon with the flat side of the hammer. And normally, what the response is that the patient would have the foot plantar flexion. However, on the opposite side, what the patient might have is no response or maybe over exaggerated response. Now, lastly, is to test for the Clonos test, or this is the Clonos testing rather. And this is to determine if our patient has a hyperactive reflex. So you're going to put the patient in their on their back, but you're going to support their leg with one hand under the knee. And then what you need to do here is to dorsiflex the patient's foot towards the client's head briskly. And normally, what can happen is that there will be no rapid contractions, no oscillations. However, there is an issue. There's positive clonos. They're going to develop that rapid contractions, and this is going to indicate that they have in the upper motor neuron. So they probably have a lesion there. And the next thing that we're going to do here is your plantar reflex testing. So this is what we call as the Babinski's testing. So you're going to be using that particularly maybe the edge of the reflex hammer, or yes, that's the part of the reflex hammer that you'll be using. And what you're going to need to do is to stroke the lateral sole of the foot from the heel to the ball with the reflex hammer. Normally, the patient will have that flexion of the toes. There will be curling of the toes. This is expected. However, if there is going to be fanning out, this is what we call as the positive Babinski's test. This is a sign that your patient has an upper motor neuron lesion, or they could be unconscious, or they could be having some alcohol intoxication. Now, lastly, we're going to talk about the meningeal irritation testing. So you will have the Brzezinski's testing. So you will be placing the patient on their back. However, what you're going to need to do here is to flex their neck and observe the hips and their knees. Normally, the hips and knees remain relaxed, right? However, in a patient that may have a meningitis, the patient will have the flexion of the hips. They will also have flexion of the knees. Again, this is a sign that there is meningeal irritation caused by the meningitis. And lastly, we have the Kernig sign. You're going to put the patient on their back. And the technique here is to flex the hip and the knee. Then you're going to straighten the knee. The normal response for a normal person is that there's going to be no pain, even though the discomfort behind is normal. So that would be your interpretation. However, if there is meningitis or if there is meningeal irritation, the patient will have pain and resistance to extension. So that would be your interpretation for the Kernig's sign. Hello, everyone. Today I'll talk about safety and infection control. So hang tight and get ready with your pen and notebook to jot down important concepts. So let's get started. So today we will be tackling first about fire safety, and this is a very important aspect of our NCLEX. We need to make sure that we're able to really recall those very important concepts regarding promoting safety, regarding electrical capabilities in our workplace. And so first thing that we should recall about fire safety is to make sure that we need to keep open spaces free of clutter. We know that the hallways, the doorways, and workspaces should remain clear to allow for safe and quick evacuation in the event of a fire. Now, we know that clutter can really block the escape routes, and it can also hinder fire department personnel from accessing critical areas. So we definitely need to make sure we keep this um, clutter-free environment. Now we want to make sure that we also have that clearly marked fire exits, that it will be visible to everyone, patients and also workers, so that they're easy to identify, especially in a low visibility conditions like smoke or even power outages. So make sure that these signs are illuminated. Now, we also need to make sure we know the location of all the fire alarms, the exits, and the fire extinguisher. And for us staff nurses, it is very important for us to be more familiar with the exact placement of those fire alarms and the exits, especially the extinguishers. And this will enable us to promptly respond um, to the fire, and also to sound the alarm and finding the closest exit point, and to make sure that we can use the appropriate extinguisher to control those small fires. Now, this time we really need to review regarding the different types of extinguishers. We got there types A, B, C, D, and K. So for the type A type of extinguisher, this is mainly used for those combustible materials like cloth, wood, paper. These materials can easily catch fire easily. Now, the type A extinguishers are filled with water or a dry chemical to put out these flames. Now, we also have the type B type of extinguisher. They are intended for those combustible and flammable liquids, such as grease, gasoline oil, or oil-based paints, and the fires that are typically found in these are found mostly in kitchen garages or areas where the chemicals are stored. Now, we also have a Type C of extinguisher. This is intended to um, control electrical equipment fires involving plugged-in appliances, could be tools, wiring. Um, and also, this type of extinguisher will be helpful in stopping fire without the risk of electrical shock. No, the Type D is intended for flammable metals like magnesium and titanium, and these kind of fires are much less common, but are extremely dangerous still. And this kind of specialized extinguisher is necessary to combat them. And then finally, we have the Type K, which is intended for kitchen fires involving vegetable oils, animal oils, fats used in cooking. Um, and also, the kind of extinguisher that we have here will use a wet chemical to cool and smother the flames in high heat cooking environments. Now, another thing that we need to keep in mind regarding the fire safety is to make sure that we know that telephone number, emergency number for reporting the fires, and ensure that you're aware about the direct number. And also, and in addition to that, we need to also dial 911 or emergency services. Now, another thing that we need to do here is to quickly or be aware about the fire drill and evacuation procedure. This is a very important element in the training. This is going to uh, require you to really understand which patients or areas to prioritize during the evacuation, where the safe meeting points are, and also you need to know your role during the drill. Now, another thing that you need to remind yourself is that you don't have to use or do not use the elevators at all during a fire, because elevators can malfunction and they can trap people during a fire. And this is really going to pose a much more life-threatening risk to those inside. And so it is advisable that you're going to use stairwells when evacuating, because they are designed to offer a much safer escape route during the emergency. And also make sure that you know how to shut off and also identify where these areas are, especially when there is a fire. Now, in the event of a fire, if let's say if a client is on a life support, make sure that we can maintain respiratory status by offering manual resuscitation using that ambu bag until the client is moved away from the threat of the fire, and when they can be placed back into the life support. Now, in cases where patients rely on the ventilators or other life support devices, it's very important for us to maintain their breathing manually. Okay. And another thing that we need to do is to make sure you know about who these ambulatory clients, they can be directed to walk by themselves to a safe place. And in some cases, they may be able to assist other patients that are in a wheelchair. And so, yeah, this is actually going to be a good reminder for us, especially who these ambulatory patients are. They can be a lot of help. Now, especially for those bedridden clients, generally they're going to be moved using a stretcher, could be bed or their wheelchair, and care should be taken to prevent them from having any injury, especially during the relocation. Now, if in case the patient needs to be carried from the area of a fire, we need to really know about the proper transfer techniques. You really need to use correct body mechanics here and transfer methods to avoid injury to both the client and also yourself as a staff member. Um, and also, another thing that you need to be reminded about is that the personnel in the fire department, when they're at the scene, they will be able to help evacuate the clients as well, and they can take over the evacuation efforts. Okay, so this is very important for you to follow these instructions. Now, let's move on into the um, priority actions during the fire. And so you will see the different acronyms, RACE, and the other one is PASS. So just to kind of get refamiliarize yourself with the acronym, RACE stands for Rescue, Alarm, Contain, and Extinguish the Fire. So for the rescue, you need to immediately remove the patients or the staff from danger. You got to prioritize those closest to the fire. And for the A, activating the nearest fire alarm and also notifying the emergency services will be important to ensure help is on the way. And for the C, confine the fire, make sure that you have the doors closed and windows to prevent the fire from spreading. And then E, extinguish the fire, simply means that if safe, you can use a fire extinguisher to put out the fire. If the fire is uncontrollable, you need to evacuate the area as well. Now, the second acronym that we commonly use is the PASS, which stands for the pull, aim, squeeze, and sweep. For the pull, this is basically pulling the pin on the fire extinguisher. And the A, it is basically to aim the nozzle at the base of the fire. And we got the S is to squeeze the handle to release the extinguishing agent. And lastly, the other S here is to sweep the extinguisher um, or sweep the nozzle side to side at the base of the fire until it is out. And this is something that that is actually a training, a part of an annual skills training for the employees at the facilities, especially. Now, let's move forward into the electrical safety, and this is a big deal. We know that um, electrical equipment must be maintained, correct? Especially that we are going to be dealing with a lot of medical equipment. They need to be in good working order and should be grounded. And so, if in case there is a problem, this is actually going to be a hazard to us and to our patients. So one thing that you need to know about the fire safety is to make sure that you are removing the equipment that is not in proper working order and make sure that we are notifying the appropriate staff. Now, another thing that you need to remember is that we should be using the three-pronged electrical cord, and this is going to provide grounding protection. This is uh, the other two prongs basically carry the power to the piece of electrical equipment, while the other prong is the ground. Now, another thing that you need to recall is that you have to check the electrical cords for any fraying or damage, or if there's any wires that have been exposed. So this is something that would require a regular inspection for any visible damage. Now, another guideline that you need to follow is avoid overloading any circuit. So you got to be cautious not to exceed the electrical load capacity of any circuit. So this is to prevent overheating and fires. And very important for us to read all warning labels on all equipment and never to operate any unfamiliar equipment. And another thing is to make sure that we are using extension cords only when absolutely necessary. And this should cause us to tape them to the floor with electrical tape. Okay, this is to prevent tripping hazards as well. Now, another thing that we need to recall about fire safety is to never run electrical wiring under the carpets, because this can actually cause overheating and it can increase the risk of the fire. And when you are managing a cord or when you are pulling the plug, make sure that you're using or you're grasping the plug itself, not pulling the cord. Okay. Now, another thing that you need to recall is that we never use electrical appliances near sinks, bathtubs, other water sources, because this can actually place a higher risk of electrocution. And always disconnect a plug from the outlet before cleaning an equipment or appliances, and make sure that the electrical items are away from the water, because they are conduction. They can conduct to electricity real quick. Now, if the patient receives an electric shock, what we need to do first is to turn off electricity before touching the patient. We need to switch off that power source before making any physical contact. Now, let's move on to the radiation safety. This is a very common concept that you should know about, especially in the acute care setting. There are some protocols that you need to abide, especially when you are involved with exposure to radiation. So one of those guidelines will be to label potentially radioactive materials. Anything that can emit radiation should be labeled appropriately to prevent accidental exposure and ensure the proper handling and also disposal. Now, another aspect of this radiation safety is to make sure that you are reducing your exposure to the radiation itself. And you can follow this steps. One is to limit time near the radiation sources, especially to the radioactive materials. And another thing is to increase distance from radiation. The farther you are from the radiation source, the lower the exposure. And as radiation intensity decreases with the distance. Now, another thing is to use protective shielding and make sure that you're wearing appropriate protective gear, such as the lead aprons or shield to block or absorb radiation when necessary. And this is something that OR nurses or scrap technicians are supposed to be doing, especially that they're involved with a lot of radiation, especially with the fluoroscopy type of procedures. And also make sure that you are monitoring the radiation exposure with a dosimeter badge. And this is something that looks like this. This should be worn at all times when you are working near radiation sources to accurately measure and track your cumulative radiation exposure. Now, another thing that you need to keep in mind is to place the patient with a radiation implant in a private room. To limit the exposure to other patients, as these type of patients can emit low levels of radiation as well. And just in case, whenever there is a dislodgement of radiation implants, you never touch that. Do not touch it directly. You got to notify a radiation safety officer or any specialized staff for proper removal using the correct equipment. And make sure that you keep all the linens in the client's room until the implant is removed, as we know that they are already contaminated, right? And so we're going to have to wait until the implant is removed and follow proper procedures for handling the potentially radioactive materials. Now let's go right into the discussion about the disposal of infectious waste material. This is a very common theme that you need to know about. So the first thing that we need to know is that we should be handling the infectious materials as a hazard. We need to treat them as a hazardous material to prevent the spread of infections. We gotta dispose of waste in the designated areas only, and we should be using those proper containers for disposal. Okay, so there are specific containers for each medical waste as well. Now, we have to ensure that infectious material is labeled properly. to prevent accidental exposure. And lastly, especially if we are handling way so many sharps, needles, we need to dispose all these immediately after use in closed puncture resistant disposable containers that are actually leak proof and labeled or color coded as well. All right, now let's move on into our next section of our discussion, and we will be talking first about the physiological changes in the elderly, because we know that when the person ages, there's going to be so many physical changes that can occur in their systems. And one of those changes will be the musculoskeletal changes. So, what is happening here in the elderly person? They're going to end up with a decreasing muscle strength, and also their function is going to be decreased. Their joints are less flexible, their bones will become fragile, and they are known to have much reduced mobility, and there are going to be some postural changes as well, which will really put them at risk to falling. Now, for the nervous system changes, they're going to have some slowing down of their reflexes. They don't have that quick response, and their ability to react to very multiple stimuli will decrease, and their sensitivity to touch will actually decline, and this can also affect their coordination and response time, especially for those diabetic individuals. Now, another system is the sensory system change. Now they're going to have some trouble with their vision. Potentially, they can develop the cataracts, and they can also have a much slower response to temperature changes. There's also hearing loss, especially for high frequency sounds. This can also develop to these elderly people. And lastly, the common genitourinary changes, especially during the nighttime, they're going to have the frequency to get up to use the bathroom. And this is going to put them at risk to having falls at night and a much higher likelihood of incontinence as well. And we know that these people will also be adamant in really using the bathroom. They're really going to be worried about soiling their bed. So you got to consider these physical changes. Now, let's move on into the fall prevention measures. And this is one of the aspects that will be asked in the NCLEX, especially that safety, those precautions about falls will really influence the direction of our care. And so, what are those full prevention measures that you can do or that you should recall before taking the NCLEX? Well, what you need to do first is to assess the client's risk of falling. And there are so many fall risk assessment tools that are used. One of those is the Morse Fall Risk tool that you will be doing that interview. You're going to have to go through the physical assessment, ask the patient or any family member if your patient has these risks, right? And this has to be documented in the medical record and has to be done every shift as well if the patient is at risk. Now, another thing that you need to do is to place the client at risk for falls in a room closest to the nurse's station. And this is a very common practice to lessen the incidence of falls. Now, the next step is to educate these patients that are high risk on ways to prevent falls. Even those people that are alert oriented, they are still at risk to developing falls. Maybe they have some hemiparesis or hemiplegia, all the more for those people that are confused. Now, another thing that you need to do is to alert, make sure that the staff members are aware of the clients who are at higher risk to falling, and make sure that you follow the facility's alert system for fall for prevention. One of the practices that we use normally would be labeling or the application of the fall risk yellow bands into our patients. Could be placing the fall risk signs outside the patient's doorway, and also identifying them in the medical record. They're going to be highlighted or marked as high risk for falling in the chart as well. So we will know for sure who these patients are, so that they can check on them every now and then. Now, we have to check the client regularly. This is what we call as the hourly rounding, and this has been the practice that I've used to do way back when I was still working at the bedside. And the nurses, nurses' aides are actually alternating the hourly rounding to make sure that we are meeting the patient's needs, especially if they need to use the bathroom, offering them maybe to take a sip of water, make sure that their belongings are placed at their proximity, especially the call light, the placement of the buttons or the controls, making sure that they are able to reach their eyeglasses for reading, or making sure that their beds are locked and their beds are placed in the lowest position, and make sure that they can use the maybe bedside commode as needed. Now, another thing that we need to do is to orient the client to their surroundings. This is very important. Make sure that they are familiarized with the room, the exit points, or let's say where the items are in their respective room. Now, we also need to advise the client to ask for help when getting out of bed or moving around. And this is a common thing that can happen, especially with the elderly people or for those post surgical patients that might still be recovering. They probably are not quite with it. So they might get confused, not able to get the appropriate help at the right time. And so we need to also teach them how to properly use the nurse call button. And this is a huge thing. Make sure that we also use the safety devices like floor mats and bed chair alarms, and also to notify staff if the client attempts to get up. And one of the most sophisticated things that I have encountered so far with these technology is that the bed alarms are connected to the centralized system, wherein when the bed alarm goes off in the patient's room, it can send the alarms into the nurse's station as well. So everyone will be alerted, and they will start running into the patient's room. Now, to continue about the fall prevention measures, we also have to keep the bed low with the side rails properly set, and make sure that we can lock the beds, or we will be locking the beds, the wheelchairs, and stretchers, and to keep the personal items within the patient's reach, and to remove any clutter, any obstacles from the client's room, and to make sure that the room is well lit and free from slippery surfaces. And then we can also minimize the bathroom dangers. And we need to also stick to a toileting schedule for the client, so they will not be able to, they will not, so the chances of being impulsive to use the bathroom will be greatly lessened. Now, another thing that you need to know is to follow the toileting schedule. And what else? Encourage sturdy, supportive shoes. We also have those sticky um, socks that will actually help stabilize the patients when getting up from their bed. And this is to really prevent the falls as well. Now let's move on into our next topic, and this will be about safety devices or restraints. And this is a common type of equipment or device that will be used to limit the movement or immobilize a client or their limb. And this is a device that we should be cautious in using. Make sure that we are using them properly and not just because of our comfort. Now, one of those is the use of the bed or chair alarms when possible. These are things that we need to incorporate, especially when we are applying restraint to our patient. This will alert us when the patient is attempting to get out of bed unsafely. We need to make sure that the order for the restraint is complete, and the order should have the type of restraint there. So it should clearly state the type, the method, the reason why we are applying the restraint, and also the time of the application. Okay, so these are the things that we should have in the order. Okay, now there's also a need for us to make sure that the provider will be assessed, that they should assess the patient within 1 hour if the restraints have been applied to our patient. And the application and the protocols in the restraint application can vary slightly from one institution to the next. We'll have that generic standard procedure, especially with um, the order, how this restraint order has come into play. Now, what we're going to do next is to actually we are required to have a renewal of the restraint order as per policy. And in some hospitals, it will be required to be renewed every day. And for those other types of restraints, they will require much more frequent renewal. Now, make sure that you know this, that restraints are never ordered as a PRN. We never do a PRN restraints. We will be using the restraints as indicated and no trial release. Now, we need to also educate the patient that uh, also their family members the reason why we are applying the restraint to them. Okay. And to take note that the restraints are not supposed to interfere with the treatments or her health conditions. And when we are tying the patient, make sure that we are using that quick release to the bed frame, not onto the side rail. Make sure that this is secured and not easily removed by the patient. Okay, and not easily removed by the patient, but easily removed by the staff. Now, we need to also keep in mind that we should leave enough slack for slight movement for the patient. We have to make sure that they have good circulation, that there's no cutting of their circulation that can impair their physical function. And we also need to check for the the restraints tightness, the skin, and we need to remove the restraint uh, in order to allow the patient to have some mobility. But this is not considered what we call as the try or release. This is basically part of the treatment that every 2 hours we are checking the restraint itself, their skin, their breathing. Make sure that we are checking their vital signs as well in order to identify if there's any complications that could have arisen. Now, we also need to continuously assess and document the need for the restraint. If there's no longer need for that, then we need to discontinue and document. Now, we also need to offer toileting to our patients, fluid intake every 2 hours, and that's basically part of the care. Okay. Now, we are going to talk about the documentation of the restraints. This is very important. Again, we are going to put in the medical record why we are putting the restraints on, the purpose. We need to also describe how the safety device is applied and to record the date and time the safety device was put on. And we need also to note how long the device was used and how the client responded, and also include in the documentation when the device was removed for exercise and check for circulation, for the nerve function, and also the skin condition. Now, it is also important for us to assess if the safety device is still necessary and to make sure that we are also recording how the client reacted to using that device. Now, moving forward here, we have to also do some or follow the guidelines regarding the alternatives to the restraints. So one of those would be to orient the client and their family to their surroundings. Make sure that we are also providing companionship, supervision, also with the use of the trained sitter. So before we are actually going to apply those restraints, there are ways that we can pacify the patient, make sure that we are doing the least restrictive amount of what do you call this? Restrictive restraint, right? We really don't want to use those as much as possible if it is also unavoidable. Now, another thing that we need to keep in mind is to offer activities like towel folding for distraction. And I've had so many experiences with this, having worked in the neuro stroke unit, and we have a large population of elderly people that have some chronic insomnia or just being agitated at nighttime. So we do a lot of activities for them, especially like towel folding or yeah, so these are the stuff that we have actually done so far for them in order to pacify them. Another is to place the patient in a room that is closest to the nurse's station. We also use the calming techniques, and we also talk to them to diffuse their aggression, and we also provide visual or sound stimulation, and we also block those stairways from their view. We also use gowns or cover their IV lines to prevent them from ripping off their IV axis. We also need to encourage relaxation methods to improve their sleep. Also promote regular exercise and walking, and especially during the daytime. So they'll be resting mostly at night. Now, we also need to plan the use for their toileting, food intake, pain management needs as well. And if there is such a way to stop those uncomfortable treatments, then discontinue them as soon as possible if they are unnecessary. Now, let's move on into the topic about poisoning, which is basically a common occurrence mostly in the home setting. It's not happening a lot in the acute care, but we need to know what exactly this poison is. It could be in a form of a substance, right? That can be ingested or inhaled or absorbed. And we do have specific antidotes or treatments that are available for some poisons. Now, what do we do if in case our patient gets poisoned? Um, then we have to remove any of that substance from their mouth, their eyes, or body right away. And we need to identify the poison and amount to determine the treatment. And we need to call the poison control before taking action. And if we are instructed, we need to call the ambulance to take the person to the ER. And if they're vomiting, uh, save the vomitus if requested, and it needs to be brought to the ER as well to identify the poison. And if in case uh, the patient has swallowed these substances like lye, cleaners, grease, or petroleum products, we don't normally induce vomiting. And we never induce vomiting for those patients that are unconscious. Okay. Now, again, recall that before you take any action to anyone that has poisoned, we need to really call the poison control. And this is going to be a big deal in the NCLEX. Now, let's move into the different precautions, especially standard precautions. So, this is something that we need to follow for all our patients, regardless of their diagnosis or their infection risk. We know that the standard precautions include the hand washing right before and after removing or placing the gloves, use of mask, eye protection, and goggles, gowns as necessary. And so the standard precautions are actually going to be applicable to blood or body fluids, even if they don't contain blood, or for those secretions, excretions, broken skin, and also mucous membrane. So, what do we do when we are practicing the standard precautions? So, this is just a quick review. We need to make sure that you're doing your hand washing before or between the patient care, after touching the blood, body fluids, secretions, excretions, broken skin. You need to wash your hands after removing the gloves as well. Now, always wear gloves when touching blood or body fluids, secretions, or excretions, or for any presence of broken skin, contaminated items. And we need to remove the gloves and wash hands between patients. Okay. Now, another thing that you need to recall is we can use the alcohol-based hand rubs when hands aren't visibly dirty. And we can also wear the masks, eye protection, or face shields if there's a chance of splashes or sprays of blood or body fluids during patient care. And we need to also use gowns if there is a risk of getting clothes dirty with blood or body fluids. And we need to wash hands after removing the gown as well. Now, we need to recall about the proper donning and doffing of the personal protective equipment. And so, for the PPE donning, we should start with the hand hygiene. You got to wash your hands first with soap and water, or it could be hand sanitizer to ensure that they're clean before putting on any PPE. And then this is followed by the placing of the gown. You're going to have to slip your arms into the sleeves. You're going to have to fasten the ties or Velcro at the neck and the waist, and making sure that the gown is fully covering your torso from the neck to the knees, and it's actually wrapping around your back. Okay. Now, the next is the placement of the respirator or mask. You got to have to place the mask over your nose and the mouth and secure the mask or the goggles by tying the straps, or actually not the goggles or the respirators. So you need to adjust the ear loops as well. Now, if you're using the N95, ensure that it fits snugly over your face and the chin. And then you're going to have to perform a fit check by inhaling and exhaling to ensure that there are no air leaks. Now, the next equipment that you should wear is the goggle or the face shield. So it needs to cover your eyes or face, and you can adjust as needed to ensure they fit securely and comfortably and providing full coverage without gaps. Now, the next is the placement of the gloves. So you're going to have to put this on last, ensuring that they are covering the cuffs of the gown and to prevent any exposure of the skin at the wrist. Now let's go into the duffing steps. So you are going to have to start removing the gloves first, as they are the most contaminated. So you're going to have to pinch the outside of one glove at the wrist, and you're going to peel it away from your hand, turning it inside out. And you're going to hold the removed glove in your gloved hand. Then you're going to have to slide two fingers under the cuff at the remaining glove and peel it off over the first glove, and then you can dispose them properly. So just taking a peek over here. Now moving into the next step is the removal of the goggles or face shield. You can handle first the straps or earpieces, avoiding contact with the front of the goggles or the face shield, and you can place them in a designated area for cleaning or disposal. Now, the next one is the removal of the gown. You can untie or unfasten the gown at the neck and the waist area, and make sure that you're pulling the gown away from your body, touching only the inside. And you can turn the gown inside out as you're going to remove it and roll it up. And make sure that you're discarding it in a proper container as well. Now, the second equipment will be to remove the mask or respirator by touching only the straps or the ties. And you have to lean forward slightly and untie or lift the straps. And you can pull the mask away from your face. Make sure that you're avoiding touching the front of the mask and dispose it properly. And then lastly, you have to do the hand hygiene. Again, immediately after removing the last piece of PPE. You can use soap and water or the alcohol-based hand rub. Now, let's move into the next topic about the disinfection, control or disinfection or cleaning of the equipment. And so make sure that after each use, you're going to clean and disinfect the equipment and discard those single-use items. And we need to place those contaminated linens in leak-proof containers or leak-proof bags, and we handle them minimally. And make sure that we're also using those needleless systems or like safety devices to prevent needle sticks. And as far as like disposal of the sharps, we need to put them in a puncture-proof containers. And it is very important that we don't recap needles, okay? And we can also use the 1:10 bleach solution whenever there is going to be a spill of body fluids or anything like that, just in case. Now, we are going to talk about the transmission-based precautions. So we'll start first with the airborne precautions here. And so we are going to use this for infections such as measles, chickenpox, disseminated varicella zoster, TB, also COVID-19. And keep in mind that the barrier protection that we'll be employing here will be a single room with a negative pressure to keep the door closed. And this is something that you should be doing, especially in a TB patient and COVID-19. And we need to maintain airflow with a 6 to 12 air exchanges per hour using a HEPA filter, and use of the N95 for the healthcare workers. And for the COVID-19, we are going to have to include droplet and contact precautions as well per guidelines. and make sure that you, as the caregiver, will be wearing surgical mask. Um, or actually the patient rather is the if they're going to leave the room maybe for a diagnostic procedure, then they should be wearing the surgical mask before leaving the room to prevent your transmission. Now, let's move ahead to the droplet precautions, and this is intended for the following infections like flu, meningitis, mumps, pneumonia, rubella, scarlet fever, sepsis, and COVID 19. And the barrier protection that should be included are the following: private room or to cohort with the same patient with the same infection. We're going to have to wear surgical mask within 3 feet of the patient. And for COVID 19 patient, we are also going to add the airborne and contact precautions. And eye protection is also important here. And when the patient is going to be required to leave the room, maybe for a maybe for a diagnostic exam, then they have to wear a mask to prevent transmission. Now, lastly, we're going to have the contact precautions, and this is intended for the multi-drug infections, multi-drug resistant infections. It could be C. diff, respiratory syncytial virus, or the RSV, flu, wound and skin eye infections. And the things that we need to include here are the following. We're going to have to make sure you're wearing the gown. We also wash your hands with soap and water, especially for C. diff, and avoiding sharing of equipment. And we need to use bleach to kill the spore. So, if unavoidable, there are some facilities that probably have lesser equipment. So, let's say vital signs machines, pulse oximeters. Most of these devices need to be disinfected with the bleach solution before use to the next patient. But ideally, each patient room should have its own equipment to prevent the transmission of the infection. Now, let's move forward into the next section of our topic, and we'll be talking about the biological warfare agents. And we know that a biological or chemical substance used in warfare can cause some massive destruction and death. And one of those is the anthrax. This is actually caused by the bacteria Bacillus anthracis. And this is something that can be contracted through digestion, skin, through the wounds, or it could be inhaled. And this is going to be transmitted through direct contact with the bacteria. And also their spores, which can activate the inside, which can be activated inside the host. And however, though, the anthrax cannot be spread from one person to the next person. Now, as we're going to talk about the progression here, this will usually can travel to the lymph nodes and it can spread through the bloodstream and also the lymph as well. So with that, the toxins can actually cause the shock and also death. Now, what is the impact here to the respiratory system? It can actually cause fluid buildup. It can lead to tissue damage and also death if untreated. Now, what would be the detection here? It is going to be identified by detecting the bacteria's DNA. Now, for the treatment, this is an infection that can be treated with the antibiotics like ciprofloxacin, doxycycline, penicillin. And as far as the vaccination, there is a limited vaccine available for the anthrax. Now, let's talk about the smallpox. This is a infection caused by the variola virus, and this is something that is spread through air droplets, also contaminated objects, and this is transmitted via the air droplets as well. Now, as far as the symptoms, this is going to start appearing 7 to 17 days after the exposure. And this is going to start with the fever, back pain, vomiting, and headache. And after 2 days of exposure, there's going to be formation of the rash. There's going to be conversion into papules, and this will be converted into pustules as well, especially in the face and also the extremities. And if you're going to ask about the vaccine, there's going to be available vaccine for this, for those who are at risk. But as far as the treatment, these are the two medications that are approved by the FDA. This is the tecovirimat and also the brincidofovir. Now let's talk about the next infection, which is the botulism, and this is caused by the nerve toxin we call as the Clostridium botulinum, which is a potentially fatal microorganism within 24 hours. And this is easily transmitted, can be found in the soil, it can spread through the air, food, especially canned goods, contaminated wounds, and this can be transmitted via the air, canned food, or contaminated food. Please take note that this is not going to be transmitted from person to the next person. And the symptoms are the following. The patient can complain about the abdominal pain, the nausea, vomiting, some swallowing difficulty, or difficulty in speaking, and muscle weakness as well. Now, as far as the progression, this is going to lead to paralysis within hours to days of exposure, and this will require the patient some mechanical ventilation as well. Now, talking about the treatment here, we are going to be able to treat this by administering the antitoxin, which can block the circulating toxins if caught early on. There's also a chance that surgical treatment can be done in cases of wound botulism. Surgery may be needed to remove the source, and antibiotics can also help with this. Now, there's no vaccine available for the botulism as of the moment. Now, let's talk about the next biological agent, which could be the plague. So this is caused by the Yersinia pestis, typically found in rodents and fleas, and this is something that can be transmitted via flea bites, contaminated meat, or handling infected animals. And there are three forms of this. There's actually one, the bubonic plague, which is the most common one. We also have the pneumonic type and the septicemic, which is the most deadly type. Now, what are the symptoms of the plague? This can start within 1 to 3 days after exposure, including fever, chest pain, swollen lymph nodes, and also coughing of blood. And this can actually progress into a respiratory failure, shock, and death. And now, as far as the treatment, there will be antibiotics like the streptomycin or gentamicin that can be administered to treat this infection. And as far as the vaccination, that is also available. Now, the next biological warfare agent is the tularemia. This is what we refer to as the rabbit fever or deer fly fever, and this is caused by the microorganism Francisella tularensis, and this is easily transmitted by ticks, deer flies, or contact with infected animals. And so if you're going to get the infection, you're going to manifest the following: fever, headache, skin ulcers, lymph node swelling, or it could be eye infections or pneumonia. And this can be treated with the following: streptomycin, gentamicin, or ciprofloxacin. And as far as the immunity, this will provide their recovery. After the recovery of the infection, this will provide a lifelong immunity as well. And there is a vaccine available for this type of infection. Now, the last one, or not really the last one, second to the last, is the hemorrhagic fever. This is caused by the viruses like the Marburg, Lassa, Janine, and also Ebola. And this can be transmitted by rodents or mosquitoes, and this can be spread through the body fluids, through the GI tract, the wound as well. And the manifestations are the following: headache, nausea, vomiting, organ failure, and also bleeding of the organs. Now, we're going to treat the hemorrhagic fever symptomatically. There's not really a specific treatment for this one. However, though, this can also lead to paralysis. Now, let's move forward into the other infection, which is basically the Ebola virus, or known as the EBD. This is caused by the Filoviridae family, which was first discovered in 1976. And the transmission here is through contact with the contaminated clothing, needles, medical equipment. The symptoms that the patient will be manifesting are the following. They can have fever, headache, um, also muscle pain, vomiting, and they can also bleed during the exposure or after the exposure, usually around 21 days. When you are going to assess this patient, make sure that you ask them about their recent travel to areas with high incidence of Ebola virus disease. And our interventions here will be geared towards isolating the patient in a private room, make sure that the healthcare workers are protecting themselves with a PPE and minimize the exposure of the infection. Now, as we're going to talk about the biological warfare, basically, our role here as nurses is going to make sure that we are aware, we should be prepared to assess the situation quickly. And this simply means that we need to be able to figure out what kind of event it is and how many people might have been affected and when they can expect clients to show up at the healthcare facility. So these are things that we should be able to do. And we need to stay alert to the fact that these microorganisms can also change and make them more dangerous. Hello, everyone. Today I'll talk about medication administration and intravenous therapies. So I want you to hang tight and get ready with your pen and notebook to jot down important concepts. And I'll be talking all throughout the same topic or chapters. So it is very important for us to review this section as we are going to explore into the critical guidelines and also the best practices in the administration of the medications and also the intravenous therapies so that we can answer the correct options in the NCLEX. Now, we know that the medication administration is very important and also a nursing responsibility that is quite critical because this can really impact our patient safety and also the treatment outcomes. So let's get right into the first part of our topic here, which is basically the administration. So here we're going to have to review the guidelines that you should stick. So let's go into these. So we'll start first with the reviewing of the medication order. So we need to verify the doctor's prescription before we proceed in the administration or the preparation of the medication. Now, this is something that should be followed by comparing the current medication order with all other medications the patient was previously taking to avoid errors. And this will give you a good idea if there is an adjustment of the patient's dose, maybe it's going to be an increment, or if there was a need to decrease the drug dose. Now, another thing that we need to keep in mind before we administer the medication is to ask about the patient's allergies and also if they're taking any supplements, over-the-counter medications. Also, we need to assess the condition of the patient to make sure that the prescribed medication or the intravenous solution aligns with the patient's current health. And there is a definite reason why we are administering that drug. Is this intended for this patient's condition? Now, we need to also confirm the patient's understanding why they're taking this drug and how long they're going to be taking that drug as well. Now, we need to also educate the patient about how to use the medication properly, especially if they're going to be taking this medication at home for continued use. And we need to also address their concerns, make sure that we can discuss with them and also resolve any social, cultural maybe, or religious or spiritual concerns that the patient may have regarding this medication. Now, another is we can have to check the dosage conversions. If needed, we need to calculate and confirm the proper medication dosage before we administer it. And I really want you to recall the rights of the medication administration. Commonly, we do have the 10 rights, and one of those is the right patient, which is signifying that the medication is supposed to be given to the right person, to the right individual. We need to verify their identity. We have to use at least two identifiers, such as their name and their date of birth. Now, another part of the rights of medication administration is the right drug or right medication. We're going to have to confirm that the medication is being administered is going to match the prescription. That is the right drug. Now, another thing is the right dosage. We have to check the dosage if it is accurate according to the prescription, and we need to verify any calculations. And then we also have the right route. We make sure that the medication is given to the correct route. Could be oral, could be intravenous or subcutaneous. And the next one is the right time. This is something that we need to think about. Make sure that we are administering the drug at the correct time, considering the factors like, let's say, the time of the day, the timing of their meals, and also the frequency of when to administer the medication. And we also have to keep in mind that we are doing the correct assessments. We are going to perform those blood pressure measurement, could be the heart rate measurement, or could be the blood sugar measurement before we give this particular drug, because this could possibly cause a drop in the blood pressure or cause a drop in their heart rate or the blood sugar. We want to make sure that our patient is safe to take the intended medication. Now, another thing is we need to check for the right education. This is very important. We need to inform our patient about why we are giving it to them, the purpose, the potential side effects, the adverse effects, and that includes teaching them of what to report in case they will start experiencing the side effects. We need to let them know that they have to notify us as soon as possible. Now, another is the right documentation. We make sure that we are recording the time when we exactly administer the drug in the medical record. It could be the electronic or it could be the paper-based medication administration record. We have to make sure that we are not doing fraudulent entry as far as the time of the administration. Now, another is the right evaluation. We need to also monitor the patient after we administer the medication to check if the drug is effective. Let's say if this is the pain medication addressing the pain level of 10 out of 10 for their abdominal pain, or is there nausea, or is the patient vomiting controlled after we give them a dose of ondansetron or Zofran, or let's say metoclopramide. And lastly, we have to take note about the right of this patient to refuse. They have that right to refuse any medication, but we need to make sure that they are of their sound mind, that they have their reasoning why they don't want to take this medication. And before we're going to decide that, hey, I'm just going to not going to give this medication, we need to give them the correct education, explain to them why this medication is very important. We need to tell them the risks and also the benefits if they're going to take the drug or not take the medication. This is something that you need to respect and make sure that you document this in the medical record, and then you inform the medical provider that they refused the medication. Now, another thing that we need to keep in mind as far as the medication administration is that we'll let the patient know that they have rights, such as not receiving unnecessary drugs, that they have the right of information if the medication is experimental, and they're receiving proper support during the treatment. And we also need to make sure that we are also checking their vital signs, the lab results, and any possible food or drug interactions before we give this medication to them. And also, we need to make sure we are monitoring the patient's reaction or response to the treatment. This is part of our safety goal. Now, around this time, we need to talk about the metric system, because this is very important for us to really familiarize or refamiliarize with this system, which is basically the standard measurement in healthcare. Now, this is very important for us in the calculation of the dosages of the medication when we are preparing these medication to ensure patient safety. Now, as we were talking about the metric system, this is going to comprise several basic units, and each of this unit have different dimensions. So we're going to talk first about the common abbreviations. We have the meter there, represented by the small m. We got the liter, small big L. We have the milliliter and kilogram. We got the gram, represented as a small g. Milligram is mg, and microgram is mcg. And also we have the mil equivalent as MEQ. Now, let's talk about unit equivalents. What are these things? We need to make sure that there is actually equivalences between the different metric units, which is very critical for us to accurately calculate the drug. Okay, so we have the following: the 1 mcg, which is equivalent to that in gram, right? And then we have the 1 milligram, which is equivalent to about 1,000 micrograms, and 1 gram, which is equivalent to 1 gram is 1,000 milligrams, and we have 1 kilogram as 1,000 grams, and 1 kilogram, which is equivalent to 2.2 pounds, and 1 ml, which is equivalent to 0.001 liter. Now, there's other measures that you need to refamiliarize. So we have this mil equivalent, which is basically the measurement of this particular medication in grams of a medication in an ml of a solution. So this is particularly important, especially for electrolytes such as potassium, wherein we're going to need to have a precise dosing, which is very critical for maintaining their electrolyte balance. Now, another is the units, which is used for the measurement of the medication based on their effect rather than their weight. And this is something that we commonly use for medications like penicillin, insulin, heparin, where the therapeutic effect is more relevant than the actual weight of the medication. Now let's move on into the metric conversion. So this is basically based on the decimals, making it very straightforward to convert between different units. And to perform the conversions, you can either multiply or divide by 1,000, which involves moving the decimal point 3 spaces to the right, or moving the the decimal point to the left side. Now, when we are converting a large unit into a smaller unit, we have to do that by multiplying it by 1,000, or we're going to have to move the decimal point 3 places to the right. So for example, here we have our 2 kilograms. To convert 2 kilograms into milligrams, what we can do here is to basically multiply the 2 grams by 1,000, which will result into 2,000 milligrams. Now, if we are going to convert a small unit to a larger unit, for example, if let's say we're talking about 250 mLs to be converted into liter, then what we can do is we are going to divide it by 1,000, or what we can do is to move the decimal 3 places to the left. But with the use of the division, what we can do here is we can convert that 250 mLs to liters by dividing 250 mLs by 1,000, which will result into 0.25 liter. Now, we're also going to talk about the medication labels, and these are very important for us to pay attention to so that we can ensure safe and also accurate drug administration. So we'll see that a particular label will have a medication name, such as a generic name of the medication, which is the universal. This is a non-branded name of the drug, which is the furosemide. And some of the medications may display the trade name, or what we call as the brand name, such as Lasix, which is a proprietary name that is given by the manufacturer. So again, for this instance, the generic name here is furosemide, and the brand name is Lasix. So we are gonna refamiliarize again with both names here. But in the NCLEX, what usually can happen is that they're going to give us the name, the generic name rather, of the medication. They will rarely use a brand name when they're going to ask us about pharmacological tests or any to ask us for pharmacological management. Now, let's talk about the expiration date. This is very important. You got to make sure that you are looking into the manufacturer date and also the expiration date, because you have to do something about it, especially if the medication has already been expired. You're not going to give that medication, of course. What you're going to need to do is to get that drug returned to the pharmacy. If, let's say, you're working in the acute care institution, you need to make sure that that drug is going to be disposed in the correct container as well, if that is the practice. But usually, if we have medications that are already expired, we usually will return them to the pharmacy, so they'll be able to also account the medication that had been expired in the system. Now we'll talk about the medication prescription. So let's break down the key components of the medication prescription to ensure clarity when administering or reviewing the medication order. So this is just an example of, let's say, a script electronically. So it should have that patient's name, such as John Doe, John E. Doe. So that is the patient's name. But before we go to do that, let's just go through here what I did with the highlights here. So the medication metoprolol, this is the medication name. So this is the specific name of the medication to be given. It could be either the brand name or the generic name. And we nurses should confirm that it matches the medication order. Okay. Now the next one is the dosage, which is the 25. That is the number of the specific numerical value of the drug in milligrams. Okay. It could be some other medications that may use micrograms, or it could be units. But in this case, we're using the milligrams for the metoprolol. Now we need to also check the route of the medication. This is going to tell us how the medication should be given. It could be oral, it could be IV, it could be IM, sub-Q, or it could be inhalation. And we need to make sure that we are only administering the medication as ordered. Okay. If there is an error, how the medication has been ordered by the medical provider, we need to get that rectified, verify it, and get that corrected. Okay. Do not just assume that, hey, the doctor has made a mistake and I'm just going to give this as oral because I know that this is for oral route. No, you got to make sure that that route is corrected before you administer that in order to officially correct that medication order. Okay. Now, another is the frequency, the time. This is going to tell us how often the medication should be administered. Let's say every 6 hours, every day, or twice a day. And this can vary from the institution or the facility. They have their own standardized frequencies. But as nurses, we need to know the patient's need as well, and also their condition. So we'll be able to carefully adjust the frequency of when to exactly give the medication. Now, another component here is the prescriber signature. So this should be the person who has entered the order. It could be the MD or the DO, or it could be the physician's assistant, or it could be the family nurse practitioner, or it could be the dentist, okay? Or it could be the pharmacy or the the Pharm D. We call them as the pharmacist. So they also have some privileges to actually write down medication orders. Now, another thing that we need to pay attention is the name of the patient. There should be that first and last name. This is supposed to be added in the prescription to know exactly who this patient is, right? We want to make sure that we have the correct individual that should receive the medication, okay? And this is something that we need to do before we administer the drug. We need to double check the patient's information or identifier, such as their first and last name and their date of birth. Now, another thing is the date and time of the prescription. When is this supposed to start? So this will ensure that the prescription is recent and it is valid. So this will give us an idea, the specific time or window of when to administer the medication, especially for acute or time-sensitive treatments. All right? So don't forget about those necessary components of a medication prescription. Let's get into the oral medications. Now, you might notice that there are some medications, let's say in the form of tablets, capsules, or liquids. And if we are talking about those tablets, there's what we call them a scored tablet. So what does that mean? So imagine you're holding a tablet with a line down the middle, just like this one right here. You see that line or crisscross right here? So this is what we call a scored tablet. So that little line isn't just for a show. It is designed to help you break the tablet into halves or even quarters when needed as prescribed. So, but here's the key though. You need to always follow the facility's policy before splitting them. So it can ensure a much more precise administration of the drug, which is very important in correct or accurate dosing. Now, another we have is the enteric-coated or the sustained release capsule. So what are these medications? They are finely tuned time machines. So such as the enteric-coated tablets, or let's say the sustained release capsules, they are designated to release the drug slowly in order to bypass the stomach acids for absorption in a different part of the body. And they are specifically to be absorbed by the small intestine, such as the duodenum. And so if you are going to crush them, or let's say you're going to melt them in a liquid, or if you're going to allow the patient to chew on it, if they are enteric or if they are time release, it can cause the medication to work way too fast, which can probably lead to toxic effects. It can possibly irritate their stomach lining as well. So think of these medications as needing their protective bubble to let them do their job as intended. Now we also have the capsules, which can contain maybe a powder or a powder component, or let's say oil. So the capsules are basically little packages of these substances. They're tucked in a gelatin or like a shell, and these medications are supposed to be swallowed whole. But in occasion, depending on the patient's needs, you might be given specific instructions to open or mix them in a particular way. So you got to make sure that you're always checking the medication guide or orders, because these gelatin houses may be fragile. They're holding potent medicine. Now let's move into the liquid medication. So when it comes to the liquids, you got to be precise in preparing the medication. So these solutions are carefully labeled with exact amounts, making the dosing a breeze. So just pour the correct amount and you're good to go. So whether it's for a child or an adult, the liquid medications are the heroes when swallowing pills, if pills are so tough to even take. And the use of the medicine cup right here, you have here this filled medicine cup with an orange liquid. Most of these cups are standardized. They can hold about 30 mLs of fluids, or let's say 1 ounce, and they are going to come with marked uh, lines where we can see all those measurements. And there's also that spoons that are disposable spoons or cup. They actually have those measurements as well. And why are we going to have to use these very important tools? The reason for that is because that's the only way to be sure that you're giving exactly the right dosage of the medication. So just one wrong glance and you could overfill or underfill these tiny measurement or these devices. Now, you're also going to see some medications for oral drugs. You probably would have to use the syringes as well, which is intended to measure those small doses. So when you're going to deal with anything that is less than 5 mLs, especially for children, you got to really use that syringe. Sans the needle, of course. So you got to make sure that there is pinpoint accuracy. Even a little bit extra can make a difference when treating our smallest patients. Now, let's talk about the parenteral medication. So these are those drugs that are injected into the body. It could be in a form of IV, IM, subcutaneous, or intradermal. And they can come into ampules, vials, syringes, cartridges. And most of the time when we are going to administer this medication, we're going to use the 3 ml syringe. And it's going to be marked by 0.1 mLs increments, and it is used for most injections. So when we are actually drawing the medication, the top ring of the plunger, which is basically right here, it should align with the required dose. And we don't inject more than 3 mLs, okay? Especially for a single intramuscular site, we don't inject more than the 3 mLs for a deltoid site. Or what we're going to have to do is to inject 0.5 to 1.5 ml for a subcutaneous injection. No volume greater than that. And we also need to check for the large doses as well, because this can potentially cause some toxicity to our patient or overdosage. Now, for the subcutaneous injections, what we're going to use here is to use the 25 gauge needle, and we're going to have to use that 45 or 90 degrees angle. And for the IM injections, the needle size can vary based on the patient's weight and also the body fat. And so the larger needles are actually going to be needed for more viscous medications. Now, for the intradermal injections, we're going to have to use the tuberculin syringe or the 5 to 15 degree angle to do that accurate administration, right? And another thing that we need to do is to use the tuberculin syringe, or actually the insulin syringe, when we are administering those insulin, different types of insulin. And so this can come into different sizes. There are insulin syringes that comes in 30 or 50 unit syringes. But for the regular and pH insulin that can't be combined in one syringe, we usually will have to draw the regular insulin first. Now, there are also other available options in administering insulin, such as pumps, or it could be pens. And we also need to exercise the proper use of the needles. There are some safety guidelines that we need to abide in, also the use of the guards, needle guards, in order to reduce the risk of needle stick injuries. Now, let's talk about the reconstitution of injectable medications. Those are going to be available in powder form, and they must be dissolved, reconstituted. And this is something that you should really keep in mind. You got to follow the instructions on the vial for the reconstitution details, including the final volume and expiration after mixing. So what you need to do here is to follow the exact steps. We got to gather the materials. We want to make sure that we get the vial with the powdered medication and the vial with the exact diluent, like sterile water, it could be the saline. And we need to disinfect the vials, especially the stoppers. When we remove the caps from both the vials, we will have to wipe those tops or the stoppers with alcohol swabs, and then we'll let them dry first before puncturing them with the syringe to aspirate those medications. Now we gotta prepare the syringe. So what we need to do is to pull back the syringe plunger to draw air first, and this should be equal to the amount of the diluent you need to withdraw, as recommended by the manufacturer. And then we're gonna have to inject air with the diluent into the vial. On a flat surface, we're gonna inject the air into the airspace of the diluent vial. Now, next to that is we're going to have to withdraw the diluent. We are going to invert the diluent vial and pull back the plunger to withdraw the correct amount of fluid, and then keep the needle tip below the liquid surface. Now, we're going to have to use air pressure this time. So you're going to have to let the pressure from the vial fill the syringe. And if needed, you're going to pull the plunger slightly to get the right amount of the diluent. Now, this time we're going to have to mix the powder. You're going to have to inject the diluent into the vial with the powdered medication. Then we're going to have to remove the needle. Now, we're going to have to mix the medication gently by rolling the vial between your palms to mix it until the powder is fully dissolved. We are not going to shake the vial because this can form bubbles. And this can also alter the consistency. Now, before we're going to administer the drug, make sure that we have read the label carefully to see the dose after the reconstitution. And we're going to have to withdraw the medication in the appropriate syringe. We want to make sure that we are drawing the exact amount of the reconstituted medication for the ordered dose. And again, double check the calculations. Now, this time we're going to talk about the dosage calculation. So here, for example, if the prescription says give 5,000 units of heparin subcutaneously, and the medication vial shows 7,500 units per ml. Now, the question here is, how many mLs should the nurse draw up? And you're going to need to round the answer to the nearest tenth. Now, to use the standard formula, here is the formula. You can either use this basic formula. So the D is the desired, okay? It's the desired dose. This is the prescription that the doctor has ordered for us. Then we have the letter A, which is going to be the divisor. This is the available stock. It is the dose strength as stated in the medication label. And we have the Q, which is the volume in which the dosage strength is available. So it could be in a form of tablet, or it could be a liquid. It could be in mLs. Now, we're going to have to substitute the following components of the formula. So since we're going to use the top numerical value, this is our desired. This is a doctor's order, which is the 5,000 units. We're going to have to divide it by the available dose, which is the 7,500 units. You're going to have to multiply it by the 1 ml, which is basically what's stated in the preparation. So we're going to be getting that exact number of 0.66 ml or 0.7 ml to be exact, okay? We are going to round it to the nearest tenth. All right, let's move on into our next calculation. So if we are going to use the dimensional formula, which is another method of doing it. So what we're going to need to do here first is to identify the unit needed in mLs, and we're going to write it on the right side of the equation, okay? And we're going to put the prescribed dose, which is the 5,000 units, as the numerator of the first fraction. After that, we are going to use the medication concentration as the conversion factor, which is the 7,500 units per ml. And since the units are in the numerator of the first fraction, they should be in the denominator of the second fraction to cancel out, leaving only the mLs in the numerator. So this is how we're going to do that. That is our 5,000 units, which is the order dose. We are going to have to multiply that with the 1 ml. And our denominator here will be the 7,500 units. You're going to have to, since the measure is units in the numerator and the denominator, you will cancel each other out. So we're going to only leave the mLs, which is the desired unit measure in this question. So we're going to have to cancel the units, leaving only the ml. So we're going to have to perform the math by multiplying across the numerators. So 5,000 units multiplied by the 1 ml. And then, of course, just the 7,500 units on its own. Now, we are going to yield that, or we're going to get that exact number of 0.66 mLs. But again, our task here is to round it off to the nearest tenth, which is going to be 0.7 ml. Now, we're going to also take note about the different guidelines in the calculation of the correct dose. So the key point here is that if a prescription requires more than 3 tablets to achieve a single dose, it's very important that you're going to have to review the order and confirm its accuracy. This could indicate a potential medication dose error, right? And another thing that you got to do is to double check parenteral doses that seems too big to administer for this patient. And just like with oral medications, if a parenteral dose seems unusually bigger, then you got to start questioning, is this something that could be safely taken by my patient? As soon as you're going to think about some kind of a doubt, make sure that you do that follow-up calculation. Now, another thing that you need to keep in mind is to make sure that you have all the units being consistent and converting when necessary. So make sure that the units will match, let's say milligram to milligram or mLs to mLs, and you're going to perform the conversions when required to prevent the mistakes. Now, for injection doses, these are usually rounded to the nearest 0.1 ml, measured using the 3 ml syringe, right? So the key point here is that most IV injections or injections in general, the doses are rounded to the nearest tenth of a milliliter rather, and are typically measured using a 3 ml syringe, ensuring that we are giving an accurate drug dose. Now, for the smaller, or let's say critical doses, we need to round them to the hundredths place, and we're going to measure it in a 1 ml syringe, because these will require really precise extraction of that liquid medication. Now, as a key point here, for those very critical doses that will really require us to do precision in the measurement, we have to make sure that we are going to use or rounding them off by the hundredths. Okay, don't forget that. Now, when we are going to use that dimensional analysis to calculate the dosage, we should make sure that we have to independently do that. And if you are in doubt, make sure that you have another nurse do that calculation independently. If in case we are going to calculate those high-risk medications, let's say insulin, could be heparin or dopamine, these medications will require 2 licensed personnel to do independent calculation. Now let's talk about the this type of a medication here. So the example here is on a drug that is fluorouracil, which is to be given 12 milligrams per kilo per day for a patient that weighs 176 pounds. And then the available drug here is 500 milligrams per 10 ml. So the question here is, how many mLs should the nurse administer per day? So what you're going to do here first is to make sure you're converting the patient's weight from pounds to kilograms. You're going to divide it by the number by the pounds in the patient weight. And so the patient weighed 176 pounds, right? And so when converted, it's 80 kilograms. And then the second step here will be this. You're going to have to multiply the order dose by the patient's weight in kilograms. So that will be 12 milligrams by going to multiply it by the 80 kilograms, which will be 960 milligrams per day. And the third step here is to determine the volume in mLs. So if you're administering that, you're going to either use the basic formula of D over H times the volume. So that will be 960 milligrams. You're going to divide it by the 50 milligrams, which is the actual concentration of the medication. Let me see if I can. Okay, so that's the zoom that I can only do this time. So that would be the 50 milligrams. So this is going to result into 19.2 mLs of that fluorouracil. Okay, let's talk about doing that in a dimensional analysis. So this is the basic formula for that same medication calculation. So when we are going to do that, again, we'll have to use the dimensional analysis setup here. So you have to make sure, again, convert the patient's weight of 176 pounds. You got to convert it to kilograms. And so since 1 kilo is equivalent to 2.2 pounds, you are going to divide it by 170. You're going to divide 176 pounds by 2.2 to get to 80 kilograms. Now, when you are going to calculate the dose, again, you're going to have to prescribe the medication 12 milligrams per kilo by the patient's weight in kilo. So this is what's done in the basic formula. Now, for the dimension analysis, this is something that will that you should be doing. You're going to break down the calculation into a continuous calculation. You're going to show how the different units are. Let's say the milligrams, the kilos, the mLs. You're going to have to cancel each other out. So you're only going to leave with the final answer in the mL. So we're going to have to cancel the milligrams here, the kilograms, and also the pound. Okay. So you all have the numerators here, which is the volume, the preparation, the stack in hand. It's going to be 50 milligrams per. Each ml is 50 milligrams, and then this is something that you can multiply by the 12 milligrams. Of course, you got your denominator here, 1 kilo, and of course, you're going to have to do your calculation. You're going to multiply it by 1 kilogram, and then you're going to multiply it by the 176 pounds as well. So you just cancel them out, and this will result into 2,112 mLs. You're going to divide it by the 110. So this will result into 19.2 mL. So make sure that you're going to use that syringe. This is going to be a bigger syringe that you will be using. It's 19.2 mLs. Make sure that you have the correct volume. Make sure that they are getting the exact volume per day for this fluorouracil. Now, we're also going to have the ratio, percentage and ratio. So this is something that will show you the concentration of the medication in grams. Let's say in 100 mLs of a solution. So for example, we have the 10% calcium gluconate, which simply means that the solution has 10 grams of calcium per 100 mLs. And we also have the ratio solution, which simply means that this is telling us that this is the medication is expressed in grams per ml. So for example, a medication like epinephrine, 1:1,000, that simply means that there is 1 gram of epinephrine in 1,000 mLs. All right. Now let's move on into our intravenous flow rates. Here we're going to make sure that we are able to monitor the flow rates of our patient often, even when we are using the IV pump. And if in case you're running behind on schedule, you have to ask the primary healthcare provider first before you increase the flow rate. If we have not really administered the correct volume at the correct time. Okay, do not increase the rate of the administration, because this can do some issues to our patients who probably would not be able to tolerate an abrupt rate change. So this can really compromise them. They could probably develop exacerbation of their congestive heart failure. And so most of the calculations will involve the conversion of mLs per hour to drops per minute. And we know that the IV tubing that we'll be using is already calibrated in drops per ml. And in the standard tubing, this is probably going to be, it could probably come in 10 to 20 drops to 1 ml. And we also have that mini drop or that micro drop set, which is going to be used to deliver much more accurate measurement, especially in the critical care or for our pediatric patients. And our micro drip setup, they come in 60 drops, and this is equal to 1 ml as well. All right. Now, when we are going to calculate this one, the prescription is 1 liter of 0.9% sodium chloride, normal saline, to be infused over 12 hours. What is the flow rate in the tubing? What is the flow rate, rather, if the tubing is set at 15 drops per ml? So how are you going to calculate this? We are going to use this formula, which is total volume multiplied by the drop factor divided by the time in minutes. So what we need to do here is to convert the hours to minutes. So for example, it said to be infused over 12 hours. So we're going to convert that number of hours by multiplying it by 60 minutes. So this will result into 720 minutes. Now we can proceed in substituting the formula with the corresponding value, such as 1,000 ml. We're going to multiply it by the 15 drops per ml and divide it by the infusion time in minutes, which is 720. So this will yield 20.8 drops per minute. And then before we're going to do the final step, we need to round that to the nearest number, which is basically 21 drops per minute. Okay. Now, if we are going to calculate for the infusion time, such as in the case that we need to look for the number of hours, when or how long is this IV infusion will finish? What is the required time? Or how long will this infusion gonna be done, okay, or consumed? So you need to have the prescription as well. So for example, what we're gonna do here is to get the total volume to infuse, which is basically part of the medication order. And in our example, that is the 1 liter of 0.9 sodium chloride. And for example, if the IV pump was set at 75 mLs per hour, so this is our denominator this time. Okay. So you're going to divide 1,000 mLs by the 75 mLs per hour. So this is going to result into 13.33 hour infusion time. So this is the duration for the IV drip. Okay. Now we need to convert the 0.33 here. Okay. So how are we going to do that? We're going to convert that by multiplying 0.33 by the 60 minutes. And so this will be around 20 minutes and add it to the 13. There you go. You will be infusing that IV drug in 13 hours and also 20 minutes. So this is the exact infusion time. Now, moving into the intravenous flow rates, we will be administering this medication. If you're going to be asked how many mLs per hour are you going to deliver this drug, again, you got to refer to the prescription. Our prescription is the zero or the 1 liter of 0.9 sodium chloride to be infused in the 12 hours. So the flow rate will be simply going to be calculated by dividing 1,000 mLs by the 12 hours. And this will result into 83.3 mLs per hour. So if the infusion pump can be programmed to deliver partial milliliters, you can set the pump to deliver 83.3 mLs per hour. You're going to round it to the nearest tenth. If the infusion pump cannot be set to deliver partial milliliters, what you're going to need to do is you're going to set the pump to infuse at 83 mLs per hour. You're going to have to round it to the nearest whole number. Okay, so that is the guideline. Now, this time we're going to have to talk about medications that should be administered by unit dosage per hour. And this is going to be used for those medications such as let's say the heparin. Actually, it's not yes, we're talking about the heparin here. So what we're going to do here is to determine first by doing the two-step process. So we're going to have to determine the amount of medication per ml. So, and then we're going to have to determine the infusion rate or the milliliters per hour. So for example, here in our first problem, so this is going to be our prescription of heparin, which is a continuous heparin sodium by IV at 1,000 units per hour. Okay, so that is our prescription. So the available or stock on hand is an IV bag of 500 mLs of D5 water with 20,000 units of heparin sodium. So this is already incorporated or reconstituted. Now, the question here is how many mLs per hour are required to administer the correct dose? So the formula here is going to be to do the following step. You're going to have to calculate the amount of the medication in units per 1 ml. So you're going to have to use the numerator, which is the known amount of medication in solution, and then you got to divide it by the total volume of the diluent. So let's substitute that. So that's going to be 20,000 units, which is basically the, let's take a look here. The IV bag, which comes in 20,000 units of the heparin sodium. So that is our numerator, right? The known amount of medication in the solution. Okay. Now, we are going to divide it by the 500 mLs, which is basically the exact volume of that liquid drug. So this will yield into 40 units of heparin per 1 ml. Now let's go into the step 2 of this calculation. We're going to have to calculate the mLs per hour this time. So your numerator here will be the dose per hour desired, and this is going to be divided by the concentration per ml. So this is how you're going to find out the mLs per hour or the infusion rate. So let's substitute that. We got the 1,000 units, which is the dose per hour desired. Okay, so this is the order. And we're going to divide it by the concentration per ml, which is basically the 40 units. The 40 units is the value that we obtained in the first step. So you're going to divide the 1,000 units, which is the exact prescription, by the 40 units. So this is going to yield 12 mLs per hour. So this is the flow rate that you're going to be putting into the intravenous pump to accurately set up the medication drip rate. Hello, everyone. Today I'll talk about the perioperative nursing care. So hang tight and get ready with your pen and notebook to jot down important concepts. Let's get started. Now, we're going to talk about the preoperative care and focusing about the informed consent. And it's very important for you to recall that preoperative care involves a much more comprehensive patient preparation. And this involves informed consent, and which is a very critical part of this process. So what's going to happen here is that the patient should be informed about the procedure, and both the surgeon and the nurse can play essential roles in this aspect. Now, the first thing that should happen here is that the surgeon is the sole person to be responsible for explaining the procedure and to address any questions the patient may have. And once the patient understands and agrees to the plan, the consent form will be signed by the patient, and this is going to be witnessed by the RN, ensuring that the patient is not only agreeing, but also has a clear understanding of what the surgery entails. Now, it is a great responsibility for the RN to just extend to witnessing the patient's signature on the consent form, and also to make sure that he or she confirms that the patient has totally comprehended the information provided by the surgeon. So this is a very crucial step in protecting our patients' rights and also to ensure informed decision making. Now, the nurse this time must also document this action, making sure that she or he has verified that the patient had fully understood the procedure. And there are also other considerations, such as having a parent or a guardian for those patients who are minor or under age of 18. They need to have this guardian or parent to sign the consent form on their behalf. And so for other patients who are not mentally capable or could be not alert or, let's say, incapacitated, they're going to require a legal guardian or someone with the power of attorney to sign the consent form for them. However, though, for psychiatric patients, unless they are legally considered as incapable, they can retain the right to refuse the treatment. Now, another aspect that you should recall is that there should be no sedation administered, anti-anxiety medications, until the patient has signed the consent form in order to ensure that the patient is mentally alert and able to make the decision. Now, there are some cases wherein there might be a need for us to obtain the consent via the telephone, and maybe in cases where a legal guardian or a power of attorney can provide consent via phone. And so this will require another person, another registered nurse, to witness this exchange. Even so, in these type of cases, the surgeon will remain the responsible person for educating the patient about the procedure as much thoroughly as he can. And this is a process where the patient's autonomy is emphasized and making sure that we have upheld we upheld the ethical and also the legal standards, and also to make sure that we are maintaining that in the entire pre-op care process. Now, let's talk about the nutrition of our patient. So in the pre-operative care, it is very important for us to optimize the patient's condition before the surgery is done. And we know that nutrition really plays an important role in preventing the complications during the procedure. So we need to properly manage the patient's nutritional intake, including withholding any food or withholding liquids, to ensure that the patient is well prepared for anesthesia and also the surgery. Now, these are the things that you need to be reminded about. Keeping the patient NPO. So we need to follow the surgeon's orders for nothing by mouth status before surgery. And this is a key component to reduce the risk of aspiration during anesthesia. Another is withholding solid foods or liquids So for general anesthesia, patients are typically gonna be placed on fasting on solid foods and also liquids for about 6 to 8 hours. Well, in the case of local anesthesia, the restriction period may be around 3 hours. Now, another thing that you need to be reminded about is the placement of IV line. So, if necessary, we need to initiate an IV access before the surgery to ensure that the catheter size is the most appropriate, especially if we need to administer fluids or blood products as needed during or after the procedure. Now, another thing that we need to do here is to make sure we are able to maintain elimination of our patient. So, if in case there is a plan to do an abdominal surgery, the surgeon may order an enema or let's say laxative the day before. And we are going to need the patient to also void right before the surgery. And in some cases, the medical provider or the surgeon might order the insertion of a urinary catheter. And we want to make sure that the bag is emptied before the surgery. And we got to document the amount and the appearance of the urine. Now, another aspect that you need to recall would be the surgical site preparation. So this is a very common aspect, especially before we send our patient to the OR theater. So one of the things that you might end up doing will be to wash or clean the surgical site with the antiseptic soap the night before surgery. And possibly we're going to get an order to shave the area prescribed, and which may be done in the operating room as well. And we have to inform the patient to report any post-operative pain and let them know that we are going to provide them pain medication and explain that some pain is expected and this is going to be normal. Now, there are some teaching points that we should be including in our education before the patient gets to the surgery. One is pain control for the post-op pain. Another thing is the use of the patient-controlled analgesia, which is the pump, if prescribed by the surgeon. Another thing would be is the teaching about the non-pharmacological pain relief methods. So this will include those relaxation or guided imagery to use alongside with the pain medication. And we also need to advise the patient not to smoke for at least 24 hours before the surgery, and we need to discuss smoking cessation options as well. Now, another thing is to teach them with deep breathing, coughing exercises. We need to show exactly how we make sure that they use the incentive spirometer, and also to encourage them to do early movement to prevent post-op complications such as pneumonia and also the formation of the blood clots. Now, another thing that we need to do is the use of the foot and leg exercises to improve the circulation, and this is also to prevent blood clots. And of course, coughing and the breathing is something that we are going to look forward to. They need to do the splinting of the abdomen, especially the abdominal incisions, when they're going to be doing the coughing and deep breathing exercises. And we also need to inform that they might need to use any of the devices, maybe catheter or could be urinary catheter or IV after the surgical procedure. And we're going to let them know that they need to keep those lines intact and they will be removed as soon as possible. Okay. Now, another thing that we need to go back to will be the this is what we call the psychosocial prep, and another important aspect in the pre-op care, which is going to focus about the mental and emotional well-being of our patient. So we need to address the psychosocial needs to alleviate their anxiety and also to support a more positive surgical experience. Now, these are the things that we can do as part of our pre-op psychosocial preparation. One is that will be to monitor the anxiety. We got to make sure that we are from time to time assessing them if they have any anxiety or their anxiety level has really cause them into an emotional distress. We need to address their concerns. We will provide them about clear answers or answer the questions or any concerns regarding their surgery and also to foster confidence. Another is to maintain the privacy. We want to make sure that our patient is getting that private time to prepare themselves for the procedure and always offer the emotional support and assistance on individuals' needs and make sure that we are also respecting their cultural and spiritual considerations. These are things that are very necessary for their healing as well. Now, we're moving to our next topic, which is all about the pre-op checklist, which is a very critical component in ensuring that our patient safety is maintained. Now, here are the following checklists. We're going to make sure that our patient's ID bracelet is accurate, ensuring that the patient is wearing proper identification. And we want to make sure that we are confirming the kind of allergies the patient may have, particularly latex, because this is often used in the products that are used in the OR. Now, another thing is to make sure that our checklist is completed before the surgical procedure. This is supposedly checked per hospital protocols, and we want to make sure that the consent forms have been verified, that the patient had signed them all, including those for surgery, could be blood transfusion or other procedures. Now, we need to make sure that our medical documentation is complete, that there is that history and physical examination documentation in their chart, making sure that the consultation request in documentation is already available, and there will be those lab results as well, especially diagnostic tests that are necessary as part of the pre-screening process. Now, another thing that we need to have in the chart are those testing, such as EKG, chest x-rays. These are the common diagnostic tests that are required for some patient population. Same thing with the blood work, blood typing, cross-matching in cases wherein the patient might need blood transfusion. And as we are talking about the personal belongings, we want to make sure that we have removed a patient's personal items like jewelry, dentures, and also secure these valuables and put them in a container and make sure that these are documented and kept in the hospital safe, or maybe sent with the patient's family to home, making sure that this is accounted for to prevent losses. Now, another thing that we need to do is to make sure that there is that documentation about the patient's fasting. The last time that the patient had a drink of water or liquids or their last solid intake. Now, we want to make sure that as part of the pre-op, our patient voids before they're sent to the OR and that they have received those pre-op medications, and also make sure that the vital signs have been taken and recorded properly. Again, these are the necessary documentations: their last oral intake, documentation of their last void, administration of the pre-op medications, and the most recent vital signs. Now, let's tackle this time the medication and substances that might have direct or indirect effect to our patient while they are going to have the surgery. Now, we need to make sure that we have assessed all those medications, ask them thoroughly about what they are taking, as they can possibly have some significant impact on the patient's anesthesia and also their recovery. Now, there are certain medications that need to be adjusted or stopped before the surgery in order to minimize these complications. So here's some lists of these medications that you need to ask. So one of those will be to determine if the patient is currently taking any antibiotics, because these medications can increase the effects of anesthesia. This can lead to prolonged sedation or delayed recovery. So this means the patient may require more time to regain consciousness after surgery. Now, the next classification will be your anticholinergics. So these drugs are often used to reduce the patient's oral secretions or GI secretions but they can cause confusion, especially in the older adults. So they may also increase the patient's heart rate. They're going to end up with tachycardia, and their bowel motility will also be reduced, which can lead to post-op constipation, or what we call as ileus. Now, another classification is the anticoagulant or the antiplatelets. So some of those will be like the heparin, warfarin, aspirin. These are medications that will prevent clotting, but this will also increase the patient's risk of excessive bleeding during and after surgery. So they often need to be stopped or adjusted just before the surgery. Now, another classification is your anticonvulsants. They're used to control seizures, but these medications can also interfere with the metabolism of the anesthesia, which can potentially require dose adjustments and the anesthetics, because we know that these things can also prolong the sedation after the surgical procedure. Now, another classification is the antidepressant. And some of these antidepressants, just as the SSRIs, or let's say the tricyclics, can also lower the blood pressure, which may become a problem during the anesthesia, as it can lead to the hypotension. So this is very important for us to carefully monitor our patients' blood pressure and their cardiac function during the surgery. Now, another classification here is the antidysrhythmic. So these are medications that are used to control abnormal heart rhythms, like amiodarone, beta blockers. But these medications can also impair the heart's electrical conduction. And then they can also reduce the heart's ability to pump effectively, and this can increase the risk of cardiac complications during the surgical procedure. Now, another group of medications are your antihypertensives. So these are your beta blockers, ACE inhibitors, and these too can also cause dangerously low blood pressures such as hypotension and bradycardia, especially during the anesthesia. So careful monitoring during the procedure is very important. Along with the corticosteroids, these medications can weaken our patient's immune response, and also it can reduce their ability to respond to the natural the stress, right? And so this is going to be a factor. And to prevent complications like adrenal insufficiency, the dose of the corticosteroid may need to be increased before the surgical procedure happens. Now, another group of medication is your diuretic, and these are known to control the blood pressure by increasing the urine output. But this can also lead to electrolyte imbalances, especially potassium. This can lead to hypokalemia, which can complicate anesthesia and also recovery. Another classification are your herbal supplements, such as the ginkgo biloba, garlic, maybe St. John's wort. And the garlic, biloba, these are medications that can interfere with the blood clotting, and also with the St. John's wort, this can interact with the patient's anesthesia. Now, this is going to increase the risk of bleeding and also other adverse effects to the anesthetic agent. And so generally, these patients are advised to stop these supplements before surgery. Now, another classification will be your insulins. This can be either be increased or decreased, because our patient may have a low blood sugar because of the fasting, decreased nutritional intake, or possibly because of the stress that the surgery can it can actually increase the stress level of a patient, which can trigger hyperglycemia. So this is something that should be closely monitored, as well as the patient will need adjustment of the insulin dose. Now, we have to talk about the pre-op medication. So these are things that we need to administer as prescribed before the patient is sent to the OR suite, and also to explain to the patient the purpose and the effects of these medications in order for them to be more cooperative, and so they will know for sure what to report to us and also to the medical provider. Now, this time, we will need to talk about some medical conditions that may increase the risk associated with the surgery. So making it crucial for us healthcare providers to assess and manage the risk prior to any procedure. So I'll talk about specific conditions that can affect the surgical outcomes. So one of those is the older age, because we know that aging can affect nearly every body system, and that older adults are more vulnerable to surgical complications because of the reduced organ function, slower healing, and increased likelihood of chronic conditions. And so their bodies may not be able to tolerate the stress of surgery as well. And so recovery can be prolonged. Now, another risk factor here is the obesity. The excess body weight can increase their risk of complications, such as poor wound healing, maybe infections, or cardiovascular stress during the surgery. Now, with obesity, this can also make the anesthesia management much more difficult, particularly the airway and breathing issues. Now, another risk that we have identified are your bleeding disorders. So, for example, hemophilia or the von Willebrand disease. These can impair the blood clotting, significantly increasing the risk of excessive bleeding during and after surgery. So you need to really take some special precautions and medications may be necessary to manage these patients' clotting. Now, aside from that, diabetes is another huge risk, because if a patient has this, they are at a higher risk of developing an infection, slower wound healing, and unstable blood sugar levels during and after the surgery. And they will also have an increased risk of the cardiovascular complications. And as we are going to take care of these patients, we need to assess, monitor their blood sugars closely, and to control before, during, and after the surgery. Now, another thing that we need to keep in mind is the patient's chronic pain, because patients with chronic pain may have altered responses to pain medications or anesthesia. They might require higher doses of pain medications during the recovery, and managing post-operative pain can be more challenging for these people. Now, another risk factor here is the heart disease. So, for example, cases of coronary artery disease, heart failure, arrhythmias can increase the risk of cardiovascular complications during the surgery, such as heart attacks or, let's say, irregular heart rhythms. So we need to do close monitoring of the heart function, which is very essential during and after the procedure. Now, another risk factor here is the obstructive sleep apnea. This is a very common thing, especially for those obese individual. This is going to place them at risk for airway obstruction, especially when the patient is placed under anesthesia. And this can also lead to breathing difficulties during the surgery and also their recovery, particularly if they are receiving sedatives or opioids. Now, another risk factor is the respiratory infection. So examples are the pneumonia, or it could be bronchitis. These can compromise the lung function, and it can make it more difficult for the patients to breathe during and after surgery when they have these pre-existing conditions. Now, another is the liver disease, because we know that liver plays a role in processing the medication, including the anesthetics. So the liver disease here can possibly impair the drug metabolism, and it can lead to prolonged effects of the anesthesia and maybe a higher risk of bleeding due to reduced clotting factor production. Now, another risk factor here is fever, which may indicate an underlying infection, which can also increase the risk of complications during surgery, such as sepsis, or could be delayed healing. And as needed, surgery may be postponed if a patient has an unexplained fever. Now, this time we're going to talk about the chronic respiratory diseases. These are your conditions such as the COPD, asthma, emphysema, which will make it harder for patients to maintain adequate oxygenation during the surgical procedure, especially when they're under the general anesthesia. And examples such as the immune system disorders like HIV, autoimmune diseases, or immunosuppressive medications being used, this can also place the patient at a higher risk for infections and also delayed healing after the surgical procedure has been completed. Now, we also need to take extra precautions to reduce the risk of infection around this time. Now, another risk factor here is drug abuse. We know that substance abuse can affect how patients can respond to the anesthesia and also the pain medication. So, the long-term drug use can impair their organs, making anesthesia much riskier and also will lead to a complicated recovery. Now, also, the patients may have some alteration in their pain thresholds or, let's say, tolerance to certain medication. Now, lastly, we have smoking. We know that smoking affects the lung function, right? And also, it will affect the circulation, making it harder for the body to heal after surgery. And our smoker patients are going to be at a higher risk of respiratory complications such as pneumonia, and they heal much more slowly due to their reduced oxygen delivery to their tissues. So it is very imperative that we are going to advise them to quit smoking before the surgery to reduce this risk from happening. Now, we are going to talk about the preparation of our patient with the administration of the pre-op medication. And so we need to confirm that the patient will be receiving those prescribed pre-op drugs. So, for example, those medications such as the sedatives, anxiolytics, antiemetics, and other pre-op medications, these are intended to prepare the patient physically, prepare them mentally. And this is something that we need to be administering at least 45 minutes to 75 minutes before the anesthesia is to be administered. So timing of the prep is very important here. Now, we need to make sure we do the double checks about their prescription and make sure that we have confirmed all the pre-op instructions have been followed, such as the fasting as well. Now, another thing that we need to be reminded about the pre-op medication is that we need to instruct them about the purpose, the side effects of these pre-operative medication. We are going to educate them about the purpose, why we are giving this drug, the desired effects, and tell them that the sedative will help them relax and prevent restlessness during the pre-op waiting period. And this is also going to make them much more cooperative with the treatment plan. Now, another thing that we need to also do for them is to monitor for the adverse reactions. This is huge. We need to carefully observe the patient for any excessive sedation, could be respiratory issues, could be allergic reactions or unexpected side effects. And early detection here is a very important matter. And to make sure that we can intervene it is very critical to ensure that the patient remains stable and fit for the surgery. Now, we need to continuously monitor our patients' vital signs and to ensure that they remain alert enough to communicate, especially before the sedation deepens. Now, maintaining safety is huge in the perioperative phase, because after we administer those pre-op meds, we need to make sure that the patient stays in bed with the side rails up, with a bed in the lowest position, because this is going to prevent them from falling, climbing out of bed, and also to reduce possible injuries. Now, at this time, we are going to talk about the patient's arrival in the operating room. And in order for us to avoid the common wrong site, wrong procedure surgery, we have to make sure that the surgeon meets the patient and marks the surgical site with a pen. And in the OR, the nurse and also the surgeon should double check the Mark site, making sure that we have the correct patient for that correct procedure. And before the surgery starts, the entire OR team will be subject to the timeout. And this is to confirm the patient's site and also to confirm the correct patient. So this is a huge deal. Now, after that, we need to also check the patient's ID, and also the patient's chart need to be reviewed. And we will be checking for all those things, such as the consent, the history, physical exam, allergy information. And these are the basic stuff that you need to really complete while the patient is awaiting for the final procedure. Now, this time, we'll be talking about the post-operative care, which includes the management of this patient after the surgery in order to prevent the complications and also to help in the healing of their incision and restore their health. So one of the systems that we should keep an eye on will be the respiratory system. So as soon as the patient comes back from the OR, especially if you're working in the recovery room or the post-anesthesia care unit, make sure that you are checking the patient's breath sounds. Because if you're going to hear those wheezing and stridor, these signal airway obstruction. Now, again, our important aspect of care here is to monitor their airway, breathing, and also their vital signs to assess the circulation. And we need to be cautious with the patients that are becoming lethargic, as they're going to struggle to keep their airways clear. So this is very important for us to make sure that we are checking their rise and fall of their chest, make sure that they're being suctioned as needed if they're not able to cough up yet because of the anesthetic agent. We need to encourage coughing and deep breathing exercises in order for them to clear the airways as soon as they are wide awake. We're also going to check their oxygen saturation continuously, and we'll notify the medical provider or the surgeon if their oxygen saturation is less than 95%. Now this time, we'll head into our cardiovascular system. So here, we are going to monitor the patient's skin color. Capillary fill. This is to target the integrity of their circulation. We need to check for any bleeding, abnormal heart rhythms. We're going to have to check for their blood pressure, either it's elevated or not, or we will be looking out for signs of the blood clots, especially in patients that are positioned for surgery, right? Now, another thing is to promote the venous return using the compression stockings or devices if needed, such as the sequential compression device. Now, we're going to head out into tackling about neurological system. We have to check their level of consciousness and compare the pre-surgery status. And we need to keep trying to wake the patient until they're fully alert and orient the patient to their surroundings. And another thing is to keep their body temperature at an even range with the warm blankets. Now, another system that you should keep an eye on will be the musculoskeletal system. You will be positioning the patient on the desired position after the surgical procedure. And as permitted, we are going to encourage them to ambulate to ensure that the patient sits at the sides of the side, to sit at the side of the bed first before they're going to stand up to prevent the orthostatic hypotension. We need to also position the patient in the low Fowlers to help with the lung expansion unless it is contraindicated. And we have to turn our patients at least every 1 to 2 hours to prevent those known complications. Now this time we'll talk about the temperature regulation and integumentary system. So as far as the temperature regulation, we're going to watch our patient for any hypothermia, especially for the older population, especially when they are taking that anesthetic agent. They are really prone to developing hypothermia, and warm blankets, again, will do magic. Now, integumentary system, this is where we're going to be worried about monitoring the surgical site and also the patient's dressing for any bleeding or any excessive drainage. And we are going to watch our patient for any signs of infection or skin breakdown. And if there's a need for us to change the dressing, we need to use sterile techniques during the wound care as per policy. Now, another thing that we need to do is to check their skin for any signs of infection and skin breakdown, which can happen due to the immobility while the patient is on bed rest. Now, the next system that we should talk about will be the fluid and electrolyte balance. We need to check the patient's hydration status by observing their mucous membranes, skin turgor, and to monitor the patient's intake of the intravenous fluids, oral intake, and also the output. Now we are going to have to slip or peek into the next part of our discussion, which is going to be all about the gastrointestinal system. We're going to have to monitor the patient for any nausea, vomiting, bowel function alteration. And if there is an order for us to keep the nasogastric tube patent, we need to do that as well. And again, ambulation is highly recommended to promote bowel movement and also to start their diet with clear liquids once they're allowed to do so and advance their diet as tolerated. Now, another thing that we need to be reminded about is the um, renal system. So we are going to monitor the patient's bladder function and also the urinary output to make sure that our patient voids within the 6 to 8 hours post-op. If there is no catheter, we really need to keep an eye on these things because we know that the renal system is a direct representation about how the body is able to perfuse the vital organs. Now, let's talk about checking the uh, patient's bladder, maybe with the use of a bladder scanner to see if they're retaining. This is another step that will be helpful for you to determine if a patient is having some complications. Now, about pain management, we will be assessing our patient's pain level using the pain scale and to make sure that we are gauging their intensity appropriately and to also monitor for the effectiveness of these pain medications. And we can also incorporate the use of the non-pharmacologic measures such as the repositioning or let's say the application of heat to help with the pain relief. Now this time we will be focusing about the post-op complications that will affect our patients recovering from surgery. So here are the complications, starting with the pneumonia and atelectasis. Again, we know that this is the inflammation and also this is something that is caused by the infection, could be aspiration or the lack of movement. And this is something that you will expect to appear within the 3 to 5 days after the patient has a surgery. Now, atelectasis is the collapsing of the patient's lungs, or maybe the lack of the air in part of the lungs due to the blocked airways from the mucus or poor breathing efforts after the surgery. And it will typically occur within 1 to 2 days after the procedure. And we can prevent this by promoting the use of the incentive spirometer as often as the patient can do, and also to make sure that they do the breathing exercises. Now, what are the things that you should be looking out for a patient with a pneumonia atelectasis? Well, obviously, they're going to have shortness of breath. They will have crackles in their lungs. They're going to have fever. They're going to have productive cough, chest pain. And we need to check their lung sounds. That's very important. We need to have baseline information, what their lung sounds are. And we will be turning our patient every 1 to 2 hours while in bed. We will encourage deep breathing, coughing, and the use of the IS. And we will be providing the chest therapy, postural drainage, and also to promote the fluid intake, early movement. Now, we will also be using the Yankauer suction to clear mucus if the coughing is somewhat ineffective, and we will be ensuring that they use the incentive spirometer as prescribed. Now, another problem that can happen is the hypoxemia. This is the low oxygen levels in the blood. And this is going to happen often due to the shallow breathing from the anesthesia or the medication. So our patient here will become restless. They will have dyspnea, sweating, faster heart rate. They're going to have that elevated blood pressure as a compensatory mechanism. There's also cyanosis or low oxygen saturation readings. So, what do we do here as nurses about the hypoxemia? Of course, we're going to have to monitor the patient for any signs of hypoxemia, inform the medical provider or the surgeon. We're going to have to monitor the patient's lung sounds and their oxygen levels, and we will be administering the oxygen as prescribed and to encourage them to perform the coughing and deep breathing exercises and also with the use of the incentive spirometer. Now, turning the patient every 2 hours and allowing them to mobilize as early as they can is very important. Now, as we are going to move along here, we will be talking about the pulmonary embolism, which is basically the lodging of that blood clot that's blocking the lungs artery, which can disrupt the blood flow to other parts of the lung. Now, I want you to recall those manifestations of the pulmonary embolism. One of those is the sudden difficulty breathing. Another is sudden sharp chest pain or a upper stomach pain. There will be cyanosis. There will be fast heart rate. There can be low blood pressure according to where the clot has lodged. Now, what are we going to do here as nurses to act on the pulmonary embolism? We will notify the medical provider right away or the surgeon. This is a life-threatening condition. We will be monitoring our patient's vital signs and we will administer oxygen and treatments as ordered. Now, this time, we will be talking about other complications such as hemorrhage, which is a large, rapid loss of blood either inside or outside the body. So, our patient here can become restless, they will become weak, low blood pressure, they're going to have tachypnea, their skin will become cool and clammy, their output of the urine is also decreased. Now, as nurses, what we need to do here is to actively apply pressure at the bleeding site. We're going to have to notify the medical provider or the surgeon, and we will administer the oxygen as needed. Now, part of the care is to provide them with the intravenous fluids and also the blood product as prescribed. We're going to have to prepare the patient for surgery if needed. And if in case our patient will become hypotensive, they might be in a shock. This is a life-threatening condition caused by the low blood volume and also can happen because of severe bleeding. Now, what are those assessment findings that you should recall about the patient in shock? They're going to have the blood pressure kind of going downhill, their heart rate and their respiration going fast. And the patient will manifest those confusion as well and dizziness because of the drop in their blood pressure. So, what do we do if the patient is in shock? We will elevate the legs. We will notify the medical provider. We will treat the cause of the shock. We're going to administer the oxygen, monitor our patient's level of consciousness, their vital signs, and also their fluid balance. And we need to check their color of the skin, their temperature, their hydration. And also, we're going to have to administer the IV fluids and blood products as needed. And for the case of a spinal anesthesia shock, we can do here the elevation of their legs on pillows, but not too high to prevent breathing problems. Now, another complication that you will be expecting is the thrombophlebitis. This is the inflammation of a vein, usually in the legs, and this can often lead to clot formation. So our patient will be complaining about the swelling, the painful vein. It's going to be hard and tender to touch, and the temperature of the site can be elevated as well. Now, what do we do if in case our patient develops the thrombophlebitis? We will be preventing this by encouraging early movement, avoid them to dangle the legs. We have to prevent them from prolonged sitting, okay? And to make sure that they're doing the regular leg exercises. However, if the problem has already existed, we're going to have to monitor the patient's leg for any swelling and leg pain. And aside from that, we're going to have to elevate the leg to decrease the edema and also to apply the compression stocking, and also to remove those at least twice a day. Now, this time, we're also going to administer the anticoagulants, which is very crucial. As soon as we know that the patient has the DVT or thrombophlebitis, this patient would definitely need to get the anticoagulants to prevent growth of these blood clots. Now, this time we will talk about the urinary retention, which is another complication. This is the patient's inability to empty their bladder, maybe because of the anesthesia or the pain medications that's causing it. And this can happen at least 6 to 8 hours after the patient gets the surgery. Now, what would be the manifestations? Well, of course, difficulty urinating. There's going to be restlessness, sweating. They're going to end up with lower abdominal pain. Their bladder will feel distended. Their blood pressure will be higher as well because of the pressure into the aorta. And their bladder sounds will be sounding hollow when you are trying to percuss them. And what will be your interventions here for the urinary retention? Well, of course, you're going to monitor your patient for their voiding and check the patient for their full bladder, palpate that, or also you can use the bladder scanner to identify how much fluid or how much urine has been retained in their in their bladder rather. And also we're going to have to encourage ambulation and also to allow circulation and making sure that everything is in the right spots. Um, Another action that we need to do is to increase the fluid intake. And this is to make sure that our patient is not hydrated as well. We're going to have to use warm water, running water to help the patient urinate. And if in case they're not able to do that, we will require probably the placement of an indwelling urinary catheter to empty their bladder and to prevent urinary tract infections. Now, another issue that is very common is the constipation. This is the difficulty in passing the stool. And this is possibly caused by the anesthesia, the pain medications, the decreased level of activity, and also the limited intake after the surgical procedure. And so, what you're going to find here is that they're going to have uh, absence of bowel sounds, probably, or hypoactive bowel sounds. They're not going to be able to pass stools. They're going to have some abdominal bloating. They're going to have some loss of appetite, headache, nausea. But there are some nursing interventions that you can use, such as increasing their fluid intake up to 3 liters per day, unless it is contraindicated. We need to also encourage early ambulation. We will suggest high fiber food intake and to make sure that we are providing privacy anytime when they are doing these bowel movements, and to also administer the stool softener or laxative is prescribed. Now, this time, we are going to talk about the paralytic ileus. This is the condition wherein the bowel stops moving the contents forward. And so this is caused by the anesthesia again, and also the bowel handling during the surgery. Now, what are those manifestations? Well, of course, the patient might manifest vomiting after surgery. They're going to have abdominal bloating. The bowel sounds will be absent or hypoactive. And what we can do here is to track the patient's intake and output, keep them NPO. That simply means no food or drink strictly until the bowel sounds return. We need to ensure that any nasogastric tube is working properly. We're going to have to encourage them into ambulation. We will administer IV fluids or nutrition as needed, and also to administer medications to improve bowel movement as prescribed. Now, we're going to have to also treat this with bowel decompression using a nasogastric tube if needed. Now, this time, we will be talking about the complication, which is the wound infection, right? The wound infection is something that can happen easily in our patient. Now, what are these manifestations? Well, of course, they're going to end up with a fever, chills, warm, tender, swollen incision. Their skin becomes tight, edematous, and their white blood cell count can become increased as well. So our goal here for this patient with the wound should be to monitor the temperature. We will be checking their incision site for any signs of infection, such as redness, swelling, and drainage. And we will be ensuring that the drains are working and check it for any changes or drainage. And we will be maintaining cleanliness and also change the patient's dressing as prescribed. And we will be expecting the possibility that we need to collect the cultures if infection is suspected, and we will be administering antibiotics as prescribed as well. Now, this time we will be talking about the wound dehiscence and evisceration. So, just a quick review here. Dehiscence is going to happen if there is wound reopening, often 5 to 10 days after the surgery. Whereas we have the evisceration, which is the protrusion of the organs, especially the abdominal organs from the wound. And this is something that can happen also during the 5th and 10th days after the surgery. Now, what are those assessment findings with the dehiscence? It could be more wound drainage. There could be more open wound edges. There's going to be visible tissue. However, for the evisceration, the drainage will be serosanguinous. This going to allow us to see the visible organs. There's going to be sensation of popping as well. Now, as far as the interventions, this is what we are going to be asked. We're going to have to call for help and notify the surgeon right away. And we will stay with the patient. We will position the patient in low Fowler's position, and also with the knees bent. We will be covering that with the sterile saline dressing. We will be monitoring the patient's vital signs and watch for shock and prepare our patient for surgery if needed. And then we're going to need to document what we had done for the patient and also what transpired. Now let's talk about the ambulatory care discharge criteria. So before we're going to decide on discharging our patient, especially in the urgent care or let's say same day surgery, these are things that you need to keep in mind, especially if the patient is not admitted to the hospital. They are just visiting the surgical center for probably a minor procedure. So these are the things that you should keep in mind of. We want to make sure that before you send the patient home, our patient is awake oriented and their vital signs are stable, that the lab results, if ordered, are within the normal range, and also that the patient has urinated, they're breathing without any difficulty. The patient can walk, they can swallow, cough, and pain is minimal. The patient is not also vomiting, and there is no bleeding from the incision and no signs of infection. Now, a responsible adult is probably going to be required for this patient to take them home, to give them a ride, and make sure that the discharge is done safely, either to home or another facility. Now, this is something that you should all consider when the surgeon has already signed the discharge release. Now, this time, we will be talking about the discharge teaching. So what are these teaching? Well, we will be assessing first the patient's readiness to learn and their readiness to understand about their care. We will also determine if the patient needs any home care resources. Maybe they're going to require the use of oxygen at home or maybe another medical device. We will be showing the patient how to care of their incision and change the dressing. Now, if showering is allowed, we will advise the patient to cover the incision with plastic. And we will be providing the patient with a 48-hour supply of the dressings as per agency or protocol. And we will emphasize the importance of making sure that they show up for the follow-up visits with their medical provider or surgeon. And those sutures that they are seeing currently, they're going to be typically removed within 7 to 14 days. And the same thing can also happen to the staples. Now, for the other teaching stuff, we're going to have to include educating the patient about the use of their medications, the purpose, the dosage, side effects. And we are going to advise the patient to drink at least 6 to 8 glasses of liquid daily unless contraindicated, and make sure that they are not lifting heavy objects, especially greater than 10 pounds. This can cause undue strain to the surgical site. And we need to make sure that they know when to exactly to return to work, probably within 6 to 8 weeks, and depending on the severity or the gravity of the procedure. Now, we will also be talking about the other discharge um, things, such as education about their complications. We will be providing them written instructions about their care, so they will have something to refer to. We will be also explaining them the potential complications, also offering them resources for home care support, and make sure that somebody is able to take them home. And they should not be making any decisions or to drive or to sign any legal documents 24 hours after the anesthesia, because this is possibly going to give them some influence, right? They might not be able to fully think properly around this time. Now, we will also discuss to them about their home safety, the recommended safety devices, and make sure that we are also reviewing the dietary recommendations, make sure that they will adhere to that. And we will encourage the patient to call their surgeon if there is any complication at all. Now, we are going to remind our patient to follow up the appointments as well. And this is to monitor if our patient is getting the benefit of the surgical procedure, if there is any other complication. Hello, everyone. Today I'll talk about hygiene, mobility, and skin integrity. And so you need to hang tight and get ready with your pen and notebook to jot down important concepts. Let's get started. Now, we'll talk about the provision of the self-care, and providing the nursing care here is very important, and the other various factors as well that we need to talk about, especially for those that can influence the patient's hygiene. And also the factors that can include here are the social practices. It could be the personal preferences, could be the body image, or it could be the socioeconomic status of our patient, the health beliefs, the cultural variables, and also the developmental stage, and also the physical condition of our patient. So as we're talking about self-care ability, we need to make sure that we will be assessing that. And to evaluate a patient's self-care ability, we need to make sure that we are looking into their muscle strength, their flexibility, their balance, their visual acuity, and also their ability to detect thermal and tactile stimuli. So they really need to have all those sensations, because if they probably would not be able to tell all those extremes in temperature, they can possibly get injured. Now, another thing that we need to assess when we are providing care to our patient will be to check if they are able to tolerate some specific activities. So we need to observe their ability, especially if they're able to do their personal hygiene, and to take note of those signs of intolerance. Now, this might be reflected in some changes to maybe a respiratory rate, their skin color, or it could be the pulse rate, and also some complaints of dizziness and weakness, could be fatigue. So you got to be sensitive in noting these subtle changes, especially with their breathing. Maybe they're not able to really proceed with that particular activity that you're planning to do or you're already doing. Now, there might be some patients that will have those physical limitations, right? And especially their mobility, their strength, their vision, their fine motor, skills or maybe activity tolerance, they probably will require assistance with hygiene tasks. So it could be a one person assist or total assist. Now, the activity intolerance can again be manifested those by specific manifestations, respiratory effort, the change in the skin color, the pulse. Okay. Now let's talk about the uh, bathing. This is a very important aspect in the patient care. So there are several types of bath. Uh, and one of those will be the complete bed bath, partial bed bath, sponge bath. There could be tub bath, showering the patient, or it could be the bag bath, or maybe with the use of the chlorhexidine gluconate, or known as the CHG bath. Now, there are some considerations that you should um look out here. Maybe your patient might get exhausted from the bathing experience, especially with complete bed baths, like tub baths as well. And also, showering can be taxing to this patient as they are going to need to increase their oxygen consumption and also the demand. So, this can potentially lead to their fatigue. Now, take note that there are some patients that may benefit from the partial bed baths instead of the complete bed baths. And also, avoiding bed baths can, especially with the basins, because if this is something that is still in your practice, especially with the use of the baths with soap and water. Again, this is no longer recommended due to the potential transmission because they can harbor bacteria, which can lead to infection. Now, another thing that we need to keep in mind is the use of the chlorhexidine gluconate, or known as the CHG. So, this has been shown to reduce the bacterial growth in the wash basins, and this is going to be a very effective alternative to the standard soap and water. Now, you need to make sure you know that there should be proper handling of the bath basins because if they are used, they should not be used for other purposes, let's say storing supplies. And these containers should be thoroughly dried after use to avoid bacterial growth. Now, we need to take note about the infection control measures that should be included while you are providing the bathing to your patient, especially those disposable items. They should be um, used whenever possible. Washcloths, towels, and linens should be discarded in proper receptacles after use. Now, also with the privacy and safety of our patient, we need to maintain this. And in order for the patient to at least uh, regain that kind of independence, and also we need to anticipate the patient needs during the bathing. Now, another aspect here is the perineal care and the assessment. So this is going to include the checking of the possible sore areas, or could be excoriation of their genitalia, or could be the bottom. There could be some pain or odors that we need to investigate. And there are some patients that might be a risk for the infection. So those are possibly the uncircumcised male patients, or for those who might have an indwelling urinary catheter, or maybe for those patients that may have the genital or rectal surgery, or for those postpartum patients, they are at a higher risk to develop these perineal infections. Now, take note that we also need to consider about the skin breakdown risk, especially in the perineal region. And for those patients that may have been having the urinary or fecal incontinence, or for those patients that may have the surgical dressings or indwelling catheters, or for those obese patients, they are at a higher risk to develop these unwanted skin breakdown. Now, this time we'll talk about the skincare. And aside from just providing skincare, it is very important that we are doing the assessment regularly. And what we are assessing here are the color of the skin, the texture, the thickness, the turgor, the temperature, and we also need to check for any dryness of the skin, maybe scaling, or it could be cracking. Now, we need to also pay attention to the device related um, in the skin assessment for those patients who might be using oxygen tubing, feeding tubes, or it could be the orthopedic devices, as well as the pressure points of our patient, like skin folds, or could be hard to reach areas like the perineum and breast. Now, you need to make sure that you're looking out for this patient, especially if they have been wearing the oxygen tubing. This can potentially cause ulcer behind the ears, or for those patients that may be using the nasogastric tube, this can also cause some ulceration into the nasal area. So make sure that you do your diligent assessment into this higher risk areas of ulceration. Now, another thing that we need to pay attention here will be to check about their impaired sensation or circulation. Now, especially for those patients that may have darker skin, where these signs may be less noticeable. Another thing that you need to pay attention will be the odor. So if you're going to be able to smell those unusual odors, this should be noted in your assessment, and possibly if this is related to some form of infection, of course, you're going to have to relay this to the medical provider. Now, there are certain risk factors that can also lead to the skin problems of our patient. And top of that will be the immobilization, and especially if they're unable to move independently, they can develop those pressure ulcers. If they're obese, if they have that excess body weight, they will have that increased risk for skin friction and moisture, leading to the skin breakdown. And also for patients that may have neurological issues, where they have reduced in sensation, which is common in possibly patients with diabetes mellitus, or for those neurological patients, they probably would have some injuries already, especially in their skin, that they are probably not aware of because they have the lack of sensation. Now, for those patients that may have some cognitive impairment, such as patients with dementia, which can really prevent them from attending to their own skincare needs. And for those patients that may have poor nutrition and hydration, these malnourished, dehydrated patients are more prone to developing the dry and also fragile skin. Now, there's also excessive secretion, especially with patients that may have increased perspiration or maybe urination, they are incontinent, or could be patients that may have wound drainage are at a higher risk for developing skin problems as well. For those who have medical devices applied most of the time, this can cause pressure on the skin, such as braces, could be tubes. These can lead to skin injuries, and also, vascular insufficiencies. This can lead to poor circulation, especially for those patients that may have peripheral artery disease. They are at risk to develop the skin breakdown. Now, there are also common skin problems that you need to be aware of, and these are the dry skin, which can lead to itching and irritation, acne, which is very common in adolescents, and because of with the hormonal changes, rashes. This could result from allergies to food or medications or substances, maybe latex, or it could be infections. They might also have the contact dermatitis. This is caused by the contact with irritants and abrasions, which is going to lead to skin damage from friction or injury. And for those patients that may have surgical incisions, they are at risk to developing infection or delayed healing. And others would have the wounds, and they will require frequent dressing changes and also careful monitoring. Now, this time, let's talk about foot and nail care. And here, don't forget to do the assessment again. And your task here is to inspect the nails and all surfaces of their feet, especially between the toes and on the soles. And there could be some dryness, there could be some inflammation, there could be cracking and lesions. That may indicate the foot problems. Now, you really need to also assess for the foot pain or altered gait. They might complain the pain or discomfort, and this can signal that there is an underlying foot or nail issues. Now, take note that there are some special considerations that you need to know, especially for those patients that may have peripheral circulation problems. If they have diabetic neuropathy, they are at risk of developing foot and nail issues. Now, there's also common foot and nail problems, and here are the following: calluses, corns, plantar warts, tinea pedis, or it could be the ingrown nails, and paronychia, which is the infection of the skin around the nail, or it could be foot odor, and this might indicate infection or poor hygiene. Now, in the foot and nail care, we've got to do the routine foot care, which involves possibly soaking the feet of the patient in drying them thoroughly and also trimming the nails. Unless, here's the caveat, unless the patient has diabetes or if they have peripheral vascular disease. So you got to pay attention to this. You don't necessarily soak the patient's feet whenever they have a history of diabetes. You need to get that consultation with a podiatrist before you're going to provide the foot care. Now, so there are special considerations such as the following. For those patients that may have diabetes mellitus and for those peripheral vascular disease patients, they need to make sure that a podiatrist is on board to monitor whatever changes that they may have their foot or the integrity of their nails. Now, another thing that you need to keep in mind, again, there should be no soaking of the patient's feet with a diabetes because this can cause maceration. And also avoid trimming nails without the professional help. This can potentially cause some injury or ingrown to your patient. Now, make sure that you have the podiatrist on board, like I've said. Now, we need to also avoid soaking and with the use of the harsh chemicals, because if you're going to do the long soaks or to use those harsh chemicals, this can also lead to the maceration and potential infection of their feet. Now, take note about the moisturization. This is something that you need to keep in mind of. You're going to be able to apply the lotion to their feet, but avoid applying it between their toes to prevent fungal infections. And they are higher risk to developing that. And also making sure that there's proper nail trimming and they should be done straight across. And the edges should be filed unless the patient has diabetes or peripheral vascular disease. And again, the podiatrist should be involved. Now, there's also an importance about making sure that our patient will have the right footwear and also the temperature, because this should be avoided, especially with the extremes in the temperature and also with the use of the well-fitting shoes to prevent any skin injury. And also taking a look into the use of their socks, make sure that they're wearing those clean, absorbent cotton socks rather, with no seams. This also to avoid those mended socks to reduce the risk of infection and also the pressure sores, especially in the diabetic patients. Now, this time, we'll be talking about the importance of oral hygiene. And again, you do your assessment here while you are providing care to your patient. And we know that oral hygiene can enhance the patient's comfort. It can reduce the risk of infections and also improve their appetite. Now, as we are going to do the routine oral hygiene, we can include the use of the toothbrush, could be flossing or rinsing with fluoride, toothpaste, at least twice daily. And we can also incorporate the use of the alcohol-free mouth rinses, which should be used to prevent tooth decay in our patient. Now, flossing is uh, another care that we can provide to our patient, especially to do it before and after brushing, and also vigorous flossing should be avoided, especially for those patients that may be receiving chemo or for those patients receiving radiation, or if they are using anticoagulants because they are at risk to developing the gum bleeding. And please don't forget about assessing for any oral lesions, especially around the lips or inside the mouth. Now, take note that part of the care here is to provide denture care, and this should be done regularly to prevent infection. And we need to handle these items carefully to prevent breakage and to make sure that we are removing the dentures at night to allow the gums to rest and making sure that we're able to clean their mouth regularly. And for the dentures, they need to be soaked overnight in a labeled container and also to lessen the contamination. Now, this time we're going to talk about the special care of their mouth. Now, there are people that will really require this, especially for those people that are unconscious, if they have diabetes, if they probably are not able to do it on their own, if they are on immunosuppressants or maybe taking chemotherapy, they're prone to developing those stomatitis. If they are using the artificial airways, they are prone to developing those issues like dry mouth or what we call as xerostomia. Now, the unconscious person will definitely need to require the frequent oral hygiene because they can accumulate those plaques, debris, and bacteria so fast. And this can lead to the development of pneumonia and also can also do some more of spread of the infection in their system. Now, there are common complications, especially if they are unconscious. They probably will have dry mouth. There's probably inflammation of their oral mucosa. Could be some ulcers. And again, the oral care here should be done frequently and making sure that we are using the moisturizing agents, antiseptic solutions, as well as suctioning to prevent the infection and to maintain their oral health. Now, for those patients that may have diabetes mellitus, they are prone to developing the dry mouth due to the altered salivary production. And also, they have that high blood sugar levels, which can foster the periodontal disease and also fungal infections like oral candidiasis. And also some conditions like gum disease. And also we need to make sure that they're receiving the appropriate toothbrushing with fluoride toothpaste, flossing, and with the use of the antimicrobial mouthwash, and to monitor them for any signs of infection, sores, or could be ulcers to prevent their complications. Now, especially for these patients that may have the immunosuppression, let's say with an immune system that is weakened because they're taking some antiviral or retroviral medications, chemo, or if they are taking drugs to prevent rejection of their transplant, they are very susceptible to developing the infections like stomatitis, herpes simplex, and also candidiasis. Now, there are common complications that you need to know about, like painful ulcers, maybe increasing risk of bleeding, systemic infections originating from the oral cavity. Now, around this time, we need to make sure that we are going to use those non-alcohol based mouthwashes and offer gentle cleaning to avoid trauma and also to apply the antifungal, antiviral medications for infection prevention and to maintain their hydration. Now, this time we will be talking about the hair care. This is another part of our patient care. We need to make sure that we ask the patient about their preferences regarding hair care products and also the technique. And aside from that, we need to carry out the assessment of their hair and the scalp to check if there is any alopecia, if there's any head lice or pediculosis capitis, or maybe lesions in their scalp. And also to perform the brushing, which is going to help distribute the oils and keep the hair clean. And while braiding prevents the tangles. And also with the shampooing and with the use of caps No rinse shampoos can be used for patients who are unable to shower, and dry caps can provide effective and way of cleaning without the need for water. And also, washing the hair can be used, especially um, if they can, if there's some availability of those products based on their scalp condition. So make sure that you're avoiding the use of the harsh chemicals that can irritate their sensitive skin or scalp. Now, this time we're going to talk about the ears, eyes, and nose care. And this time we really, especially to the sensory impairments. Um, and for instance, for those people that may have some hearing loss or visual loss, they might require assistance, especially in cleaning their assistive devices. Let's say eyeglasses, could be contact lenses or hearing aids. And if they have any decreased sensation in their nose or ears, they may not be able to notice discomfort or irritation from the medical devices or improper hygienic practices. Now, here, guys, we're going to have to talk about the assessment of their function. So, what are these? So, during the hygiene care, we should be assessing our patient for the function of their eyes, the ears, and the nose, and make sure that we are evaluating whether the patient can see clearly, if they can hear properly, and if they can breathe without obstruction. And for those patients that may be using the oxygen tubing, or let's say nasogastric tubes, or let's say uh, if we are worried about any incontinence, we need to assess their skin under around these devices as well to detect any signs of irritation and pressure source. Okay. Now, we also need to assess for the eyes, and this is something that we need to do in our care. We have to use the soft water moistened washcloth, and we're going to start cleaning from the inner canthus to the outward, so to prevent debris from entering the tear ducts, and also to prevent the irritation and also infection. Now, this is something that we need to be reminded about, because this will ensure that the foreign bodies or the discharges are removed efficiently while avoiding contamination of the tear ducts. Now, what would be the proper cleaning technique here when we are providing the eye care? We want to make sure that we are cleaning both their eyes, and we should be using that different part of the washcloth for each eye to prevent cross contamination, especially in case where the eye might be infected or if it's irritated. And we also need to assess their blink reflex. And this is essential, especially to protect their eyes from the debris and dryness. So, for those patients who are unconscious, or maybe they have impaired blink reflexes, they have that increased risk of corneal injury due to the drying out of their eyes. And in such cases, we need to lubricate their eyes with eye drops or artificial tears to prevent the further damage. Now, aside from that, we can also provide them with eye patch to keep the eyes close and moist. Now, this time, let's talk about ear care. Now, with the ear care, we need to assess if there's any earwax buildup, which can impair their hearing and it can cause some discomfort. And also, we need to assess for any signs of impaction. Okay. All right. We need to do that and make sure that we are also going to investigate if they might need irrigation to remove the blockage. Now, this is something that you need to be careful about, because this might damage their eardrum. And if the patient will report that there is ear discomfort, or let's say a decline in their hearing, the ear irrigation might be indicated as well. Now, part of the education here is to make sure that we tell them not to use the common cotton swabs or the Q-tips, or the insertion of any objects into the ear canal, because this can push the cerumen deeper into their ear, or it can cause the damage to the ear canal or eardrum. But instead, what you can do here is to teach the patient proper ear care technique. It could be wiping the outer ear with a damp cloth or allowing the cerumen to exit naturally. Now, there's also a need for us to assist with their assistive devices like uh, the eyeglasses, the hearing aids, and also um, other devices. We want to make sure that these um, eyeglasses are cleaned properly with a soft cloth or material, and they should be stored in a soft, safe place when not in use, and make sure that we are also careful in handling contact lenses and making sure that they're cleaned and stored properly according to the manufacturer's instruction. And also with the hearing aids, that we are wiping them clean regularly. We need to teach them how to change the batteries and also adjust the volume as needed. Now, aside from that, we are going to be talking about the second here. My screen is freezing up. Now, we also need to do the mobility assessment, which is going to be a very huge factor in our care, considering that they might have any other disorders that may impair their ability to move. And so here we need to begin the assessment with the client lying in bed in a supported position. And then what we're going to do next is to assess their ability to sit and also their ability to transfer and walk, maybe with or without those assistive devices, such as the walkers, or it could be the crutches or canes. And these might be required to maintain their mobility and also to facilitate exercise and promote independence. Now, this time, we will be talking about the complications of the immobility. So there are some changes, such as the metabolic effects. So this can also impair endocrine function. It could possibly lead to electrolyte and fluid imbalances. And we know that the endocrine system adjusts these things, such as adjustment of the blood pressure, electrolyte balance during immobility. However, though, if the patient has a decrease in the metabolic rate, this can possibly lead to fluid imbalance, except during fever, which can increase the metabolism. Now, another effect here will be the um, protein breakdown, wherein the patient might have reduced muscle mass due to this breakdown. And this can lead to the negative nitrogen balance. It can also lead to weight loss and weakness. And aside from that, we will be worried about the possible weakness. They're going to be at risk to developing falls as well. They're not going to be able to really use their muscles or be able to participate those daily activities. Now, another issue that you might encounter here with prolonged immobility is the bone resorption. This is going to cause the bone structure to allow those calcium deposits to leak into the bloodstream. And this can cause complications such as osteoporosis. It can also lead to um, some kidney stones. And in other patients, you might find these patients might end up with fractures, and possibly with the prolonged immobility, they might end up with the fecal impaction, which can complicate into intestinal obstruction. Now, let's move forward into another complication which can alter the respiratory function. And one of these is the respiratory effects, especially atelectasis, or what we call as the alveolar collapse, or it could be the hypostatic pneumonia, wherein there is inflammation from the pooling of secretions during prolonged immobility. And they will have the weak cough reflexes. And this can result into retained mucus secretions. And again, this can increase the risk of developing the pneumonia. Now, this time, we will be talking about the hypostatic pneumonia, which is another complication. Again, the pooling of secretions, especially if they're not able to reposition themselves in bed, they're probably not participating with the out of bed activities. Now, to move forward here, we'll talk about the cardiovascular effects. And with that, this can lead to the development of the orthostatic hypotension. And this can lead to increasing cardiac workload and also the development of the blood clots. Now, when the patient changes or when the patient changes their position, they might feel the dizziness, they might get lightheaded, or they will probably end up with nausea and may experience the pallor or fast heart rate and fainting. Now, another aspect in the cardiovascular effect for the immobility is also the increasing cardiac workload and also the development of thrombose or known as the DVT. Okay, please take note about those common complications. Now, this time, we will be talking about the musculoskeletal effects. So we know that the immobility can lead to the protein loss. It can also reduce the lean muscle mass and also increase the weakness. And it will also put them at a higher risk for falls, and especially that there can be some bone resorption occurring, which will result in disused osteoporosis. They're also going to be prone to developing those contractures in the joints, could be foot drop, which can become permanent and will be debilitating for them. And another thing is that they probably will end up with the urinary effects, which will actually, the body will be hindered from having that normal urine flow into the bladder. And this can lead to urinary stasis, which will predispose them to developing the urinary tract infections and also the development of kidney stones. Now, also the dehydration and the concentration of the urine can further increase their risk of infection and kidney stone formation. Okay, let's move on into the um, other topics here. Let me just close some windows. Now, let's talk about the integumentary system. All right, so there are some integumentary effects wherein it can lead to the development of the pressure source or breakdown of the skin, especially for the bony prominences. They can easily develop the skin breakdown, especially in the trochanteric area, could be the coccyx area, and this can also lead to the development of the open source, right? Now, another aspect that we need to keep in mind are the psychological effects of our patient, because the immobility can also alter their coping mechanisms. It can alter their cognitive and also sensory functions, their emotional well being, and also depression. This can arise from the altered daily routine, and they're going to end up with that social withdrawal as well. Now, this time, we will be talking about the walking of our patient with the use of the crutch. Now, this is very important for us to know and review, especially that we have to measure the device accurately to prevent the brachial plexus injury. And the correct measurement here should be, take a sec, why this is not clicking. The accurate measurement should be at least 2 to 3 finger widths of space between the crutches and also the axilla, and making sure that the patient's elbow should be flexed at about 20 to 30 degrees angle when using the crutches. Now, when you are assisting the patient, make sure that you are standing on the client's affected side. And also, you're going to need to advise your patient to avoid resting their armpits on their crutches, and make sure that our patient will be looking forward and place the crutches at least 6 to 10 inches in front when they are walking. And we are also going to instruct the client to stop if they feel numbness or, let's say, tingling sensation into their hands and also their arms. Now let's proceed with the making sure that our patient will follow the instruction, making sure that they properly place their crutches right in front of them. Again, the crutches should be at least 6 to 10 inches in front when they're walking. And if they feel any numbness or pain or tingling sensation in their arms or the hands, they should stop, because possibly there is an injury going on with a brachial plexus. Now let's take a look into the different gaits that will be used for a patient. So first we have the 2-point gait. This is something that will be beneficial for those patients who can bear weight on both legs, and if they had mastered the 4-point gait. Now, how does this thing works? The crutch on the affected side will be the patient will have to place the crutch on the affected side, and also making sure that the opposite foot will move together. Again, the crutch on the affected side together with the opposite foot will move together. Now, the tip to remember here in recalling the 2-point gait, make sure that you recall that two things move at the same time. So that's the crutch of the affected side and the opposite of the unaffected side, the opposite foot, I should say. So here is the sequence of the step in this patient using the 2-point gait. Again, the crutch on the affected side will move together with the opposite foot. They're going to move at the same time. Crutch on the affected side and the opposite foot. I can't emphasize that enough. Let's have our next crutch gait, which is the 3-point gait. So what is this? This is something that will be beneficial for those patients who can only bear weight at one leg. And how does this thing work? The crutches will be placed forward, then the strong leg will follow. So your tip here to remember is to 3 points, both the crutches and one leg will hit the ground at the same time. So this is the sequence of the 3-point gait. Sorry, let me go back to that. All right, let's move on to our next gait for the crutch walking. We'll talk about the 3-point gait. This is intended for those patients who can bear weight on both legs, but they're going to need more stability, or if they have mastered the 4. So this is basically the patient that will need more stability here. And so the sequence here, or how does this thing works? So what we're going to teach the patient here is to move one crutch, then the opposite foot followed by the other crutch, then the opposite foot will move. Now, what is the sequence here? So there will be 4 movements where you got the crutch, the foot, the crutch, the foot, all separate and also steady. Now let's talk about the swing through gait. This is going to be used for those patients that may have good arm and leg strength, for those patients that may have paraplegia. And this is going to work by moving both crutches forward and then allowing the patient to swing through their body. And this is the gait sequence. Now this time we will be talking about the use of the crutches and assisting the patient to sit or stand from the chair. Now, what we're going to do here first is to position the client. This is very important. We are going to guide the client to stand directly in front of the chair with their back of their legs slightly touching the edge of the chair. And then we will instruct the patient to hold the crutches on one side and have the client hold in one hand, usually the side of their unaffected leg or stronger leg. So they should be able to grab both crutches by the hand grips for stability. Now, what will happen next here is to have them reach for the chair. That is the next step. And we're going to instruct the patient to use the other hand, the one hand that's not holding the crutches, and this hand will be able to reach back for the armrest or seat of the chair. So look into this section right here. Okay, I'm trying to get my laser pointer. Now this time we will be letting the patient lower themselves slowly into the chair by letting them sit by bending the stronger leg first. And this will be followed by making sure that they are stable enough. So once they are seated, make sure that they will place their crutches nearby within their reach and for when they are gonna need to stand again. Now, this time we will be talking about the use of the crutches when they are walking, or let's say when they are actually standing from the chair. Now, the procedure here will basically be the exact opposite. So first thing is to make them positioned, have them move to the edge of the chair, keeping that stronger leg in front. And then we're going to need them to hold and have them place both crutches on the side of the weaker leg. And we want to make sure that they're holding the hand grips with one hand. And also the next step here is the leverage. We're going to make sure that they're using the other hand to push off the armrest for support. Okay, so look at the picture right here. And then finally, with the use of the crutch, we're going to make sure that once they're balanced, they will bring the crutches into position under both arms. Okay. Now this time, we will be talking about the use of crutches while the patient will be walking up and down the stairs. So first things first, we're going to start with assisting the patient to walk up the stairs. So remember, this mnemonic, good goes up. So here, we're going to assist the patient to step up with the strong leg first, or the unaffected leg. And then they're going to need to bring the crutches up next. And then this will be followed by the weaker leg. So remember, when they are walking upstairs using the crutches, make sure that they are stepping first with the stronger or the unaffected leg. Now, the sequence will ensure that the stronger leg will lead and also will provide stability while moving up the stairs. Now, when they are going to be going down the stairs, the mnemonic will be bad goes down, good follows. So what we're going to instruct the patient here is to let them move the crutches down first, and then followed by the weaker leg, and then followed by the stronger leg. Okay. Now, let's talk about the use of the cane. So these are common strategies to help recall the key points for using the canes. Make sure that is properly done. Remember, cane opposite affected leg, or this is what we call as the COAL, C-O-A-L. So the cane should always be held on the opposite side of the weaker leg. So this is how the position is going to happen. Now, this is going to be followed by the handle level. So this is going to be the greater trochanter as the key reference point, and this is where the cane's handle should align. Now, talking about the elbow flexion, think about the use of the 15 to 30 degrees as your mental reminder of the degree of angle, and also the elbow flexion that is needed for comfort and also their balance. Now, another thing that you need to be reminded about is the movement of the sequence. So, cane and weaker leg together, it will uh, help you remember that the cane and the affected leg move together for support. Cane and weaker leg together. Now, also part of the use of the cane will be to make sure that you are doing the routine checks of the rubber tips, and also making sure that these rubber tips are checked for wear and tear in order to maintain safety for our patient. Now, this time we will be talking about the use of hemicane and quadrupod canes. So, for example, the use of this is going to be memorizing or recalling hemi-quad equals one arm. So the hemi canes are actually designed for clients who can only use one upper extremity, and this will offer more security by having the hemi first, quad next. So the hemi canes can actually provide more stability than the quadrupod canes, and but we know that both can uh, be used safely than a single tipped cane. Okay, so look at the footing here. There are 4 points where you can help the patient stabilize their stance and also walking. Now, please don't forget about the positioning of the hemicane or the canes. So you wanted to memorize this: cane opposite, straight beside, in order for you to recall that the straight side of the cane should be placed next to the body on the unaffected side. Now, please take note that there is also that requirement 6 inches a distance or a rule wherein the cane should be positioned 6 inches, or let's say 15 centimeters from the body, with the hand grip at the hip level or the greater trochanter. Now, this time we're going to talk about walkers. And this is something that you need to also refamiliarize. Make sure that you're standing on the client's affected side and ensure that all the 4 points of the walker are flat before they're going to apply their weight on it. Make sure that they have the feet of the walker planted into the ground. And make sure that they are using the walker to move the walker first, and then followed by the affected leg, and then followed by the unaffected leg. So that would be the sequence. All right. So what we're going to need to do next here is to talk about the skin integrity. And this is a very huge aspect in our patient care, as we know that there's a lot of complications that can arise, especially for those patients that may be immobile. And we know that the skin is the largest organ in the body, and this is something that can provide a protective barrier against the disease. It can also help synthesize the vitamin D and enable perception for pain, temperature, and touch. And so your role here as nurses will be to carefully assess for the patient's skin integrity. We need to identify any potential issues or active issues, and we need to initiate those nursing actions as needed. Now, part of the care here is to perform or do the Braden scale assessment in order to identify those risks for so that we can detect if there's any increased risk for developing the pressure sores, especially during the admission or when the patient comes in from the nursing home or the patient may be debilitated at home. Now, this time we also need to notify the medical provider if the Braden scale is so significant that they probably have pre-existing wounds that will need treatment. Now, this time we will talk about so many factors that might affect the patient's skin integrity. So it is very important that our patient will have the adequate nutrition. This is very crucial in maintaining their skin integrity and also promoting their wound healing. We want to make sure that they have the adequate protein, vitamins, and trace minerals, and also they have the adequate calories needed to support their cellular function and also to allow their wounds to heal. And part of the nutrition assessment here is to assess for the serum albumin levels to evaluate any nutritional deficiencies. Now, part of the factors here will be the tissue perfusion. Let's talk about this one. Now, we know that oxygen is very important for wound healing. And so if the patient may have diabetes or poor circulation, they have a higher risk for the alteration of skin integrity, and also there's going to be delayed wound healing. Another thing is the infection. This is going to cause prolongation of the inflammatory phase of healing, which can delay the recovery. So most of these signs of infection include the redness. It could be the pain, the fever. If there's any changes in the amount of drainage, could be purulent discharge, or could be presence of odor. And the same thing with age of the patient. The older adults may have a delayed inflammatory response, and they will have slower wound healing as well. Now, please take note that when they're using some medical devices, this can also lead to pressure injuries, especially if they're wearing those traction, or it could be with the use of some boots. If we are not checking those ears properly, this can potentially lead to the pressure source. Now, another factor here will be the immobility. And because we know that the lack of movement can increase their risk of pressure injuries as well. And the same thing with the incontinence. So this can predispose them to developing the skin breakdown, and also because of the excessive moisture and the irritation of their skin from the excrement, or it could be the presence of the urine. Now we will be talking about the classification of the wound, and we will be comparing them as acute or chronic. And as we know that the acute type of wound, these are the type of wounds that can occur suddenly, and this can typically heal within a predictable time frame. And examples of these acute wounds are the surgical incisions, could be the laceration, or it could be the abrasions. Now, if we're talking about the chronic wounds, these are wounds that do not follow the normal stages of healing, and they will often persist longer. Okay, take note about the term chronic. Okay, they will persist longer, and because this is caused by the underlying factors, maybe poor blood supply, it could be infection, it could be diabetes, and we also need to take note about the wound healing phases, which are the inflammatory phase, which basically can happen immediately after the injury. Let's say the last 3 to 5 days. Now, in the inflammatory phase, the primary characteristics of this phase are the swelling. There could be pain, there could be redness, or let's say warmth. And this can result from the increased blood flow and also immune response to protect the wound from the infection and begin the repair process. Now, the next phase of wound healing is what we call as the fibroblastic phase. And this is going to last around 4 days after the injury, and it can last to 2 to 4 weeks. Now, in the fibroblastic phase, there's going to be development of the scar tissue and also the granulation of the tissue, which will start to form as the body lays down collagen to provide structural strength and also the wound. And there's going to be new blood vessels forming during this time as part of the granulation process. Now, another part here is the maturation phase, which will start approximately 3 weeks after the injury of the skin. And this phase can last up to 1 year. Now, during this maturation phase, the scar tissue will gradually thin and this will become firmer. And this will become firm as a collagen and this will be reorganized. And also, there's going to be wound contraction to happen here and making a healed area more resistant to further injury. Now, if we're going to have to classify the wound according to the intention or types of healing, these are your primary intention, secondary intention, and tertiary intention. So let's refamiliarize ourselves into the primary or first intention. So what is this? The healing of the wound basically happens when the wound edges are brought together, especially when it's sutured or if there's placement of the staples or it could be adhesive strips. And this will allow the minimal scarring. Now, this can typically happen for those patients that may have the surgical wounds as well, or let's say if they have clean cuts. Now, this time, we will be talking about the secondary intention, which is basically the patient's wound is left to heal from the bottom up with the granulation tissue. And this process is longer and it can result in more scar tissue. And this is something that you can see in patients with wounds, large tissue loss or infection. Now, lastly, we're going to talk about the tertiary intention, which is basically going to happen when the wounds are open temporarily. And this can often, if the wounds are healed by tertiary intention, rather, they will often reduce the risk of infection or allow more thorough cleaning before they are finally closed. Now, let's talk about the wound drainage types. So what are these things? There's the variety of, let's say, the serous. There's also that serous sanguineous. So let's talk first about the serous wound drainage. So this is the type of the wound drainage that is characterized as clear, straw-colored, and it also is watery. It is indicating that there is normal fluid output from the inflammatory phase of healing, and usually it will not indicate the infection. Now, for the serous sanguineous type of drainage, the drainage here is thought to be pale pink, and it will be watery, and it represents a mixture of serous fluid and also the blood, and it can indicate normal. This is a very common occurrence as well. This is going to happen in the early stages of a fresh wound or after a procedure, and this should be monitored for signs of any excessive bleeding. Now, this time we will be talking about the last one, which is the purulent type of drainage. So what is this? We will be noticing that this is going to be yellowish or it could be green in color, which indicates infection. And this can contain those white blood cells, right? That's why it's purulent. It can have the dead bacteria. It could have the tissue debris, and this could signal the need for further intervention or treatment to manage their infection. Hi, everyone. This is the continuation of our discussion about the hygiene, mobility, and skin integrity. So let's proceed with our next topic about pressure injury. Now, this is defined as the damage to skin and underlying tissue, and this is caused by prolonged compression. And the locations of these pressure injuries can happen anywhere in the body, especially over bony prominences. And the cause here, it's because of the prolonged pressure, which will restrict the blood flow, which can lead to the ischemia, the inflammation, and also the tissue death. Now, there are known risk factors that you need to refamiliarize about the pressure injury. So one of those will be the skin pressure, which is the direct pressure on the skin occurring when an individual remains in one position for an extended period, which can lead to the restriction of the blood flow. The second one is what we call as the shearing and friction, which occurs when the layers of the skin will slide against each other, often when a patient is moved or, let's say, when she is repositioned, while the friction is the resistance encountered when the skin rubs against surfaces. Now, the third risk factor here is the immobility, which can stem from medical conditions, could be from surgery, it could be pain, or this can lead to prolonged pressure on the specific body parts. Now, the fourth risk factor here is malnutrition, because the poor nutrition can also lead to weakened skin integrity. It can also delay wound healing, and it can increase susceptibility to the pressure injuries. Now, the next one is the incontinence. This can lead to the prolonged exposure to the moisture, which can break down the skin integrity, and it also will contribute to the pressure injury formation. And lastly, we have the risk factors for the pressure injury, which is the decreased sensory perception, wherein the person will have reduced awareness of the pressure or reduced awareness about the discomfort, which will limit the patient's ability to respond to the pain or discomfort. And this can lead to the prolonged pressure in the certain body areas. Now, this time, let's talk about the interventions for the pressure injuries. We have the following here. It starts with the prevention, wherein we're going to have to identify those individuals or patients at risk and to make sure that we are doing all the measures, such as repositioning. We will be using those pressure relief devices, maybe an air mattress, and we need to maintain proper nutrition of our patient. Another is skincare. We gotta do the skin, making sure that we're gonna keep it dry after they're incontinent, and make sure that we're applying the skin barrier, and also to protect for the incontinent clients. Now we also have the repositioning, when we can do the every 2 hour turning for the patients who are immobile at least every 2 hours, and also to perform the range of motion exercises. Now, following that, we need to assess and also document those measures and make sure that we have charted the size and the condition of any existing wounds, and also monitor for signs of infection and complications. Now, there's also the need for the treatment options. This might include the dressings, the debridement, and also the advanced therapies such as a vacuum assisted wound closure device, or could employ the use of the hyperbaric oxygen therapy and also skin grafting. Now, this time we're going to have to talk about the different stages of pressure injuries. We already know that some of these, especially stage one, wherein the skin is intact and does not blanch with pressure. That is the characteristic. And when you're looking into that photo right here, wherein there is that reddened area. So when you're going to apply some pressure or palpate the area where it's reddened, it doesn't turn white. It will not have that blanching reflex. Now, for the stage two, we call that as the partial thickness skin loss with exposure of the dermis. And this is what it looks like. There's no a excavation of the dermis right there. And we have the stage three, which is basically the full thickness skin loss, wherein you're going to see the visible fat tissue. There's also granulation tissue and maybe presence of slough. It's going to look like this. Now, for stage four, this is what we call as the full thickness tissue with the exposure of the muscle. Could be the exposure of the bone or the tendon as well. And there's going to be presence of slough and eschar. And this is going to show these deeper layers, including the bone. Now we have the unstageable, which is what we call as full thickness loss. And this is obscured by slough or eschar. And then this is going to look like this, that eschar formation. and slough covering the injury below that. And then we also have the suspected deep tissue injury, which is basically the persistent and non-blanchable deep red or purple discoloration. And this is something that you can see in the specific areas like the heels, wherein there is that purple discoloration and you cannot really see through anything under it. Now, I really want you to use the mnemonic here to remember the different stages. So for stage 1, I put there red. In stage 2, penguins. Stage 3, fear. That represents for the full thickness. Stage 4, that's the bone. And then unstageable underneath. And lastly, suspected deep tissue injury, which is skin deep. So the mnemonic here is red penguins, fear, bone underneath, skin deep. Now this time, we need to identify those common the different stages. Now, take note that here are the following: the type of dressing. We have the transparent dressing and also the hydrocolloid dressing, which will be appropriate for the stage 1. So for the transparent dressing, this is going to provide a moisture retentive environment that will allow for a continuous observation of the wound without removing the dressing. And it will also protect the skin from further injury while promoting for natural healing. Now, the hydrocolloid type of dressing, it is something that can form a gel when it becomes in contact with wound exudate. So it will now create a moist environment that facilitate the healing process. So the reason for the use of the hydrocolloid dressing is that it will protect the area and provides a cushioning to reduce the pressure on the skin. Now for stage 2, pressure ulcer, we're going to have to expect the use of a composite film, which will offer a combination of moisture and gas permeability while providing a barrier to the external contaminants. And it will also help the reepithelialization by maintaining a moist environment. Now, we also have the hydrocolloid dressing that is applicable for stage 2, and it will act similarly to its indication in stage 1. It will also promote healing, environment, and protects the wound. And it has that gel formation, will aid in reducing the pain, and it will also speed up in the healing process. Now we have now the hydrogel. So what is this? This is something that can provide moisture to the wound bed, which will help in the reepithelialization, and it will act in the debridement of the dead tissue to promote a healthier healing environment. Now let's move on to our 3rd degree pressure ulcer, which is the full thickness skin loss with visible fat tissue. So the following dressings that will be applicable here are the hydrocolloid, hydrogel, and also the calcium alginate. And for the hydrocolloid, this is to be used to support the moist environment. It will protect against the contamination and pressure. Now for the hydrogel, this will maintain pressure. It will assist in the granulation. It will help with the otolytic debridement of necrotic tissue. And lastly, we have the calcium alginate, which will absorb the exudate and it will form a gel promoting the granulation and the reepithelialization as well. So this is the dressing that is highly absorptive, and it has that capacity that is very beneficial for the moderate to heavy exudating wounds. Again, think about the calcium alginate. Now for the stage 4, this is the full thickness tissue loss exposing the muscle and the bone or the tendon. Now, we will expect that the following dressings are going to be ordered. We got the hydrogel covered with foam. We also have the calcium alginate here and the gauze. Now, for the hydrogel covered with foam, this is going to provide the moisture and also cushioning to provide the wound or protect the wound rather, and it will help absorb the excess exudate, which will facilitate the granulation and also the reepithelialization of the wound. And we see that the calcium alginate is back. It will work similarly for a wound that is in stage 3. It will absorb the exudate and it will promote healing through the granulation and reepithelialization as well. Now we also have the gauze, which will serve as a primary dressing, which can absorb the exudate while it promotes healing through the granulation, reepithelialization, and scar tissue development. Now for the unstageable, we're going to expect here the use of the adherent film, the gauze with a prescribed solution, and the use of enzymes. So let's talk first about the adherent film. So this will become a barrier to moisture while allowing for the visualization of the wound, and it can also help to keep the area hydrated, which is essential for debridement. Now, the gauze with a prescribed solution, this will provide a moist environment for the wound healing, and it can help remove the slough or the eschar when combined with a moistening solution. Now, lastly, we got the enzymes here, which will assist in the breakdown of the necrotic tissue. It will loosen the eschar at the edges of the wound, and it will promote healing. It can potentially, for those wound, which will potentially require this surgical debridement. Now, lastly, we have the suspected deep tissue injury, which is that persistent, non-blanchable deep red or purple discoloration. This is going to be matched with the calcium alginate, which will help absorb the exudate while providing a moist environment. And the healing process here will also depend on the treatment methods applied and the extent of the injury. Now, that ends our lecture regarding this chapter. And I hope that you were able to gain some more insights regarding our topic. And I hope to see you soon in our next presentation. You have a great one.